a continuing growing virtual textbook for patients and physicians on these topics. We've become accustomed to online meetings as COVID-19 has reached pandemic proportions in our world, and this has come to the Toronto Cardiac Tumor Conference. Although the meeting is online, there's time for questions, and we encourage questions to be sent to us so that we can ask the speakers. It is webcast again this year on YouTube and Facebook, with subsequent uploading of all the lectures onto the Toronto Cardiac Tumor website. There's a lot to be thankful for. We've enjoyed endorsements for so many years from Ontario Health, the Society of Thoracic Surgeons, and the Peter Munk Cardiac Centre. I have to thank again the speakers and the attendees for making the meeting what it is. Elena Morozova has helped us in the past few years with the flyer. Anybody who's put together a meeting knows that although we have the ideas, it is somebody behind the scenes who makes the meeting possible. Danu Sabason is my personal, professional, and conference assistant, and many, many thanks go to her. Of course, Henry and Barbara Bank are the real reasons behind the meeting. Through their generosity, we've been able to have this meeting over the past 6 years, and hopefully we'll continue to have it over the next many years. Now, the problem with cardiac tumors is that they are very rare. They're so rare that physicians may never have seen a cardiac tumor, and they don't know where to go to when they have a patient. Because it affects the heart, they usually send it to a surgeon, but the surgeon may never have seen a problem either. So if the physicians don't know what to do, and the surgeons don't know where to go, where's the patient to turn when diagnosed? That's what the Toronto Cardiac Tumor Conference is all about. The vision of the Tumor Conference in general is to improve the care of people with cardiac tumors around the world. The mission is to develop a subspecialty of cardiac tumor care which presently doesn't exist, and to develop a global network of centers of excellence in the diagnosis, treatment, and care of patients with cardiac tumors. Last year, we introduced a cardiac tumor database. This year, there will be an update about that. So the conference has always targeted primary cardiac tumors. Here we see a primary cardiac tumor, one that's likely inoperable at this time. We don't know the tissue diagnosis, and that creates a problem. If this is a malignancy, which is likely so given the fact that there's invasion into the pulmonary artery, chemotherapy will have to be administered. The hope is that this chemotherapy will reduce the size of the tumor so that it will become resectable. The problem is trying to figure out what type of tumor this is. Clearly, different types of cancer require different types of chemotherapy. And in order to find out what chemotherapy to give, we need to find out what this is. When a tumor is within the lumen of the heart, or within the lumen of the blood vessels feeding the heart, we can rely on a transcutaneous, transvenous puncture and biopsy in order to get a piece of the tumor. There are still some problems with small volume tumor diagnosis, and that's going to be addressed in this meeting as well. If you have a person like Patrick Wogala who's going to speak to us today, you also have an option of getting a percutaneous, transcutaneous biopsy of the lesion. This is something that I had never even thought was possible with the tumor primarily involving the heart, but has become possible through the efforts of Patrick Wogala and his team in our radiological department. This year, however, we're also going to concentrate on tumors that invade the heart. Here's a lung cancer that's invading the left atrium, and that is going to be a primary focus of our talks this year, in addition to the ones that I've just spoken about. Tumors can invade primarily into the heart from adjacent structures, or more commonly can invade through the veins and arteries that access and enter the heart. This is a typical tumor. It's a renal cell carcinoma, a very large tumor of the kidney. And as you can see, the tumor has grown into the renal vein and up the inferior vena cava and entered the heart. Interestingly, when the renal cell carcinoma enters the heart, it becomes very smooth-walled. This is regardless of the size of the tumor thrombus, so to speak. We'll hear more about this later, but here's obviously a much larger tumor within the inferior vena cava. However, when it hits the heart, it becomes very smooth-walled. Other tumors, as they enter the atrium, expand to fill the space that they occupy. This is an example of a sarcoma growing through the inferior vena cava and into the right atrium. Obviously, this cannot be pulled back, but the heart has to be entered in order to allow resection. The tumor expansion occurs regardless of which blood vessel enters the heart. This is a sarcoma of the lung, which has entered the left atrium. And you can see that as it entered the atrium, it too is expanded to fill the atrium. So the objectives of this meeting: by the end of the conference, the participant will be able to describe the workup, pre, intra, and postoperative strategies in the treatment of tumors that secondarily affect the heart from other organs. The participant will be able to describe the technique of percutaneous biopsy of cardiac tumors and the challenges involved with chemotherapy when standard agents have been exhausted. In addition, they'll be able to understand and describe the problems of biopsy diagnosis with small volume tissue. The goal of the conference is to explore the current state of knowledge and treatment and strategies for tumors that invade or involve the heart secondarily. The faculty this year is made up of a number of individuals. You can see them listed here. We have a combination this year of staff and trainees, as has been suggested in previous years, helping us with this conference. So without further ado, let's start the conference with the first presentation. And I hope you enjoyed and submit questions so that we can ask our speakers and find out more and learn more along the way. Thanks very much. Well, that's the introduction to the conference. As you could tell, it was taped earlier. That's because of the pandemic and not being able to get people here. I see Dr. Reardon signed on. You're able to ask questions in the meeting. Go to the chat and you can ask questions. We're also streaming live via YouTube and Facebook, but unfortunately you won't be able to ask any questions through that means. So if there are any questions for any of the speakers, please do so. We have a nice snowy morning here in Toronto. It's about -6 degrees Celsius. For those people who don't know what that is, you can look it up, Michael. It's cooler here than it is in warmer parts of the world, but it's a beautiful morning. So if anybody has any questions, please let us know via the chat and we'll get your questions asked to the speakers. If people want to tweet, I'm monitoring the tweet as well. And I know that there are people from all over the world watching, and welcome to everybody around the world. I know that it's different parts of the world or in different times. Some people may be watching this in the evening, in the night, and some people are in the morning and very early in the morning. So thank you to everybody. Now, does anybody have any questions about the first introduction? There's not really much to that. Okay. So I think we'll go to the next speaker. We're all trying to figure out how to do this. It's the first time we've done this in this format. We may have a little bit of a change in the order because Dr. Reardon from Houston, Texas, has to go. And Michael, do you want to start your presentation now? He and I were going to give a combined lecture, but because he's not live. Oh, I see. Okay. No, Dr. Weird's not going to speak for next.
Robert, I'm here on the line.
It's a great pleasure to be here to participate in this important virtual conference, an annual conference. And I'm Mike Farku. I'm an epidemiologist, clinical trialist at the Peter Munk Cardiac Center in Toronto. I want to talk about the INTERACT, which is the International Registry to Assess Cardiac Tumors. Obviously, this is a labor of love of many people and is an evolution, but I wanted to present some of the most important aspects of this. So primary cardiac tumors are rare, about 0.02% of autopsies, and they involve about a third with myxomas, a third with other benign tumors, and about 25% are malignant tumors, is well known to the group. And there are secondary cardiac tumors as well, which are more common and are usually arrived at a disseminated stage and are often overlooked. And we'd like to chronicle the outcomes of cardiac tumors in a way in which we may inform future clinical trials that may be embedded in registries or maybe standalone clinical trials based on the evidence. Over the last 4 decades, there are many published cohorts, but no single institution has the ability to report on large enough numbers in order to really impact and change practice. We need to all come together to bring our experiences on the surgical treatment of tumors and the medical management of tumors in order to better understand prognosis and management. So what are the knowledge gaps? Well, what is the best way to treat specific tumors? What is the best surgical method? What are the centers of excellence? Should we have true centers of excellence that operate, or should it be more widespread and more of a groundswell? Are there different patterns of disease in different parts of the world? Are the genetic differences playing a role in how tumors present in different parts of the world? And again, we need an international consortium. Even a national consortium, even in the United States, would not be large enough to be able to answer the questions that we've listed above. So INTERACT is a multinational, multi-center registry with the aspiration to gather enough data and to create a platform for investigators to interact and conduct clinical trials in order to answer the aforementioned questions. Now, the folks at Methodist have used REDCap to design their registry. It's actually fantastic. It involves the demographics, the patient history, the baseline tumor, the chemotherapy that's used, radiation therapy that's used. They also have operative details, including time from initial recurrence, and the pathology as reported. There's a biorepository, allows us to go back and analyze biosamples. And then, of course, the follow-up of the patients, including for death, recurrence, and time to recurrence. So we really are going to stand on the shoulders of others, and the folks at Methodist have done a wonderful job of putting together their registry. I think we can adopt many aspects of this into INTERACT and use REDCap potentially as our platform. This just shows you how it looks on the screen, how it outlines the demographics, the history, the baseline tumor, the therapies, and the follow-up. It is very user-friendly. So I wanted to introduce this because I think that we have the opportunity to really leverage the experience at Methodist in Houston with regards to the management of tumors. The IRAD model is a model that I think we should adopt. As I mentioned last year, this is the International Registry of Acute Aortic Dissection. Acute aortic dissection is also rare. It's about 2 to 3.5 cases, 2 to 3.5 cases per 100,000 people. IRAD was created to assess the etiologic factors, modes of presentation, clinical features, treatment, and hospital outcomes of patients with acute aortic dissection. It is truly multi-centered and international. You can see the various international centers on the right, the American centers on the left. These are 30 large referral centers in 11 countries, and this was established 25 years ago. The coordinating centers at the University of Michigan Health System, and they currently have data on about 4,000 patients with 79 investigators. And here is the PubMed search of IRAD publications. Last check, it was about 150 results on PubMed, and you can see consistently from 2000 to 2020, consistent productivity. So I think we have an opportunity here to really leverage our strengths, come together with a single international platform, with a steering committee and a planning committee that represents all constituencies, including oncology, cardiology, cardiovascular surgery, epidemiology, and so on. And I look forward to working with everyone and Dr. Cusimano and Dr. Reardon to make sure that we can really hit this out of the park. I think having one large registry will lead to many, many opportunities and ultimately to prospective studies that will inform practice. So I'll stop there and pass it back to Dr. Cusimano. Thank you very much.
All right, thank you very much for that update. COVID has slowed us down a little bit in terms of getting this off the ground as quickly as we wanted to, but believe us, there is still very strong interest in this throughout the world. One of the questions that came in actually is a very interesting question. Someone asked, is rhabdomyosarcoma still on the rise? It is more common compared to myxoma. And that's exactly one of the questions that we have no idea about. We have no idea about it throughout the world. We have no idea about it in general. And that's what a tumor database like this is going to help us to answer. Mike, do you want to say anything, Michael Farku?
No, not really, RJ. I think we're in good shape to go forward. I hope that there's interest. We are really been really curtailed a bit because of COVID. But I do think that we have participation that's global, and our steering committee will go ahead with deciding on the right platform. And I think we're ready to get started. So I think we can answer many of these questions as we go forward, and we should be as inclusive as possible with regards to specialists, including obviously the cardiac surgical community, the medical community, the cardiology community, medical oncology, and the community physicians and health officials of different countries, so that we can really make a big difference. So we're excited, and we hope that that excitement is shared by others.
Yes, and a comment made by Dr. Seidman about pediatrics as well as adults. It'd be nice to have everybody join in, and we can learn very much more information than we know now. You know,
absolutely, and that's obviously implied when we say surgeons and cardiologists. But I think a special reach out to the pediatric group would be wonderful and important.
The treatments that we have for cardiac tumors, it seems to be pretty well mature. Dr. Reardon has been a champion about this in the world. When you look at the data, however, the data is not very big, because even though he has the biggest experience in the world, the total number of cases is low. And our oncology colleagues are treating sarcomas the same way they treat soft tissue sarcomas, and that may be reasonable, it may not be reasonable. And the treatment options that we have for people, and you'll see general treatments in previous years and in this year when we speak about a general approach to things, are based on small numbers when it comes to the heart. So we have a lot of catching up to do in the cardiac world to catch up to the oncological treatments in other sarcomas, other tissues, other types of tumors. So a international database like this is extremely important for our understanding and pushing the whole treatment of cardiac tumors forward. Mike Reardon, you want to add to that?
No, RJ, I just like thank you and Michael, for helping organize this database. I mean, when I first started this about 2.5 decades ago, I'd have patients come to me and they'd tell me, well, my doctor saw me and took an image of my heart and just told me to go home and die. And they literally, nobody knew what to do. And I think we've slowly been building this kind of national, international network of people interested in this, so that we can move this forward. We still have a long way to go, particularly with malignant tumors. But it is nice for people to understand that there are options out there, as long as they come to centers where they have heart tumor teams that can look upon this in a multidisciplinary fashion.
Yeah, that's right. Even if they have a place on the internet, a presence, they can contact us and we can send them to a place that we know about. The problem is trying to find those other places, and that's one of the goals of a cardiac tumor database. It's really very, very important, I think, in moving forward in the future.
RJ, I think that's a really important point that Michael raises and alludes to the fact that as we do this, as we perform this registry, we're going to have patient engagement and patient representatives from societies and patient care groups, patient groups, to be part of our steering committee and help guide us as to how we can address patient-related issues. This is very important as we work with U.S. and I know U.S. and Canadian federal agencies, and that we seek funding as well, that we have patient engagement on our steering committee and on our particular working groups.
I'd also point out, RJ and Michael, that for the young academic physicians on the call, like you point out with our IRAD, this is a potential gold mine of academic presentations, publications. And when I started this 2.5 decades ago, I thought I'd write a paper or two, and it has been very academically productive. And of course, the best way to be academically productive is get big data. And so this will really help us.
Michael, your database, how large is it now? How many patients, and how user-friendly is it? Is it something that you believe we should build upon, or should we create our own infrastructure? You know, I really think your database is comprehensive and yet pragmatic, and a pragmatic approach. Just wondered about your thoughts about the current database that you have.
Well, I have about 450 total cardiac tumors. I just had an abstract accepted to AATS of, I think I'm up to 135 primary cardiac sarcomas, and that's going to be presented at AATS 2021. So we have a fair number. I think our database is easy for us to use. I think the main thing, Michael, we want to avoid is getting multiple databases that don't speak to each other. And I think it's more important that we standardize than which particular database we use. I mean, there's a number of good databases out there, but we want everybody, just like IRAD, putting in the same clinical report forms and data. And if we get that, then we're going to be in good shape. But if we start 3 different databases in 3 different centers, that's going to be problematic.
No question. And I guess the other major question is the ability to transpose and bring your database into bring whatever's existing into the current platform. And I think that's something we have to consider, RJ and Michael, as we go forward. But we're really at that point now to look at bringing our data management people and, have a pitch and see which is the best system. And it may be a hybrid that we create de novo.
Yeah. And as far as, importing data, Michael, that'll be for the younger tech guys, where I can send my grandkids up there and they can help.
Yeah.
There's 2 things I'd like to say. One of them is that you have the largest series in the world of sarcomas, and it's less than 150.
Yeah.
And I estimate that every year, if you take China and India, now that represents 3 billion people. Yeah. I suspect there's between 2,000 and 5,000 primary new sarcomas in the heart every year in a place like that.
Yeah.
Yeah. And even if we get 10% of that, even 10%, that represents a huge number. And that's estimation based on what I see in Toronto and the catchment area of Toronto, my hospital. And those are the patients that actually get to me. And as you say, there are countless people that have an echo somewhere and they're told, I'm sorry, this is in your heart. And just like they used to say in the olden days, an affliction of the heart is a lethal infliction, and they were scared to touch the heart. It's the same thing with cardiac tumors, and that's what we're fighting. So we have no idea the number of places, and we have no idea even if there are places that are busier than yours but aren't publishing. And that's a really important thing.
Well, the other thing I'd point out, RJ and Michael, is that what I think is one of the biggest weaknesses of my database is I've just captured people I've operated on.
Right.
We have a lot more cardiac sarcomas that I see with Ravi and Bob Benjamin over at MD Anderson that we don't operate on for a variety of reasons, because we start them on chemotherapy and they get worse. And I think as we expand this out, we need to make sure we start to try to capture not just surgical patients, but every single patient. We really want a better idea, because if I have operated on them, I've selected a subset of people already.
Yeah, I'm the same way. I operate maybe 1 out of every 10 consults I get, if it's that high. The other thing I'd like to say is that really I would like this to get into the public, and a person who's in some remote place in Africa, I know there are people listening here from Africa, gets onto some sort of web-based thing and identifies themselves to us. And so we have to get to the grassroots levels at something like this. And I suspect you can do it these days way better than you could do it in the past, because everybody has a cell phone in their hand when they may not even have an x-ray in their hospital.
I probably get 4 calls a week with somebody sending me imaging on my cell phone, RJ.
Yeah.
It's very common.
Yeah.
What we need is a central.
That as well. But Michael makes a very good point about capturing all of the patients with tumor as best we can. I think we should try to be population based. And the way we can do that is work with the national societies of cardiology and cardiac surgery and oncology to make sure that we're capturing as many of the patients as possible within a region. You can imagine in a place like China, we're 1 billion people, 1.5 billion people, it's going to be a challenge. But I think working with the national society and having their endorsement so that we don't have competing groups or competing registries, it would be very, very important. And each of our country and regional leads should have representation from the different jurisdictions, including oncology, surgery, cardiology, pediatrics, so on the committee, so that we're bringing everybody in. I think right from the beginning is essential.
We have the SEER database, and Mike Seidman, do you know about that? I'm on their steering committee. I know a little bit about them. This is a group of pathologists around the world that define the tumors around the world and have a database for that. Michael, do you want to comment about
Several things have been written out of the SEER database. We actually I wrote a paper recently with the group out of Boston using the national inpatient sample on sarcomas, which captures about 20% of the admissions in the U.S. SEER is very similar in how it captures patients. And there was just a recent paper, I think, written from the people at UPMC about this. That was a national study of sarcoma. So within the last year, there's been about 3 papers looking at national level sarcoma information. But even the SEER and the national inpatient sample capture probably only 20% of what's out there.
Yeah. I think that's we're not going to get everybody, but what we need to do is get as many as we can.
Well, I think the main thing is that the best time to have started building this database would have been 20 years ago. The next best time is today.
Yeah.
And for those of us at the end of their career like I am, you're not going to be able to harvest it too much. But if we build this and keep it for 5 or 10 years, it is going to be not only great for our patients, but it is going to be a gold mine of academic work for young physicians.
Yeah, for sure. And it's not just in our specialty. It's going to be in oncology, radiology, pathology, everything.
I would say all the complex stuff that you and I do now, RJ, is becoming team-based.
Yeah, absolutely. All right. Does anybody have any more questions? All right. Thank you very much, Michael.
Okay. Are you ready for me to share next, RJ?
Yes.
Okay. See if an old man can figure out how to do this.
Dr. Reardon is going to talk, and what we're going to do, Michael, are you okay if we do it together? You're going to do yours first, and I'll do mine second.
Do you have the slides, or do you want my slides?
No, you can take your slides, and I've got a separate set of slides.
I'm just trying to figure out how to get mine to share.
No, we can see them.
Oh, you can see them?
Yeah.
I can't. So that's
We can see your desktop currently, so you'll just need to open up PowerPoint now with your presentation.
I've got PowerPoint open and running. Maybe I need to put it in slideshow. Now I can see it. Okay. Well, RJ, thank you very much for, again, inviting me to your cardiac tumor conference for Toronto. I'm sorry I'm not up there myself. I always enjoy coming up and visiting you. And I really admire you for continuing to push this forward. So this year, RJ asked me to talk a little bit about the general approach to non-primary tumors of the heart. And of course, they're much more common, but most of them are not something that we're going to deal with from my perspective surgically. Most of them are metastatic disease that are going to require systemic therapy. So I thought I'd just go over a couple of things that I see as a surgeon that I get involved with. Of course, the more common kind of widely metastatic disease is oncologic. So there are some metastatic tumors of the heart that I think are worth operating on, but this requires a very careful discussion with your oncology team and with your cardiology team to make sure you think you can really get this out. So this was actually a 72-year-old man who was 18 years after his primary nephrectomy for renal cell cancer. And he presented with chest pain and this large mass that was felt to be metastatic renal cell, but no tumors, no disease anywhere else. And to make it a little more interesting, he was the father-in-law of one of the cardiologists that was my largest referring cardiologist. So what do you do with a tumor like this, RJ?
Yeah, we need more information about what it looks like, but this is a metastatic lesion to the heart. It looks like quite a big tumor here. We'd have to see whether it's resectable or not. Nowadays, with the chemotherapy for renal cell, I'd ask them whether or not they could give some chemotherapy to shrink it down to make it a little bit more feasible for us to operate. Yeah, so this is isolated to one spot in the heart. I think it's reasonable to take it out if it's resectable.
So whenever we see something like this, my first call is to my oncologist.
Yeah.
Find out what systemic therapy we have. This was 15 years ago, and my oncologist at MD Anderson said, "No, this guy's been pretty much maxed out in the olden days, and we don't think we can really do this." CT scan showed this on the surface of the heart involving one diagonal, and just kind of growing out of the surface of the heart, not really invading all the way through the LV wall. Normal LV, normal function otherwise. So we looked at this, RJ, and decided that, well, I thought this was resectable. We did resect this. We had to sacrifice one diagonal. And he actually did very well with this, went home, and he survived 6 more years when he presented with brain mets, and he died from brain mets. So, there are some metastatic disease that you can operate on, but again, they're few and far between. This was a man sent from MD Anderson that had an isolated mass in his heart that was felt to be melanoma. We spoke at length with the melanoma oncology service at MD Anderson, who sent him to us, saying, "Can't you treat this systemically with immunotherapy?" And they said, "No, we've blasted this guy. This is all we can do for him. He has no other disease. Will you operate on him?" And so we actually, this is a kind of a complex area to get to. So, once we made the decision, RJ, that we were going to go after this because the oncologist felt that if we could get a margin on this, he would do well. How would you approach this?
The isolated melanoma, as long as it's isolated melanoma, is resectable. It all depends, again, whether we feel that the heart, that we can resect the heart. I don't think you have to worry about the loss of ventricular function or loss of ventricular size, because these lesions tend to spread out the mass of the heart. And I think if it's something like this, it's quite reasonable. However, whenever you operate in something like this, you have to be concerned that adjacent structures that are not so adjacent, like the mitral valve, may need to come out as well. So you have to warn the people that they may get a lot more than they're bargaining for. And you as a surgeon have to be comfortable with knowing that when you go in there, you may have to do a lot more than you think you need to do.
Yeah.
But I think it's quite reasonable to ask your oncologist first, as you said. That's what we do as well. But as long as it's a single isolated spot, you don't want to get stuck with taking out one spot and the person coming back 3 months later with something in their brain or something like that.
So we were very comfortable. This was an isolated spot, but now it's down in the left ventricle. RJ, what are our options as surgeons to get down into the left ventricle?
The MRI will tell us how deep it is. I have resected tumors through the aortic valve, but those are really benign tumors. Malignant tumors, I'm worried that doing something like that's going to leave something behind. For those who don't know, we talk about R1, R0, and R2. R2 means you leave gross disease behind. You leave a bit of tumor there that you know is tumor. Those patients will die before their sternotomy heals. They'll recur before their sternotomy heals. Not die, but recur. The R0 is where you think it's all there, and then the pathologists come back and say, oh, your margin was positive. That's not good. Your best option is to get an R0. In other words, get all of the tumor behind. So in this particular case, what we would do is we would go through a ventriculotomy in this particular case. We do have experience in ventricular aneurysm resection. And as a surgeon, you have to try to figure out what you've done in the past and how you can use your information and knowledge and experience and expertise from the past to deal with their problems you have now. So I would do this through a ventriculotomy and resect that tumor and whatever else has to come out. For instance, that may be a papillary muscle there. And hope that I get an R0 response. With a melanoma, it's pretty easy to see. With a sarcoma, it's harder to see. They tend to spread along the endocardium of the heart. And sometimes it takes a while for the pathology to come back, but if we have an opportunity to do that, it's okay. Fortunately, melanomas tend to be single spots, and what you see is what you get. And that's what I would plan to do for this patient.
So there are three ways we go after. We can go through the aortic valve, like you said, and I've done that for benign tumors using axial thoracoscope to guide me. We can do a ventriculotomy. I'm not really keen on making holes in good muscle on the left side. The right side doesn't bother me. Or we can go through the mitral valve. The problem with going through the mitral valve with the heart in situ is that you have to go down and then back up again. So what we did was cut the heart out, put it in a bucket of ice, and flipped it over. And now I'm looking down at the mitral valve, and I could just push it out of the way. You could actually see the margins of this at the base of the papillary muscle. We got good margins. Pathology actually came back negative. And I lost track of this guy, RJ, at 5 years because he left MD Anderson, but at 5 years, he was tumor-free and doing well. So again, these are isolated cases, and you have to decide very carefully. They present interesting surgical challenges, and it's another reason why a global network makes sense so that surgeons that are faced with this can call other surgeons and ask them, what have you done in the past? How does it work? And what might be easier to do? Now, it worked for us because I'm just pretty comfortable cutting the heart out and sewing it back in because I've done it about 58 times now, but it's not something most surgeons have in their repertoire.
And I have sent friends of mine who've called me up, or people who've called me up, especially from the United States, because they get my name, I send them down to you. And it's really important to have a friend that you can call, phone a friend.
Yeah. Well, next time invite me and we'll come up and do it together in Toronto. Do it in the summertime though. So the other thing that we see from time to time is stage 4 lung cancer that grows directly into the heart, but has no disease elsewhere. And so this was a 72-year-old patient who was actually in pretty good health. He had a tumor that was isolated to the lower lobe, but growing into the left atrium, and no tumor anywhere else. We got together with my oncology team and discussed this, and the answer from the oncology team was if I could get margins around this, then a lobectomy and a left atrial resection would be the best thing for him. So, how do you approach this, RJ? You got this tumor, it's growing into the left atrium. You're unlikely to be able to just resect it without doing something to go on bypass, because you're going to have, you're not going to be able to clamp the left atrium. How would you approach getting this guy on bypass and doing this?
These are, of all of the tumors that we do that are more than just a tumor that passes through, these are the easiest to resect unless it's a sarcoma. We would go on bypass for this particular patient. We do it, unlike you do it, we do it all at the same sitting. I'm sure you're going to talk about that. We would do the pulmonary resection before going on bypass, before we heparinize. And after after we have all of the dissection that we can in the lung, then we go on bypass and open up the left atrium and resect the left atrium, preserving or reconstructing the pulmonary veins if we need to that are distant from that. And these are the ones where I do get a resection margin, because if it's positive, and I've been burned with that with a sarcoma in the past, if it's positive, I will go back and resect more of the atrium if I need to. The best option again is to have an R0 resection, and that's the best opportunity to get that is in the first operation. So we would do that and either close it primarily if it's a small amount of myocardium that's affected, or if it's a larger amount of myocardium and you think you're going to remove a lot of the left atrium, to use a besom bovine pericardium. It can be a little bit tricky, especially when you have to do a pneumonectomy, because the bovine pericardium is a non-compliant structure. And you can push up their left atrial pressure quite high if more of your left atrium is bovine pericardium than native left atrium. So my comment, if you're going to be doing this, not just you and I, because we have experience in it, but if you're going to be doing this as a surgeon, as a cardiac surgeon assisting a thoracic surgeon to do this, make sure you leave enough bovine pericardium there to allow a reasonable size of left atrium, especially if you're going to resect a lot of it, because you can run into pulmonary hypertension and problems with that.
I'd say, RJ, I rarely primarily close these because the left atrium is pretty easy to resect. And I take much more than I think I need and just patch it with bovine pericardium, because there's little penalty to pay as long as you leave enough there. Now, RJ had mentioned doing this in 2 steps. Yes, we do that. We call it the Texas 2-step. And we do that when I have to do a really complex cardiac resection, like an auto transplant or a very large resection, and a pneumonectomy. And the reason we do that is that these complex, really, and this is not, I don't consider this complex. This is a pretty easy resection. And in this case, we're only doing a lobectomy. But if we're doing a pneumonectomy in a complex, then I worry about getting in coagulopathy and bleeding into that empty pneumonectomy space, which then requires transfusions, which then that leads to more coagulopathy, which leads to more transfusion, which leads to unilateral pulmonary edema on the other side, which leads to death. And so we now will do, if we're going to do a pneumonectomy and a complex cardiac resection, we'll do the complex cardiac resection, disconnect the tumor from the lung from the heart, and then let them get over the pump run, and then come back the next day or the day after that and do a standard pneumonectomy, having already disconnected everything. And that actually works pretty well. In this case, RJ, what we did was just go on bypass. I take about half the atrium out here and just patch it with bovine pericardium. This was a lower lobe, so the whole lower lobe vein went. The upper lobe vein was still intact, and that's probably where I came closest to any tumor, was going as close to the upper lobe vein as I could get without compromising it. Going into the middle of the left atrium was fairly easy, and this patient did very well. This patient did develop metastatic disease 4 years down the line and died 1.5 years after that. But otherwise, I think it's a pretty reasonable outcome for a stage 4 lung cancer, which are often just looked at and said, okay, this is non-small cell lung cancer, it's in the heart, we're going to treat you systemically, and that's it. My oncologist said, if you can get this out, this will really help our systemic treatment, which he got afterwards.
Now, Dr. DePro is going to speak to us later on about these stage 4 cancers, but I'm going to ask you a question. You take a large amount of left atrium, and again, it's to get an R0. Do you take biopsies of frozen sections at the margins or not?
I do on these, RJ, as opposed to sarcomas, because the amount of pump run that we have is not that long.
Right.
And so sitting there for 20 minutes is really not going to be harmful to the patient. But if you look at, and now what I do is I take as much as I can, and then I'm closing while I'm getting my margins back and hoping they're going to be negative. So far, I've been lucky and they've all been negative, so I can take excess margin. But with sarcomas, you really can't do that. You just, you take what you can take, and that tends to be it, because the pump runs are already too long. So yes, we do get margins acutely on these, like we do with most of our oncology, but I don't just sit there and wait for margins. I'm closing while I'm waiting for the margins, because I usually have a pretty good feel about where it is. Now, if it's really close to one thing, like the pulmonary vein, I'll take a small piece right there and send that over and say, listen, I need this back right away.
Yeah, we do the same thing. And can you talk about how patulous you make your bovine pericardium? Have you run into the problems that I've seen with high PA pressure, high pulmonary pressures related to that?
No, I haven't, but I mean, my goal is to make it the same size as the original atrium. And I think that that's one of the things. So certainly when I started doing auto transplants and taking out the posterior atrium, I initially left too much space between the two pulmonary vein cuffs, thinking there was more left atrium than there was. It really did okay, but it looked funny when I closed it. So I now try to look at how much I've taken out and make my patch match the piece I took out. Most of you could lay it down there and add a couple millimeters around the rim just for sewing. That's how I do it.
And what about heparinization? Not heparinization, the warfarin afterwards.
I don't do that. You know, I'm certainly worried about on the auto transplants that we do, RJ, where I've resected pretty much all the left atrium. You know, it's essentially an AFib left atrium. We have not warfarinized those people, and we've yet to have any strokes. The good news is you don't have a lot of AFib either, because you've pretty much gotten rid of all the pulmonary vein connections. But I don't, you know, that's, you know, that my N is not that high. So you know, if you look at all the sarcomas, the number of auto transplants I've done is like 57 now. That's not a huge number to start figuring out if you need to be on warfarin or not.
So if you resect the whole left atrium and you have a completely replaced left atrium with pericardium, which is what we do when we do an auto transplant for the atrial tumors, you would not put that person on warfarin.
I haven't, RJ, but you know, if you know, some of my oncology friends look at some of these things like sarcomas as being hypercoagulable anyway, and they would like me to put them on just like 2 milligrams of Coumadin a day, just a very low level anticoagulation. I don't really have an objection to that. I just haven't done it routinely, and I certainly don't anticoagulate them to a 2.5 INR.
Okay, I'll change my practice.
Well, I wouldn't change because of me, because this is another reason why we need a database. So
yeah, that's right.
Study these things. Right now, most of us are doing this ad hoc based on what our own personal desires are, and our personal desires are usually based on our last disaster.
Yeah,
at least they are for me.
Yeah.
So this is an interesting patient that came to me. I'll skip ahead and show you this first. This patient came to me and was very short of breath, and had a previous resection of a neuroendocrine tumor, and had this tumor in the heart. So what do you do with a tumor like this? This patient literally couldn't speak a complete sentence to you.
So first I'd call you, but again, that's the reason to have the cardiac tumor database. So, I mean, what we need to do is we need to get a piece of this tissue to see what it is. This is within the heart. And, you know, obviously you're showing us a CT scan for brevity, and I know you're going to get other imaging, including an echo. An echo is very, very important here to see what's actually happening in the atrium. These people, it'd be nice to give them some sort of systemic therapy first, if possible. That means if it's a lymphoma, give them a standard chemotherapy for that, et cetera, et cetera. So the first thing we would do with this particular patient is send them to the cardiologist, who would hopefully be able to get a piece of a tumor via the vein in the leg, and get a small biopsy and send it to our pathologist to see if we can get a pathology. Sometimes the people are so short of breath that you unfortunately have to take into the operating room for treatment, and that's would be hopefully an excisional biopsy, not an incisional biopsy, because the patient has compromise of the cardiovascular system.
So what RJ says about right-sided tumors being biopsied, we try to always, when possible, biopsy a right-sided tumor, particularly if we think it might be a sarcoma versus lymphoma. We've had several times where it's saved people from operations. The issue here was this guy was so sick, he wasn't going to do anything. We presumed it was going to be neuroendocrine because of his previous history. And I asked my first thing I do is go to my oncologist and say, if this is neuroendocrine, what can you do for it? And they said, nothing right now. If we're going to try to treat this guy, you've got to get rid of this tumor. So we actually operated on this guy. We took out his whole right atrium and part of his left atrium. We replaced the right atrium by taking a big piece of bovine pericardium, and I just kind of stapled it up each end, making a cava and an atrium, and just sew it from cava to cava and just patched it. And this guy actually did quite well, RJ, for 3.5 years. And in 3.5 years, he developed more widely metastatic disease and died. But he became completely asymptomatic and went back to a functional life. And then he could receive some systemic therapy. So, you know, we can argue about whether or not 3.5 years of pretty much asymptomatic life is worth it. But if you ask this guy, he would tell you yes.
You know, you bring a very, very important point, because I'm starting to do these at our hospital, and they see these giant resections of cancer and things like that. And they're saying, RJ, how long do these people live? We have people waiting for aortic stenosis and coronary bypass and this and that. And you're bringing a patient in and you're using OR time and ICU resources and the hospital resources and financial resources. It's a little bit different here in Canada than the States, because there's only one wallet. When it dries up, nothing else happens. But you know, we give them 2, 3 years, 4 years, 5 years. Is it really worth it? And last year, when we spoke about sarcomas, not last year, but before, you know, the average lifespan of this particular patient is probably a week or 2 weeks if you don't do anything to them. We have to have a different hat when we talk about people who have cancers that affect the heart, either secondarily or primarily. I think you have to compare them to other people who are in the same boat that don't have any treatment. And I think it's really quite worthwhile in these people. If we're giving them 2 months instead of, rather 4 months instead of 2 months, that may be something different at this point in time when we know more about them, because we have a larger denominator. We may find things that may give them, instead of 4 months, 4 years. And then if we have enough patients, instead of finding 4 years, we'll get 10 years. And so I think it's really important. That's a really, really important point that I'm asked all the time in my center.
Well, just remember when we started heart transplantation, they all died too. And now we do heart transplantation on a fairly routine basis. So here's another interesting case. This was a 28-year-old man who had osteosarcoma of the leg. It was metastatic to his right ventricle. He'd been treated very intensively over at MD Anderson. They had basically run out of what they could do. And the only disease he had was this disease in the right ventricle. This poor guy could not speak. He was so short of wind, he couldn't get out of bed. He couldn't move. And the folks at MD Anderson sent him over and said, what can you do? So what do you think, RJ? What are our options here?
Well, this is treated differently here than there. Obviously, you have, first of all, we would not transplant this patient. We have to be cancer-free for 5 years to do this. There seems to be that it moves around somewhere within the ventricle and is not stuck everywhere. And so the only option that I would have here, I would not do a Fontan type of a circulation in this patient. I would go in and try to see if I could resect it and leave no residual tumor behind. But if this person's close to death, which this probably is because of the large pericardial effusion, the patient has a lot of backwards pressure. It might buy him a short time, and the oncologist would be able to help him if it's all possible, but it's a real problem. So the only thing I can offer him is resection with hope that that we get enough residual myocardium left that gives him some function so that the oncologist can get back to him and give him some treatment.
So RJ, I know you and I have both seen several people with large right ventricular tumors, and sometimes you actually can get in there and palliate them fairly well, and sometimes you can't. And it turns out in this young guy, I'll skip 2 ahead, this is what his heart looked like. This, you can see his right ventricle is completely growing into the wall. So I got in there and I realized there's just no way I was going to be able to take this out. So what I did was I took his heart out and I put in 2 Thoratechs. And this was a long ago. The last time we've replaced hearts, we now use Syncardia hearts as a total heart. But he did really well with these 2 Thoratechs. And he was a little over a month out. And we had him as at-home controller. And we were getting ready to send him home. And the plan was if he could live 1.5 years with no evidence of disease, and of course we could use all the adriamycin we want to now because it's not going to hurt the Thoratech, that we would consider transplanting him. And I remember it was a Friday, and we were going to try to send him home on a Saturday because we thought it'd be easiest to move all this equipment on a Saturday. And I saw him on a Friday morning, and he said, I don't feel so well when I talked to him. And I said, well, what's wrong? He said, I'm going to die. And when patients tell me they're going to die, that's a very worrisome thing. And so I called my device team, because I don't do devices anymore. It's a young man's game. And I said, you guys, there's something wrong with this guy. He says he's going to die. And they went and looked at him and said, well, you worry, Wart. He's just been a little bit over diuresed. We need to give him a little fluid. So they did. And I went back to see him at about 6 p.m. on my way out. And I said, how you doing? Better? And he goes, nope, I'm going to die. So I called my team again, and they said, listen, you're just an old worry wart. The next call I got was 2 a.m. He died. And what had happened was he was on Coumadin for his devices, and he bled into his chest, and we didn't think about tamponade because there was no heart in there, but he tamponaded his grafts. So, I think this is really at this far end of the spectrum of what we can do. But I mean, in institutions like mine, one of the things we're trying to do is figure out where's the edge of the envelope. And this poor fellow was doing absolutely great until he bled into his chest and died. I don't know, RJ, any comments?
Yeah, I agree with you that this is something that places places like yours, who really are at the cutting edge of everything, can explore. Even for places like mine at Toronto General Hospital, we would not go this far. I've the pathology specimen you showed is not surprising to me. That's what my pathology specimen showed, although I cut out the patient's tumor and left with tumor behind that one there, and leave it up to the oncologist to treat it. This is an extreme case. It's unfortunate that he passed away, but again, it's a cutting edge, very, very cutting edge, and congratulations to you for even trying something like this. I'm always amazed when you talk about using a Syncardia on somebody, but I'm always curious to see what the long-term results are for these people.
We do all these under an IRB protocol. We just don't do these ad hoc. And so we've written a protocol about how we would do this, who we would do, and if anybody's interested in doing this kind of stuff, you really do need to sit down and put it on paper, do it through an IRB. You just can't do crazy, wild things. And these are all done under a lot of supervision. I mean, we didn't just come over one day and we say, hey, let's take your heart out and see what we can do.
Yeah. Yeah. The cardiac tumor, the cardiac transplantation for a cardiac tumor has been discussed in the literature, and the outcomes have not been uniformly very good. But unfortunately, as with everything else, the disease is so rare that the treatment is a very, very small number. So you lose one patient out of 4, and all of a sudden you have a 25% mortality. People look at that very adversely.
So this is the kind of consult I get not infrequently. A 62-year-old woman who presented actually in Florida with a worsening cough, so they gave her a Z-Pak, hoping she'd get better. They added some antifungal treatment, never really got better, just got more short of breath and started choking. So she went into her local ER and got seen, and then got imaged with this MR. So what do you think?
I think she's in trouble.
Yeah.
So this is a tumor again. Look at that. So I mean, here the considerations here are where's it coming from? Is it affect the esophagus? The esophagus is an area where I don't think we can do anything about. But this is something where, and if I were to be presented with a patient like this, I'd try to get a piece of tumor and hope that it's something that can be treated by their oncological colleagues, and treat it as much as we can and see whether or not it shrinks down to a point where we can do something. And if we still can't do anything, I would send the patient for radiation.
Yeah. So I actually got a transbronchial biopsy, and it's sarcoma, intimal sarcoma of the lung, growing into the heart.
Yeah.
So I'm sorry, CT biopsy of the most, and so spindle cell sarcoma. So she's put on chemotherapy. The plan was to just keep following her along, and she's still in Florida. She gets a repeat imaging, and this is the repeat imaging. I don't know if this is actually.
That's what you hope for. That's really good.
Yeah. So now it's a lot smaller, and it is confined to her lower lobe and her atrium. So what do you do with this?
Yeah, it's still a big tumor. I'd ask my thoracic colleagues, I'd still look at the esophagus to make sure it's not affecting the esophagus, and that can be done by esophageal ultrasound. They can give us a lot of information.
Yeah.
But I think that's quite reasonable if the patient's had enough chemotherapy that the oncologists are happy that they have given all that they can and it hasn't shrunken anymore and there's nothing else anywhere else. This would be a reasonable one to resect with a colleague.
So
thoracic surgeon.
Yeah, so the esophagus was normal on esophagoscopy, and I put a TVAR graft in where the tumor was, just in case I got into the aorta, because I was planning on operating on this. Went in with my thoracic colleagues. They did a left lower lobe. We went on bypass, removed the atrium. The margins actually were negative on this lady. She recovered without any trouble, went back to Florida. The last I heard from her was 2 years later, she was doing well, and she had developed more metastatic disease and been put back on chemotherapy.
One of the things that I found is that when I've done a resection of the heart, big resection of the heart, they don't usually recur in the heart, they recur elsewhere.
Yeah, I think that's one thing that's actually really true, RJ. We used to have a lot of trouble with people recurring locally because of inadequate resection. So this is a young person, a young woman who's in her 40s, who is very short of wind, and this was a mediastinal paraganglioma. Now, I'm not showing all the imaging. You know, when we cath this lady, RJ, you could see huge feeding vessels like you and I always see. The problem was it was really pretty big. And so the question is what could we do for this lady? Because it's growing out of the mediastinum up into her posterior heart. So this is what we did. You can see it's pretty nasty looking, even for a virgin chest. So we're trying to get enough aorta out so we can cannulate the aorta. So we take it off the arch of the aorta. They took it off the atrium. And now we're on bypass, but we're not clamped. We're just trying to find where are the margins on the right ventricle. And you know, RJ, you've done a lot of these paragangliomas. You know it's really pretty hard to figure out where they are sometimes. We've taken it off the ascending aorta. It came off the ascending aorta very well. Now we're going to cardioplege. We're going to cut the aorta in half and cut the pulmonary artery in half so I can get to the posterior mediastinal part of this. And you know, if you cut the superior vena cava, the aorta and pulmonary artery in half, you can really roll the heart way up and get to all of this stuff. So you can see it's a fairly large tumor. We're taking it right down to good ventricular muscle. And so now we're giving some cardioplegia right down the left main, which I've freed up. We've taken out the aortic root and the pulmonary root. We're going to self-have a graft, bringing it down for the aortic root. And reimplant the left coronary artery. So that's the left coronary button going in. We were able to actually skin this all the way back to the bifurcation of the LAD and the OM and save the left main. Sometimes we have to
resectable, even if you have to do something huge like you did. And if those people in the audience actually see one, to let myself or Dr. Reardon know about it, and we can help you through the whole process. Either Michael's gone, I'm sure, to other parts of the world, and I have as well. It's hard during COVID, obviously, but we're willing to give you as much help as we can for these very, very complicated cases. But these are very salvageable cases and very operable.
And one comment: if you see a mass of the in the posterior mediastinum of the heart that you think is a paraganglioma, do not needle biopsy it. Your patient may bleed to death. Just do a heart cath, squirt the coronaries. If it's a paraganglioma, you will see it because it'll light up with giant feeding vessels. So RJ, I'm going to show one more case, which is actually a patient that I saw in clinic yesterday that was sent to me, who is 52 years old. In 2015 in Dallas, had a posterior left atrial mass taken out they thought was myxoma. It turned out to be sarcoma. And they called me and we treated her with chemotherapy. And now she comes back having trouble swallowing. So the question is what would you do? And this will be my final case because they're going to make me go to the OR soon, RJ. So what do you think?
Wow, I would say wow. I mean, I'm worried about the esophagus there.
So we were too. So she's had esophagoscopy over at MD Anderson, and we see extrinsic compression, but nothing that shows actual invasion of the esophageal wall.
And then the other thing I'd be worried about is whether or not when we resect it, whether there's going to be 4 pulmonary veins that are going to be negative.
Yep.
So in other words, can we achieve a good result with that patient?
So this is the actual decision process that we're going through right now. We will talk about this lady RJ on Tumour conference coming up next week, and you know, for those out there in the audience, this is how we go through this difficult decision-making process. Tom McGilvery, who's my partner, who's going to be taking over cardiac tumors as I retire and has been doing all these with me. He and I look at this and decide, first side, do we think it might be resectable? And second of all, if it's resectable, how do we go at it? So the original diagnosis was intimal sarcoma. Bob Benjamin thinks this is probably not intimal sarcoma because it wouldn't still be here from 2015, number one. And number two, it seems too smooth for most intimal sarcomas. He thinks it's a liposarcoma now, something different, and a well-differentiated liposarcoma. In which case, if it really is, and we're lucky, the well-differentiated liposarcomas actually resect fairly easily. So I'm going to leave that, RJ, as my last case so that people get a flavor of what we get referred to us as we go through this as decision-making teams. I always like to end when I talk about tumors by thanking Dr. Cooley, who I did my cardiac training with. I got interested in tumors when I was a resident with Dr. Cooley, and I was running what was called his valve complex room as a second-year resident. And typically when you worked with Dr. Cooley, you would start the case and you'd send word, Dr. Cooley, do you want me to cannulate? And word would come back, cannulate or not, and it was always cannulate. And then once you had was cannulated, you'd send back word, Dr. Cooley, you want me to do the case, are you coming? And if it was just some routine case, it was usually just go ahead and do the case, or otherwise he'd be coming. We had a young fellow that came to us from Italy, and he had a biopsy of a left atrial mass, and they just stopped. And they sent him to Dr. Cooley. And I sent out word, Dr. Cooley, do you want me to cannulate? And the word came back, no, which is really unusual. So he came in, he cannulated the aorta, the SVC, and low on the IVC. And then he cut the heart out and handed it to the nurse and said, now keep this, I'm going to want it back. And he didn't tell either one of us what we were doing. And we said, well, Dr. Cooley, where's the donor heart coming from? He goes, no, I'm going to put this one back in. And there was a big paraganglioma of the left atrial posterior wall, and he resected that and patched it with pericardium. But in those days, we were doing 40 hearts a day, and we kind of went through this fairly quickly. And unfortunately, this man bled, and his bleeding led to his demise. But it was clear to me that the technical aspect of cutting out the heart, replacing the tumor, if we just did it a little bit better, would work. And that's what launched me back in 1984 on this long-term quest to figure out heart tumor. So thank you, Dr. Cooley. RJ, thank you for having me at your conference. And I apologize. I've unfortunately got a full schedule today. I hope next time I'm in Toronto and then I can't run away.
Yeah, thank you very much, Michael, for your friendship and your mentorship and thinking of this whole thing. You really are the father of cardiac tumors in the world, and I'm happy to call you a friend and a colleague. One of the questions that was raised here is that they biopsy, and Dr. Regala can talk to us a little bit more about this in the future. They biopsy the neuroendocrine tumors in the abdomen, and what makes it different in the heart. Why don't they bleed to death in the retroperitoneum, and why do they bleed to death here? You want to take that one?
Well, I think it's because they all have these giant feeding vessels off the coronaries. And so, we see these things in the belly. We see the paragangliomas up in the neck too, where we embolize them. I don't embolize my cardiac paragangliomas yet. I don't know if that would help or not. I just don't. But the ones that are up around the heart, as you know, RJ, if you take a picture of them, they have huge, huge feeding vessels. And, I guess if you're lucky and you missed all those, they might do okay. But I've had 2 people that were biopsied by needles and almost bled to death and then sent to me in Houston. So that's not a huge N, but it's enough of an N for me to say it's probably not a good idea.
The other thing is that it's in an open pericardium.
Yeah.
So they can get a tamponade, whereas they can bleed into the retroperitoneum and get a hematoma, but hopefully it'll be self-limiting, I think.
Well, both of these were biopsied. They got tamponade, they got operated on, got nothing but the hole sewed up and then sent down to me. It would have been a lot nicer if they were just sent right down.
Yeah. So we say the same thing. Patrick, if I know it's a paraganglionoma, I won't send it to you.
Yeah. You really don't want to do that. And I really apologize. I really would love to hear the percutaneous biopsy. We think that's crucially important. We biopsy all right-sided ones that we can, that don't have we don't have to do something else with. And quite frankly, I would love to biopsy all the left-sided ones, but the concept of a transseptal biopsy is a little more daunting than just doing a right-sided biopsy. So thank you guys. I apologize, RJ.
Thank you very much, Michael.
Save and human misery to leave in Houston, so I got to go.
I want to put a plug out for your cardiac tumor board meeting, Michael. If there are people around the world that want to join it, they can contact me and you or you specifically to contact it. If they can't get a hold of you, contact me. It's a very, very important tumor board that you have, and it really is a world. And so it's very important.
It's a great learning experience for people that are interested or want to start their own program.
Yeah.
Thank you, guys. Bye.
Thank you. We've got a few minutes before Patrick Regala is going to speak to us. I'm going to give a really quick overview of how we do it in Toronto, which, as you see, is pretty well the same as Michael does it there. I learned a lot from Michael Reardon, but I've learned a lot having done this for the past almost 30 years myself and picking up these little tricks. So I'm going to share my screen. Here's right there. I'll try to, can you see that? So I'm going to talk about cardiac considerations when the tumors, I put the U for us and leave it out for Michael Reardon, but he's not here to see that humor. I'm going to talk quickly about this. And the tumors of the heart can be, tumors that invade the heart may be passing through or may invade the structures directly. They may also have microscopic invasion, as you've seen, and that complicates things directly. The extent of the intrinsic cardiac involvement really depends on the tumor type. So in other words, beware of the sarcomas, not to be so scared about the melanomas. So the microscopic portion is the dangerous portion in terms of the having a negative resection margin. And because of the fact that there may be microscopic invasion, you have to be prepared to do reconstruction. So if you're thinking about getting into this field of cardiac tumor resection as a cardiac surgeon, you really have to be very comfortable taking out the heart, rebuilding the heart. And cardiac transplantation is a really good training for this sort of thing. Here's one that's passing through the heart. This happens to be an infradiaphragmatic tumor. This may be a renal cell carcinoma. It may be a tumor coming from the gynecological region. Whatever it is, it's passing through. And you can pretty well imagine that this needs a cardiac surgeon to help. But the chance of this requiring any cardiac resection primarily is very low. This is a classic example, and we're going to see this, I'm sure, when Dr. DePerot speaks to us about cardiac tumors that invade the thoracic tumors that invade the heart. But as Michael Reardon said, this is a fairly easy resection from a cardiac point of view. It requires resection of the atrium. The general principles, however, Dr. Reardon spoke about them and we spoke about them, but just to write them down, you must have a reasonable heart for an operation. You know, the things that we do, when he asked me, what about this patient? I'm assuming that he's answered these questions. He's a cardiac surgeon, but you have to answer these questions as well. You have to have a reasonable heart for an operation. The patient must have a coronary anatomy amenable to bypass or at least survivability. For instance, if the patient has inoperable coronary disease, we would not take this patient to the operating room. If the patient has a coronary anatomy that needs to be resected along with the tumor, and that's why we will get a coronary angiogram on everybody, regardless of the age of the individual. If they have a tumor that comes close to any coronary artery, we need to know that. I'm used to looking at coronary angiograms and not CT angiograms, although I'm getting a little bit better at that, and I would get a coronary angiogram. Valvular disease must be amenable or at least survivable. The patient may have some aortic stenosis, but if they have severe aortic stenosis, severe mitral regurgitation, especially if the ventricular function is poor, we will not operate on that person. Now, these may be motherhood statements, but these are things that we do consider. We must be able to safely support the heart and circulation. We must be able to control the circulation so that the tumor can be resected from whatever part it needs to be resected from. And again, we must be able to reconstruct the heart as required. The last case that Dr. Reardon showed is a perfect example of that, in that if the patient doesn't have 4 pulmonary veins that are negative, it's no use operating on the individual because they won't do well. So a reasonable heart, the coronary anatomy and preparation for coronary bypass is required. We're really looking for left main disease and significant large territory lesions. For instance, if a person has some coronary disease, but it's, you know, a little bit downstream and it's not something that's going to be significantly bad in terms of a left main, the person is going to die in the table, we would leave that alone. And we would get a CT, cardiac CT, or a cardiac catheterization. If the person has significant valvular disease, a significant aortic stenosis or mitral regurgitation, then we would plan to operate on that individual at the same time. If it's too much, if it's a complex repair, as he said, complex replacement, then that may preclude an operation, but we would look for significant valvular lesions at the time of an operation. The right tricuspid regurgitation is very easily fixed, and for this we'll get an echo. You can see that multimodality therapy is the thing that we look at whenever we look at any cardiac tumor. It's not an individual person. Again, poor ventricular function is a major issue, especially less than 20%. But a dilated aorta is not an issue unless it's very large and causes aortic regurgitation. It doesn't matter if the person has a 4.5 centimeter or even a 5 centimeter ascending aorta. If it's not causing any problem, it's not a reason not to operate. We need to be able to support the heart. And really what it really means is if the right atrium is full of tumor, we need to be able to cannulate this patient and get on bypass. And that's what I mean by support the heart. You can use the femoral vein for bypass to start the patient off. A single cannula into the right atrium, and for those cardiac surgeons, a 28 Pacifical or 28 right angle Pacifical can carry 5 liters a minute. You can easily support the heart like that. And if the person has a tumor coming from the infradiaphragmatic portion, you can cannulate the superior vena cava, especially with a 28 French Pacifical, and either abdominal aorta or a venous cannulation. And if the SVC is involved, we can always cannulate the brachiocephalic vein. If the brachiocephalic vein is involved as well, hopefully there's enough collateral so you don't have to worry about draining the head because it's drained through the rest of it. You can get it from the inferior part of the body. This is a typical tumor of a patient who's coming from the infradiaphragmatic surface. You can see you cannot put a cannula into the inferior vena cava here. The superior vena cava can easily be cannulated. So here the inferior vena cava is cannulated via the groin. So we have to be able to support the heart and support the circulation while we do the resection of the portion of the tumor that invades the heart. We must be able to reconstruct the heart, and that's for infiltrative lesions. And some pathology, as I said before, like sarcoma, is more likely that you're going to have to resect the heart because the infiltrative lesions are there. It may be a minor resection or major resection. This would I consider a minor resection. The left atrium is very easy to reconstruct with bovine pericardium, as I've said. This is the tumor that I showed before. And in this particular case, we used a piece of bovine pericardium to resect this, to reconstruct the left atrium so that the size of the left atrium is not too small. The resection can be a little bit more complicated. This was a pulmonary vein resection, in addition to the left atrium and right atrium for a tumor here that affected the patient en passant, affecting the upper lobe. So we had to resect the lower lobe and reconstruct the vein to the upper lobe. So you have to be able to do this, and bovine pericardium is our friend. This particular patient had close to the SA node, and in this particular patient, we put pacemakers on as well. This is a typical tumor coming from the inferior vena cava, and this looks like it's sort of wedged in here. And sure enough, when we take it out, there really is no involvement of the heart itself. So this would be one where we would push it through to the infradiaphragmatic portion and not have any problems. You can see the liver is over here. This is a different kind of a tumor. This happens to be a sarcoma. When we look at it a little bit more closely, we can see that there is some wall involved here, and this will require, in addition to the resection of the tumor itself and the infradiaphragmatic portion of the tumor, it will involve some resection. And in these particular cases, we as Dr. Reardon use a lot of bovine pericardium. Bovine pericardium is our friend, and we use it to reconstruct a lot of the heart and the portions of the great vessels that affected. We also use the Dacron grafts, but for the primary cardiac resection, we use this. In this particular case, we resected the inferior wall of the right atrium, as well as the inferior vena cava to the liver. So bovine pericardium can be used and is used quite a lot in our resection. And you can see in this particular case, we cannulated the SVC and cannulated infradiaphragmatically for the rest. This is a tumor that invades into the heart, and Dr. Reardon spoke about these sorts of things. These are very, very complex tumors, mediastinal tumors that invade into the heart. And the concept, as he said, is try to get a piece of the tumor and treat the tumor and see that whether it shrinks down or not and is resectable. At this point in time, a case like this is not resectable. The intraoperative issues that you can run into, this question is what temperature do we cool to? A lot of these people have large liver resections and a lot of bleeding from the inferior vena cava when the inferior vena cava is opened up as the tumor courses through the vena cava on its way to the heart. So the question is what temperature to cool down to. It depends on how long the circulatory arrest is required for, but it's usually less than 20 minutes. So the amount of cooling is not that great. You can't really go to low flow because even on low flow with the heart-lung machine, there's still a significant amount of bleeding, and it really helps with speeding up the operation if you go to complete circulatory arrest. I will help with the anastomosis because I have a little bit more experience in doing things under the stress of circulatory arrest. But once the important stuff is done, we will go to low flow if we need a little bit extra time. I kept on stressing how to go on bypass when the IVC or the SVC is obstructed. We go to the femoral interabdominal aorta. If the abdomen is open, I like to go to the infra-abdominal aorta, IVC, because of, I said aorta, I meant vena cava. If the abdomen is open, I prefer to go to the abdominal vena cava because it's a large vessel. And don't forget the brachiocephalic vein if you can't get anything from above. These patients do bleed a lot, especially the infradiaphragmatic cases, because they're huge dissections. I use the usual number of chest tubes, not anymore. Then the drains are placed per all the teams. If it's an infradiaphragmatic resection, some of the diaphragm is taken out with it usually, and so there's a movement between the diaphragm, infradiaphragmatic and supradiaphragmatic areas. Where do they go? We in our hospital have a cardiac and a medical surgical intensive care unit. They're different intensive care unit. And we send the patients here at Toronto General to whichever ICU they would normally go to that takes the care of that particular type of patient had they not been using the heart-lung machine. It's really important that the team that normally takes care of these patients take care of them now. Just because they had the heart-lung machine doesn't mean they have to come to our ICU. Our ICU is not as good at taking care of them as their usual ICUs. And we always remember that even though the cardiac tumor, and we're talking about cardiac tumors here, what the other surgeons have to do when the tumor enters the heart is always way more than we ever have to do. This is a primary tumor of the liver that came into the heart. And you can imagine this is a much, much larger job than we have to do within the heart. This is a typical kind of a patient of that. This happens to be the one where I resected and reconstructed the inferior vena cava. but there was a hepatic resection, retroperitoneal dissection, and a reconstruction of inferior vena cava. And that's why these are very, very complicated cases. And they are not a single surgeon, a single group of individuals. There's a whole group of individuals, including the pathologist, radiologist beforehand, the multiple teams taking care of these patients, including the intensive care unit, anesthesia, et cetera. So with that, I've spoken about the general concepts, really to put into place what Dr. Reardon had spoken about. Next, we're going to hear from an individual who I've come to respect very greatly and is part of my team, even though he thinks he is. And I always come in looking, is Patrick here? Is Patrick here? He's an interventional radiologist, and he's an amazing person. I found out about him a few years ago when I said, you know what, I can't really get a biopsy of this. I don't know what to do. I may have to go in there. And they said, because I go over all my cases with the radiologist, we sit down there for hours sometimes talking about different cardiac cases and what imaging we can get to make them better. And I remember once I was talking to them about, you know, I'd love to find out what this is. And they say, why don't you call Patrick? He'll do this for you. So Dr. Regala is an amazing person. He's an interventional radiologist at our hospital, and he's going to talk to you about something I never imagined could be possible. And it really is magic. And I'm really happy to be associated with you, and I'm happy we have you in our system. And I'm hoping that you're going to teach people around the world all about this. So Patrick Regala, I'll let you take it away from here.
Thank you so much. And I hope you might be able to see my screen. Please let me know. As I told you in the chat, they're just starting construction right at the minute before I started here. You might hear some noise, but I told them they will be very kind with me and hopefully stop soon. So if there's a connection issue, please let me know and disrupt me. So checking, you can see my screen. Is that correct, Dr. Cusimano?
Yes.
Excellent, perfect. Thank you so much. So I observed the previous presentation in the case, and I have to tell you, this is amazes me. I don't know if I could deal with those situations, the stress in the OR, and so much is on the line. And it seems sometimes kind of interesting when I talk about the challenges in medical imaging, they seem to be minute compared to what you have to go through. So I will talk about percutaneous biopsy of tumors of the heart. And you know, I have to tell you that, you know, the percutaneous, the endomyocardial biopsy really is a mature technique, and it's always been used for many cases, and it's a phenomenal technique, mature, being developed 30 years ago, and it's in good hands. It is a phenomenal tool. Well, there is a natural limitation, as you can imagine, as far as the penetration goes. If the needle is not long enough or the tumor is not infiltrating the myocardium deep enough, there will be technical limitations with respect to harvesting enough tissue. But I'm not downplaying this technique. This is the standard of reference. This is standard of care. And whenever anything comes up, this is the method to try first. But there will be cases in which the tissue is not sufficient for a diagnosis, and then we may have to look at different options. One of which is certainly ultrasound guidance. And ultrasound, as you probably know, is a real-time method. Real-time meaning really as you do an action, you can see it. The delay from seeing the image or the image being available on a screen to reality is less than 20 milliseconds, which is really regarded as real-time. It has very flexible imaging planes, which greatly helps with the guiding the needle to the target. It's portable, which is critically important because the setup is a lot easier. We don't have to transport sick patients to a certain facility or a certain room. And there's, as you know, no radiation. We talk about this in a second, if that is a real concern or not. And then there are the natural obstacles, which is certainly airborne. And if the patient had undergone prior surgery, there may be some metal implants which obscure the view and make the biopsy a little more difficult. One of the things that you probably know is ultrasound is extremely operator dependent. And that's good and bad. It's good for those who know what to do. It can be bad because ultrasound offers so many opportunities. Any plane can be used. And if you are not really familiar with the limitations and how to hold the probe and guide the needle at the same time, there could be some challenges facing you. There's been a very interesting report recently. It's been published last year. Actually came out this year, but it was online available before. And this case came out of Mayo Clinic, and they reported on a percutaneous biopsy of an HCC, which had a metastasis similar to what RJ just showed, that metastasized or grew into the chest. And they described nicely. how they dealt with it, with all the anticipation of complications, and gave great advice. I looked at the image and said, that is interesting, because we do that here. And I wasn't really aware this is, let me call it, such an exception with respect to choosing CT as a modality. And the central message here was that CT-guided transthoracic biopsy of cardiac masses is a solution to obtain tissue safely in specific scenarios. But they also say that preparation should be made to prepare for post-biopsy complications. And of course, we take this component very seriously. And in the same issue, there was a commentary. And Dr. Sultan said, poking the right ventricle for a diagnosis is okay, but proceed with caution. And he gives a long list of why there are additional risks, which we all agree with. But the point here was of this report is it's doable. It's a technique that may be underutilized in certain circumstances. Now, here's the case I wanted to share with you. It's a 48-year-old man who came to the clinic with shortness of breath due to pericardial effusion, which was drained through an image-guided pericardial window. But the pericardial fluid cytology was negative, despite the fact that we all strongly suspected malignancy in this patient, because what you can see on the left-hand image, which is the CT scan, is 7.5 centimeter right atrial mass. We performed the fine needle aspiration, and the reason is fine needle initially is because it's a very small caliber. You need a coaxial needle, but it's in general a little bit smaller than what you would use for core biopsy. And the on-site cytopathologist confirmed adequacy of the sample, and eventually it turned out to be an angiosarcoma, and there was no complication. So that was encouraging, and we felt, well, maybe we should use this technique a little bit more often in the circumstances when decision-making is critical. But I highlighted with the blue arrow one of the pitfalls here. And you can imagine if the technique is not right, it can be very challenging to see the right coronary artery, the left coronary artery, and even the internal mammary arteries can pose a significant challenge during the biopsy. This is a companion case of a 31-year-old woman who had only one symptom. She fainted, and she was worked up first, and correctly, I think, with a PE scan. And the PE scan showed not only a pericardial effusion, as you can see on the bottom image on the left side, but also a mass that seems to be protruding into the right ventricular outflow tract, or possibly into the pulmonary artery. Also, we performed a delayed phase, and you can see there's central necrosis in this neoplasm, and clearly it grows now on the late phase into the pulmonary artery and the right outflow tract. We performed an MRI, and the beauty of MRI here clearly is the fact that you have cine images, which nicely demonstrate the continuity of the neoplasm as it grows into the pulmonary outflow tract. And you also can see how the cancer inside of the vasculature flips back and forth based on the blood flow. So clearly that is a situation that requires further intervention, but we did not know what etiology that is. We took the approach of a core biopsy, and I highlighted in the right upper corner the internal mammary artery. And as you can see, they can be tricky to see on CT if you don't know where they are. That's why preparation of those cases beforehand is critically important. We took 2 cores, and it turned out to be an undifferentiated spindle cell carcinoma. You see the cores we obtained embedded in formalin in the right lower corner. So those cases show you the feasibility of this technique in certain circumstances. And then I undertook the task to go through the literature. My fellow Marina, she was phenomenal in diving into all possible sources and finding more case reports. Reality is they're only case reports. I couldn't believe that this is the case, considering the fact that we use CT so frequently for harvesting tissue everywhere else, except in the mediastinum and the heart, when the heart is concerned. And we found those case reports, and the most recent is on top. And as you can see, the complication rate seems to be approaching 0. I doubt that's the case, but in the right hands, with the right precautionary measures, it seems to be a reasonable technique. And it's being done across the globe, from the United States, Europe, Asia, everywhere. So, we thought, okay, let's review and let's see what we're doing. Do we have to fine-tune our technique? Is there anything we need to look at? And I want to briefly mention the technology we use, the challenges that we are facing, and they're significant, the risks and complications, most of which have been alluded to. We briefly show what we did at UHN, and then I come up with a summary statement that kind of summarizes what we have gone through. Now, when it comes to CT, most of you might know CT means an X-ray tube and a detector that continuously rotates around the patient. And as the gantry rotates around the patient or revolves around the patient, images are being reconstructed. Now, showing the simulation here, once 180 degrees of data are obtained, we get an image. But the CT continues to rotate, and the second rotation then is being used for improvement of quality, noise reduction, artifact reduction, etc. But because it's a mechanical rotation, you can imagine there is a delay. There's a minimum time amount that needs to go by before we can actually physically reconstruct an image. The second limitation is the detector has a certain width. It's not indefinitely large. And to cover a larger area for diagnostic purposes, but even for interventional purposes, either we do a helical scan, which takes even more time. It can be ECG gated, of course, or we have access to a wide area detector CT, which we do have here. And then we at least need only one rotation to be able to image the heart and freeze the motion. So those techniques are available for quite some time, but does it really help? Because this is a phenomenon that we always see, which is kind of obvious, is the cardiac motion. And I just took the liberty of taking two same location images with the needle in place for a tumor and see what the heart does. Of course it beats. So unless we manage to ECG gate the biopsy, which is hard to do, not impossible, but hard to do, you will see the phenomenon that the target changes. And that's an issue. It's a major issue. We are great with freezing motion, which is essential for motion analysis as well. But how do we introduce real-time capability to our imaging tools? That was the question. So we've developed something that's being called CT fluoroscopy decades ago. And what we thought is reasonable is we need a floating table similar to angiography. You don't want to be limited to the mechanics of a CT unit. We need a lights visor that tells us where the images will be obtained, full scan control inside of the room, which was novel at that time coming to CT, an in-room control monitor, real-time image reconstruction, a challenge at that time. Now it's almost instant. And continuous image reconstruction, the movie mode. You see the movie in the right upper corner, but you also notice that the hand is in the beam. So that's something we will talk about because that should obviously not be the case. Now, training is critically important, those biopsies. And you can see our fellow at that time was kind of focused and concentrated and worried about it. But what we normally do is we have at least two operators in the room. We teach how to do it. Also, the second person is able to observe the patient, make sure that everything is fine, just in case a complication might occur. But training on these techniques on CT fluoroscopy is critically important. You can't do this and just give the needle to someone who has never used the technique before. And as soon as CT fluoroscopy became sort of the standard in biopsy, many reports told actually that the diagnostic accuracy is much higher, mainly in the chest, because in the abdomen there's less motion. But it turned out to be the method to go as soon as variability of the patient comes into play. So that's very encouraging. And the second concern was the radiation dose. Now here I have shown you a lung lesion just for comparison purposes, and these are all images we obtain, and the total radiation dose amounted to 0.03 millisieverts. Those of you who know the unit and know what that means, it's a fraction of a chest X-ray. So we're down to that level. Certainly when diagnostic scans are to be performed before and after, that adds to the dose, but the actual biopsy is almost zero exposure. And that is important to also tell the patient. But by comparison, a conventional biopsy, which is continuously done worldwide, has also risks. So this is a case of a lung biopsy, obviously in the hands of someone who was maybe not trained well enough. And just by going through the images, you can see the total dose during that intervention was 66 millisieverts. So you see the span of a factor of 2,000 for pretty much the same biopsy. And the only difference is technology and training. I alluded to the fact that the hand should never be in the beam. Everyone who does fluoroscopy would know this. There's a lot of protection you can do. And the best thing ever is keep distance from the primary beam. That's not as easy as it sounds because you would like to hold the needle and the needle must be in the beam. And Gianfelice, Dr. Gianfelice, who was actually working in our department here some time ago, he analyzed the dose. Now, at that time, the technique was actually even exposing more, both the patient and the radiologist. We're using a fraction of the dose today. But even if I take that number, which is 0.018 millisieverts per second exposure, if you hold your hand with 20 centimeter distance from the primary beam, I calculated the amount of fluoroscopy that's possible to do without reaching the dose limit to adult occupational workers. That amounts to 7.7 hours annually. Now, again, our dose is a fraction of this today, so I would even argue I will never even come close to any concern when it comes to radiation dose to the operator. And, if cancers develop and grow into the heart, we have seen those cases already, not always has the heart to be biopsied. We can also take another route close to the heart and then see that we avoid the motion. In this particular case, turned out to be a mesothelioma, which is what we assumed. We need 4 images, take the sample, we take an image after the biopsy and then confirm there is no complication. Let me continue with this case. Not always is the target so big. As you know, the normal thickness on imaging of the pericardium should be about 3 millimeters. But here in the 70-year-old woman with plasma cell leukemia that was known prior to the biopsy, who presented with cardiac tamponade and left pleural effusion, the pericardial and pleural fluid cytology was again negative. But we strongly suspect malignancy in this patient. And you may see the nodular enhancement better seen on this delayed phase imaging. I marked it with the arrows. You see the nodules that seem to be originating from the pericardium. So we targeted those nodules. And as you can imagine now, it is critically important to have not only precision when it comes to needle placement, but also we need to make sure that our technique, which is CT fluoroscopy, is able to show us a motion-free image during the intervention. We took 3 cores, and it turned out to be a plasma cell neoplasia. I have the picture of the cores here with plasmablastic transformation, and there was no complication after the biopsy was performed. Very similarly, this is the case with thickening of the pericardium. It was a 68-year-old man with clinical symptoms of pericarditis. Again, you see the thickness up to 10 millimeters. That was highly concerning for malignancy, but we only found stromal tissue and no malignancy. And then we had follow-up imaging because we couldn't find malignancy, and there was marked improvement of the pericardial thickening. That being said, there will be cases that are extremely challenging, and this is one of which we managed to publish in the New England Journal because it was such a diagnostic dilemma we were in. It was a 50-year-old man who came to the emergency department with a 5-day history of sharp pleuritic pain, recently immigrated to Canada, was a smoker, and suffered from progressive fatigue. And again, you see the thickening of the pericardium and also pericardial effusion. The late phase imaging on CT shows the enhancement of the pericardium, which should definitely not be the case. And in addition, there was a tiny pulmonary nodule. Now, the problem of those nodules is, they are so ubiquitously found almost everywhere in every patient, it doesn't mean much, but certainly in certain conditions, we may pay more attention. Now, this is an echocardiography picture. I won't go further into interpretation, but those images again show pericardial effusion in both views. And I have a movie here, and the video 1 shows the apical 4-chamber view, and you can appreciate the septal bounce resulting from pericardial constriction. And the description, certainly IVS denotes the intravascular septum. And on video 2, which is now playing, you see a long axis view, and that shows the dilatation of the inferior vena cava and a lack of collapse during the inspiration as a result of pericardial constriction. We also performed an MRI. Again, it was a diagnostic dilemma. We didn't know what that potentially could be. And the phase-sensitive late gadolinium enhancement shows the marked pericardial enhancement, which sort of hints at something we suspected. This is going to be a chronic process. This may not be acute. You see the core needle biopsy and the challenges with it, right? On a non-contrast CT, there's very little differences in attenuation, and the heart is moving, and how to make sure that we not hit accidentally, a coronary artery or any other vital structure. So this is where training comes into play, possibly synchronization with the ECG signal. And you see the 3 cores we took. Interesting enough, the initial assessment was fibrinous pericarditis. Well, that is aligned with what we assumed, and AFB was negative. And then 2 weeks later, PCR testing came back and provided the diagnosis of Mycobacterium tuberculosis. A rare case, and in hindsight, one could think about many factors came into play: history, appearance, the pulmonary nodule, which could have been a TB manifestation. But again, this is always easy to say once you know the diagnosis, and very challenging when you don't have the histology. Now, looking at the complications, sure, what comes to mind easily is pneumothorax. I will tell you why I'm not so much concerned about this. Pneumomediastinum is almost always happening. But what we're worried about is a hemothorax, hemopericardium, perforation, certainly on coronary arteries, aorta and pulmonary arteries, cardiac arrest, and also embolism, which may be an underappreciated complication in some biopsies. Now, with respect to pneumothorax, I'm not so worried about it. I would even go as far as to say a pneumothorax is part of the procedure. Now, literature says it's about 30, 40%. Our internal statistic is only 7%, but it doesn't mean much. It does happen, it's hard to avoid, but we have means to mitigate the risk. One of which is actually creating a pneumothorax. You know, when you look at this case here, and we were not really clear, is it involving any mediastinal structure or just a pure pulmonary nodule? And you see what we did is we actually created pneumothorax. We used carbon dioxide. We described the technique as well because we believe that carbon dioxide is better tolerated by the patient, and also it's being resorbed automatically. Although we do take out the air after the procedure, it is a much faster recovery time for the patient. And plus, once you have a pneumothorax, you can actually use the needle almost like a surgical instrument with moving the nodule around and then coming to a position, as you see in the bottom row of the images, so that you don't have to go through a vital lung tissue in order to obtain a tissue for a diagnosis. The second complication I alluded that happens anywhere as soon as we touch the mediastinum is a hemothorax. And here the target was a tiny nodule that we didn't really know where that is. You see what happened. The internal mammary artery was obviously hit. You see with a circle, there was some active bleed immediately post biopsy, and we ended up having to coil this artery. This is a complication I'm worried about. That should not happen. It does happen. And adequate planning, knowing what you're doing, marking where the areas are of concern certainly mitigates the risk of having this complication. Now, this is a 54-year-old woman who had recurrent breast cancer. You see the nodule in the left upper corner image marked with a red arrow. But the breast cancer was 10 years ago. That was the initial diagnosis. And then the patient presented with cardiac and pericardial lobulated soft tissue masses encasing the lower SVC, the right atrial appendage, the right inferior pulmonary vein, and also the superior surface of the right ventricular intending into the intraventricular groove. Now, the interesting thing is we immediately assume patient has cancer. So what would that be? Certainly a manifestation of the primary neoplasm, but shape location wasn't so typical. What made it more complex is that a PET CT that was performed showed that the mass is FDG added. We then opted to take a biopsy approach, this time going directly through the lung, and you will see what that caused. And we took a core from that mass, and we could not show malignancy, to our surprise. But what's the final diagnosis was IgG4 related disease, a very rare manifestation. It's being described as potentially occurring everywhere in the body, but such a large mass invading with the appearance of a malignancy is the first description of such a case. And you may see some bleed around this, but the post-interventional CT did not show any complications, and 6 months later, without any causal treatment for IgG4 disease, the tumor decreased and the cancer could have been treated. Now, one thing we are always cognizant of, I wouldn't say concerned about, but cognizant of, is an action bias. And whenever we do any intervention, that is a general rule for anything we do, there needs to be an impact on treatment. If the course or the choice of a definitive treatment, be it surgery, chemotherapy, or radiation, is not altered by the biopsy or by the results, I'm not so sure it's the right action to undertake. So we need to have a multidisciplinary discussion with our colleagues, which we do, as to whether a biopsy really has any impact on treatment. Now, here's a case in which you may raise questions, but I'm standing firmly behind the indication of that biopsy. It was a 25-year-old, very young man who had non-specific neck and groin pain. An incidental mass was found in the interventricular septum that measured, a pretty large size, 9 by 5 by 4 centimeters. Interesting enough, this neoplasm was dark on T1 and T2 and had no change with fat set sequences, which means there's no fat, neither macroscopic nor microscopic fat contained in this mass. And there was no enhancement on first pass imaging, but there was a diffuse uptake on the late imaging. Again, I'm showing you the phase-sensitive late gadolinium enhancement, which is pretty bright here for this tumor on this image. Now, again, the indication was clearly discussed. Is that the right approach to undertake? We took 2 cores, we did not find malignancy, and we found a cardiac fibroma. Now, when we go back, this is a very rare manifestation in the heart, but cases have been reported. Now, when we reviewed back the cases, well, there were clear indications. The behavior on magnetic resonance imaging, on CT, with some calcifications, and the natural behavior actually was aligned with a cardiac fibroma. But would we be able to make that diagnosis beforehand? Probably not. Similar, this case, you might look at clearly, that's a lipoma. And yes, that what came back was a 36-year-old male with progressive exertional chest pain and dyspnea and reduced energy for 3 months. Now you see this low attenuating mass on CT and signal characteristics that are very clearly hinting at lipomatous tissue. We took a core, and you actually can see the grease eyes on floating on in the formalin here. But you know, when I took the cores, they sank. And I wasn't 100% sure if that's just pure fat or if there's anything else in this tumor, liposarcoma, any other etiology that we may have missed. And then the patient went on because of the mass effect here at UHN to surgery. And the final histology was a hypertrophy arising from the right atrial epicardium. Rare situation, but I would think it was justified to undertake the biopsy beforehand. Now, what are we cognizant of? What we do is we always have to realize we have to follow the standard operating procedures, standard of care preparation for biopsy, which includes talking to the patient, making sure all the criteria are met in terms of anticoagulation that needs to be halted at least for 7 days. Patient need to be prepared, NPO, have someone to go home if that's on an ambulatory situation. And you know, the patient needs to be aware of the consequences either of doing the biopsy or of not doing the biopsy. Then we provide EKG monitoring inside of the room. I'm a personal big fan of plenty of topical anesthesia. I know many people go for much more, and that's fine too, but there is never a situation in which one can compensate the lack of freezing by any other medication. That's a prerequisite, and I always use double dose, and I could strongly recommend not to be shy to use more freezing because that makes a huge difference for everyone in the room, not only the patient, but also the stress level for all the operators in the room. We typically provide conscious sedation cautiously, which is midazolam and fentanyl. You know, the concerns sometimes patients have about fentanyl, it's a microdose, but still it needs to be discussed. In this country here in Canada, there's a mandatory written order for sedation. We can't just give it right away. I pretty much think that's in most countries the case. But also we make sure we have suction, and in the current environment of Corona, certainly appropriate PPE needs to be available, and that's mandatorily requested in our hospital. One thing I cannot overly highlight, it is you need to have cardiac surgery available and alert. Whatever we do, you know, it is to me not only a comforting thing, I think it's a prerequisite for doing anything that's related to the heart. Your colleagues need to be informed about it. Needs to be discussed. They need to know when it's happening. So just in case any unfortunate event is going to happen, you need the expertise of our colleagues, which we do have here, and they're so helpful, always saying never an issue, call right away, and we will be there to assist you. That to me is maybe the most important prerequisite for any intervention in the heart outside of the cath lab. Now, we have meanwhile done 11 patients recently, and you might think this is not a large series. In fact, it is the largest series to my surprise. And I alluded to, I wasn't really clear why people are shying away from using CT. One of the reasons certainly is it needs to be the right indication. You need to have the expertise locally, but also you need to have the backup of your cardiologist and cardiac surgeons, just in case, as I mentioned, anything goes wrong. We did not have any major complications, a small hemothorax that was just locally and didn't go any further, and a small pneumomediastinum, which I actually wouldn't even say it's a complication, because as soon as you use needles, there's always some air introduced. That's an expectation, so maybe that's not even a complication. And in one case, we aspirated fluid and then had to place a drain, which was discussed beforehand as a possible treatment option. This is the last case I'm going to show to you. It's a 57-year-old woman with intermittent palpitations. And the CT scan showed you a 7.8 by 5.2 centimeter enhancing mass along the right cardiac border with mass effect on both the atria, the superior vena cava, and the right pulmonary artery. And I've shown you an axis slice that is most relevant, and also a coronal reformat, which tells you the extent of this potential neoplasm. Now, here comes the question, is there any reason we could have avoided the biopsy? Maybe we could, but all imaging characteristics were unclear, not definitively for any diagnostic entity. So we went through the lung this time again, which I don't think is a major issue. And you see the little bleed in the parenchyma as highlighted with the arrow in the upper middle image. And the cores were kind of interesting, not really white, what I would have expected. There were no calcifications. Post-biopsy chest X-ray was unremarkable, and the diagnosis came back as a cavernous hemangioma. Now, that entity, you could argue, would there be a possibility to do maybe an angiography study or maybe another MRI to get closer to the final diagnosis? Sure, always, that's a possibility. But even in a vascular mass, if done with the right technique, the right precautionary measures, I believe biopsies can be done in a safe fashion without putting the patient at unnecessary risk. So I was thinking about what could be a reasonable summary statement. And that's hard to say because it's such a heterogeneous entity and there's so many factors that come into play. And I looked at the latest case report that I alluded to initially, and the authors actually gave a nice summary statement. They said, although transluminal catheter-directed endomyocardial biopsies are, as I mentioned before, currently the standard of care, CT-guided approaches should be considered and may be the optimal technique for large lobulated cardiac masses that will be biopsied without penetrating the endocardium. I can sign on to the statement, absolutely 100%. I may even go a little bit further. Once cases are being discussed, there is an impact of the diagnosis onto treatment, and you have an interdisciplinary approach to those complex cases. I wouldn't necessarily only say large lobulated cardiac masses. As I've shown to you, we can target with the right tools, the expertise, we can target tiny nodules almost anywhere in the body. But as I mentioned before, it needs to be carefully evaluated, right precautionary measures, and it requires an interdisciplinary team approach. I would like to acknowledge the help of our nursing staff, always amazing what they can do and support us in any of what we're doing. The technologists, which are essential to those things, nothing can work without them, for having the right measures in place, assisting us if need be. I would acknowledge my fellow Marina, who put many of those cases together and collated those cases, and certainly my internal colleague at JDMI, Mini Pekal, who's always a great resource if I have any diagnostic questions. And with that, I thank you for your attention, and please do not hesitate to ask me any critical question. Thank you.
Well, Patrick, as expected, that was spectacular. I knew that when I first met you and you did this for me, that this was something very, very special, very, very special that you brought to the cardiac tumor team and to the hospital in general. And until you showed this today, I didn't realize how special it is. You and I have spoken about publishing this, and you definitely should publish this because this is something that has helped us here tremendously. And it's an envy of people who hear about it, even Dr. Reardon down in Houston, and they have a very, very large, as I said, the largest in the world. They don't have this. So it's very, very important. I'm always amazed that you can do this without, on a moving heart. I'm really amazed. If anybody has any questions, please put them into the chat so I don't take up all the time. Is there anything that bothers you within the heart? For instance, we showed, I remember that case of the septal tumor that's at the apex. What about in the center of the septum or within the free wall of the heart in the smaller lesions?
Yeah.
You know, I'm amazed. I really honestly mean, I'm so amazed and so happy that we have you here. It isn't funny. I'm shocked that you could put a needle into a heart that moves around, but what is it that scares you?
I would say anything that goes inside of the perimeter of the heart, of the myocardial midline, I have the deepest respect. So maybe I can answer the question this way. One of the fundamental attitudes any interventionist must have in those circumstances is to have the deepest respect for things that can go wrong, and particularly the moving heart. I mean, there's the problem with the heart, as we spoke about, is not only it moves autonomously with very little control, for sure, but also the patient may move. the diaphragm does move. So there is a multi-directional, multi-dimensional motion ongoing, which requires this real-time imaging. And I do have the deepest respect. Don't get me wrong here. I wouldn't say I would easily go into the septum. I probably would ask you and call you and say, can you please assist? Those are probably limitations pushing the boundaries very far. Everything that is sort of outside of the midline perimeter of the myocardium probably is a target, a possible target. When it goes inside, I would call you and have a discussion of this case. I think you're muted. Robert, I don't think I hear
I was
you.
muted. I was muted.
Yeah.
I didn't want anybody to interfere with you. The understanding for the audience of what this has really done to us is that up until I met Dr. Rogala, we would try a percutaneous biopsy, and some of the times the biopsy would not have any diagnostic tissue, to the point where one of the people I used to go to, one of the cardiological friends that I used to go to, said, RJ, I only get pathology on these people maybe 30 or 40% of the time when we do percutaneously. There's nothing else to do. And the next step is either to do a gigantic excisional biopsy, if it's in a place where we can biopsy, for instance, the atria, or an incisional small biopsy to go in there and use a true cut needle, which I've done before, on the heart, or take a piece of the tissue. It requires an operation, recovery. Sometimes the people are not very healthy, and you're leaving a very large portion of the tumor there. All the way to go and speak to Dr. Rogala, and he says, let me look at it. And he discusses with whoever he discusses with, and they plan whoever they plan. And I know the day it's going to happen. And he always sends me pictures of these cores. And the next talk we're going to have after the break is Dr. Seidman talking about the limitations of biopsy using small tissue. But this is a gigantic tissue compared to the alternatives, a gigantic, gigantic step forward. And I can't emphasize that enough, how much it's helped us. How often do you not get tissue?
That's a good question. For the cardiac cases, it didn't happen yet, but it's only a matter of time. I mean, let's be honest, nothing is 100%, never. On average, of all the things we do in the chest, and let's take only the chest cases because the abdomen is profoundly different, we're approaching 96%.
Wow, that's great. And you use different size of needles, you said.
Yeah, ongoing discussion, I can tell you, as you can imagine. That's why I wanted to
ask you about that. Could you delve into that a little bit?
Yes, I can, for sure. That depends on the access route. Generally speaking, as everyone would know and has experienced, the thinner the needle, the fewer the complication. That has been consistently being published, and that's the experience worldwide. And it makes sense, for sure. And there seems to be a threshold up to which you can go. So naturally saying, the larger the needle, the more tissue you have, the fewer passes you need. And then, since the amount of tissue is crucial to making a diagnosis, there's a desire to go to bigger needles. It seems to be not confirmed, and I make that clear. It's the lowest degree of evidence that I can provide you with, which is just personal experience, is when you go up to 18 gauge, which is about 1 millimeter in diameter, that seems to be the upper limit. Below or with 18 gauge, complications are manageable. And when you go larger, the complications go up. That's the experience we have everywhere in the body, in particular in the chest. And I would argue it has to do with biology, how much blood can coagulate in a certain period of time. So my answer to your question would be, we try to use 18 gauge whenever possible, unless there is a very, very tricky area to go through, or we have concerns about access route and whatever that is, we may go smaller, but we try to go for 18 gauge. Now, the needle we use is a full-size core, as opposed to needles that have a tray, which doubles the amount of tissue per diameter, so to speak. And that's the preference we have. It's a gun, it's a spring gun needle. use it with caution, as I said before, get some training. And so what we do is we ask fellows to be trained on phantoms first. They need to be comfortable with those needles, because as you can imagine, a spring-loaded gun in the wrong position when the heart is moving, damage can easily be made. So the answer to your question is up to 18 gauge, which is about 1 millimeter, possibly smaller if need be. I'm hesitant to go larger than that. You're muted.
Sorry, I should remain unmuted during the discussion period. Someone says, what are the precautionary steps and measures that you take while performing the biopsy to avoid arrhythmia during the procedure? Because that can be problematic as well.
That can be problematic. It's a very good question. So what we do is we potentially have all the equipment in the room that would be required to get out of that scenario. The best thing is you have someone who is trained with this. Some authors have suggested to have the pads already on the patient to make sure if any defibrillation needs to be made, that's possible. We do have the equipment in the room because we do know our team, when we call them, is so quick that it probably is a safer option to just wait until the professionals come rather than doing it as a radiologist. We have done it for sure, but we're not sufficiently trained, I would think. So the answer to that question is yes, we do have those precautionary measures. It depends on where we take the biopsies. If the biopsy really is next to an area where I would be deeply worried about this, we have that available. If the biopsy is somewhere in the pericardium or somewhere attached to the heart, we don't do this routinely. I didn't mention the emboli, and there have been many reports suggesting air embolism is a consideration. And or maybe if you touch a tumor that has an intra-arterial or intravenous component, there may be the risk of soft tissue getting loose and then causing an embolism. Definitely that's a risk. And you may have seen on the cases I showed to you, we try to go to the outer portion. I'm worried about this, removing tissue and then it flows away and can cause damage. That is a general consideration, and we try to avoid this by all means. But the answer to your question is we have that available, and if need be, we put these pads on. There's a great discussion in the last paper that I mentioned, the most recent, and they talk about every step that could be undertaken in order to avoid and mitigate the risk of arrhythmia.
You spoke about training, and obviously this is something that not every interventional radiologist can do. You guys are specialized, highly, highly, highly specialized. There's interventional radiologists, and then there's the chest radiologists, and then there's somebody like you. Talk to us about this kind of stuff in terms of what kind of a training a person you think should have to start doing this kind of stuff, because it's still, even in our hospital, still uncommon.
It's true, and I would emphasize beyond me, remove myself from the spectrum here, because everyone specializes in something, and then this person becomes an expert in something, and that's dangerous, because if that person is not available, then the standard of care deviates. You're right. Experience is required, and I would strongly encourage anyone who is looking at biopsying those entities. You need to be extremely comfortable, both with the technology, the setup, the people around you, and also the needle you use. So what we do is fellows come in, and it's a 1-year training process initially, but they come. I don't allow them to hold the needle, to be honest. And this is not trying to be difficult. It's just I want people to appreciate the environment, to see what can happen, to be relaxed. One of the things, by the way, it's a core element that I always try to teach is if the operator is not comfortable, if the interventionist is not relaxed in the sense of muscle tension, things go wrong. You need to, it's like when you play music. When you're focused on the technicality of playing something, it's not going to be good. You need to be above the scenario, and it must seem to you as if this is a routine procedure. Only then do you have the capacity to be alert to things that can go wrong. So training is absolutely essential. And I would focus on the fact that you need to be comfortable with the needle. You need to have experience, maybe with lung biopsy, see the potential complications. And what we always do is we have other colleagues around. I will have an error margin. I will make mistakes. I do make mistakes. So quite often we have a second staff somewhere nearby for advice. It's always different when you are outside of the room. You can look through the window. You get a different view, and that view can be valuable if that needs to be taken into consideration. So I cannot re-emphasize how important training is. We let fellows train with phantoms. We gradually grow them into holding the needle, making sure complications do not occur. We let them treat the complications, and only then we feel comfortable letting people do the biopsy on their own, always with supervision. Now, you ask myself, well, I've been doing it since 30 years. That's a different scenario, but experience is key to success here.
I think it's important to have a big team, and you're part of the team.
Yes.
And it's
Absolutely.
important to have collaboration. This is really directed to the junior people who are on the, always collaborate, always ask for help, never do anything by yourself.
Yes.
Always ask for help. Two heads are always better than one.
Yes. And it's, as you said, it's sometimes, in particular, interventionalists. Now, I always feel almost intimidated when I speak to people like you and others who do such an, I don't know, a job that I could never do. It is, and then interventionists believe they are little surgeons. So that's a joke. I don't mean it that way. But we need to be cognizant of the limitations as well. And if any doubt occurs in those cases, it should always be a consideration to contact cardiologists, to contact your cardiac surgeon, discuss the case in a very open and clear fashion. That to me is the underlying prerequisite for any intervention in the heart.
Yeah, never do anything by yourself. That was, I must say, that was a spectacular talk. I really enjoyed it.
Thank
I'm
you.
sure after this you may get more people applying to your fellowship, which is
I
okay
hope so.
because one of the things is to disseminate the knowledge and to get other areas of expertise. And we are the number one in the world, it looks like, for this, and be helpful to have other places in the world that can take our experience. We're going to have a small break now for about 15 minutes or so. When we come back, Dr. Seidman's, one of our pathologists, going to talk about the challenges he has with the small biopsies. We heard about different size of needles and why Dr. Regala and his colleagues use those smaller needles. We heard about transcutaneous biopsies by the cardiologists, and we provide very small biopsies. For those who do heart transplant, we know we give small biopsies to Dr. Seidman all the time, but there are some things we ask and some things our oncologists ask that we cannot do, but there are things that we can. And Dr. Seidman is going to talk to us in about 15 minutes or so about some of those things. It's been a great start so far, other than the little bit of a hiccup we had at the beginning when we couldn't figure out how to run this thing, but we've run up very nicely. And everybody, please ask any questions you can into the chat. Don't be afraid to ask any questions. If you don't know the answer, it's not a dumb question. Anyway, thanks very much, and we'll see you all in about 15 minutes or so.
Thank you. Have a good
very
day.
much,
Thank
Dr.
you.
Regala.
RJ, I'm going to take my cue from you. Oh, I guess it's taped. So.
Hey there, yeah, I'm just waiting for RJ to return.
Oh, that makes it much easier for him to hear me. Yeah.
Yeah. Okay, I think we can start now. Am I live?
You are.
The next lecture is going to be by Dr. Michael Seidman. He's a pathologist that we in Canada stole from the United States, and we in Toronto stole him from Vancouver. And it's been a real pleasure to know him. He's a very good guy, very, very smart man, and he's going to talk to us today about what we give him, and is not very much, and that's small pieces of biopsy. And with that, he has to tell us what we need to do with the patient. So without further ado, Michael, you can take over from now. I'll put my phone on, I'll put my mute on, and if I start chatting later on, you can remind me to take my mute off.
Hello, everyone. I'm Mike Seidman. I'm a cardiovascular pathologist practicing at UHN in Toronto. Dr. Cusimano asked me today to talk about a pathologist's view on the tumor biopsies, and specifically what's enough, what sort of adequacy considerations are there, since when taking a biopsy, that's frequently a concern, is that if you miss, you have to go in and do another procedure. So to give you an idea of the range of what we might see, the image on the left, the white bar, is a 1 centimeter size reference. This is a 9 centimeter cardiac fibroma resection that was done at one of my previous institutions. In contrast, on the right, again, that is a 1 centimeter scale bar. This is a small cardiac biopsy. We see significantly more of what's on the right, so we've had to develop tools to best adapt to that. I just wanted to say I have no disclosures or conflicts of interest. And to the best of my ability, I've tried to cite sources on images. If I missed one, I apologize in advance. And a lot of the images, especially when not cited, are my own. So what I'm going to attempt to do is give you some of the principles of pathology evaluation of biopsies, particularly of cardiovascular masses, from the point of view of a pathologist. And what the important considerations I view in obtaining adequate biopsies, and then giving some tips in new ways that we might be able to start approaching tumor biopsy and sampling that might even further improve our experience. So it's important first to state why we're even doing the pathology, and what I view my job to be and my colleagues' jobs to be is that you need to be able to treat the patients when you're in the clinic, be that surgically, medically, et cetera, and we need to provide you enough information to do that. And I specifically state it that way in that we're never going to be able to tell you literally everything, but we can almost always tell you enough to take the next step forward. And our goal is to not tell you simply, I don't know, although that will inevitably happen sometimes. So diagnosis is really what drives most of the workup. Frequently, we're asked to obviously evaluate margins of resection to determine, basically if tumor is left, as many of you know. And in some cases, we are seeing post-treatment resections, and the question is how well tumor has responded to previous treatment, which would then presumably inform future treatment. Now, all of this is dependent on having enough material to answer the question. So I will say diagnosis, which does drive most of the adequacy question, is balanced against a few different things. So the as soon as possible concept, the speed, is perhaps a more complex concept than often conceived, in that there's what the surgeon needs to know instantaneously, or the proceduralist needs to know instantaneously. There's what the treatment physicians need to know in the next day or two, and then there's what information needs to ultimately be known in toto. Communication is fairly easy these days. Email provides a written record. Preliminary reports can usually be issued. So the speed of a report can vary from minutes to weeks or months, depending on how much information is gathered. And effectively, these are balancing accuracy and precision. What I can tell you on day one will not be very precise and is more prone to error. On day two, we can be pretty accurate, but not precise. And over time, we get progressively more precise and progressively more accurate, although preliminarily, we can at least tell you things like the class of tumor. So I'm going to open with a case. I have 3 vignettes scattered throughout the talk. Case 1 I've named a joint effort. This is a 36-year-old female with new onset chest pain and shortness of breath, no significant past medical history. And in workup of her shortness of breath, imaging identified a 7-centimeter mediastinal mass. A biopsy was taken and the image is shown. So it was done by percutaneous needle biopsy, and the H&E histologic section the next day came back as spindle cell lesion. What I knew was what you see in front of you, in that they were elongated, so-called cigar-shaped cells with big nuclei. They looked pretty unusual, and I was pretty sure this was some sort of cancer, but I was cautious. I did some stains, so this would now be the second day post-op, and I could confirm that it was a sarcoma, but that was about all I knew, and we didn't have the resources to do much more at UHN, so after we ran out of stains, we sent it across the street to our colleagues at Mount Sinai Hospital who have a specialized sarcoma group. And I will follow up later with what happened next. So in this context, it's important to talk about what types of masses we see. The most common mass in the heart that we actually see from a chamber is by far thrombus. And in terms of neoplasms, probably these days we're seeing myxoma more than metastasis, although in the past, metastasis was probably more common. One of the things we do see a lot of is scar, damage from other sources. Thrombus itself can be reactive or primary. And myxoma and a couple other lesions are the benign lesions we do see. And these are sort of the first things we think about, although frequently with the modern tools, something comes to us with a higher degree of suspicion if it's not one of these things. And this is actually the gross picture of a myxoma. The small little pieces show how bloody these things are and how much they can look like thrombus. And in fact, the cut section even shows hemorrhagic change in the center of the tumor, the arrow pointing out the little stalk attached to the myocardium. So then, of course, there's the malignant lesions, which is perhaps the focus today. And more common than anything else is metastasis, although they are less commonly biopsied, although frequently treated with surgery. The most common is certainly carcinoma, the lung and breast being adjacent, and the liver and kidney by virtue of ascending the IVC are lesions that are commonly seen. I have certainly heard anecdotes of others. Those happen to be the only 4 I've personally have encountered so far. Melanoma is actually not uncommon. There are several really marked cases of melanoma metastasizing to the heart. And lymphoma involvement of the heart is not uncommon, at least as cardiac tumors go. The primary lesions, by far the most common, is sarcomas. It is a soft tissue organ. You would expect it to be soft tissue tumors. Mesothelioma of the pericardium also does exist, and lymphomas that originate in the heart and are primarily diagnosed there certainly also exist. So this is an example of melanoma metastasizing to the heart and replacing a majority of the myocardium. Fortunately, this one was pigmented, so it made for a nice picture, but unfortunately not a good story for the patient. And the bottom is a picture of a pericardial mesothelioma. These do come up. I have seen one that was an accidental finding at Cabbage. And sometimes these are very straightforward and sometimes less so. I'm going to move on to my second case vignette, which I called What's the Bloody Diagnosis? This 50-year-old had new onset shortness of breath. Again, no significant past medical history, and a 4-centimeter epicardial mass. The pericardial effusion that resulted was aspirated and sent for cytology. And that is seen off to the right in what's called a Giemsa stain, a common cytologic stain that has some similarity to H&E, but with better cytomorphologic detail. And it was almost immediately identified that there were numerous small atypical blue cells, which is a category, so to speak, of neoplasm, frequently malignant, that includes a bunch of different types of lesions, and that has a fairly well-defined workup process. And numerous additional material was available, and the process was started from there to proceed. And I will give you more follow-up later in the talk. So this raises the question of some of the tools we use. Obviously, for surgical specimens, the gross evaluation is key, particularly on cardiac specimens. Assessing orientation, what parts are included, where tumor extends can be very valuable for future planning. Although on biopsies, the gross is usually not all that useful. We can comment on the color, which sometimes is helpful, sometimes not, and the size. Frozen section is often used for surgical specimens. I do want to point out that it has a very high error rate relative to permanent sections, to formalin fixed, paraffin embedded, but it is very fast. So in the middle is an example of frozen section, while off to the right is an example of permanent section of the same lesion. Off to the left is cytology taken at the exact same time as that frozen section, which actually gave better picture of the cells, where the big cells are compared to smaller lymphocytes and can be more easily identified as atypical. In the middle, I have to admit, I would be mildly confused as to what I was looking at, although fortunately there are some smaller, more normal cells towards the top. And on the right, there is no question that that is a neoplasm. In fact, this was a Ewing sarcoma. So continuing along the tools we use, the workhorse continues to be paraffin sections. Of note, the sections we take are typically 4 microns thick, and a typical slide from a biopsy will have 3 cuts of the tissue on there to make sure that we get a representation of the tissue that doesn't fragment, doesn't fall off the slide during processing, etc. Now, it will become relevant that an 18 gauge needle inner diameter is less than a centimeter. So we only have so much tissue to work with. Some other types of biopsies, this is a different consideration, but the needle biopsies are common, and I thought it would be useful to use that as an analogy. So when we get to histology, we always need H&E stain. It is what almost everything else is based on. It is the workhorse of pathology histomorphology. We do order a number of other stains, and in fact, in this cardiac fibroma shown, the key finding was actually on trichrome and Movat pentachromes, much less so on the special stains, since cardiac fibroma is kind of stained for nothing. Each stain that we perform takes about 20 microns, and we usually perform more than one H&E to make sure that we represent different depths of the specimen. So you can add up fairly quickly to a sizable portion of the core. Immunohistochemistry has really become one of the workhorses of tumor phenotyping, and it'll typically take between 5 and 20 stains, plus or minus, to identify the type of lesion in a particular case. Each of those takes another 20 microns. And in the modern day, it's relevant that molecular diagnosis, which really has become the gold standard and drives a considerable amount of care right now, requires an additional 1 to 2 millimeters of tissue depth for optimal testing, which obviously on a needle core dramatically limits the amount of material available and raises the question as to how much we can get away with. And in modern techniques, less DNA is frequently usable, but it does require that a significant fraction of that core actually be tumor. Case vignette 3, what am I? A 45-year-old male who was just generally unwell. There was a 2-centimeter intracavitary RV mass and had a massive significant history of alcohol abuse. On the left is the H&E histologic stain, and on the right is a cytokeratin immunohistochemistry. These are on endomyocardial biopsy performed by catheter. The H&E was available approximately 24 hours after the procedure and favored carcinoma based on its particular findings and morphology. It took several more days to get the immunohistochemistry, at which time keratin confirms that it is in fact a carcinoma. However, additional stains were still required to tell more than that. So some of the limitations we face that perhaps are the most important in considering the nature of the biopsy to be performed is one of the biggest limitations is, did the tumor get sampled? And this is limited both by the things that are listed below this, as well as the fact that identifying the tumor itself can obviously be challenging without direct visualization. Modern imaging is obviously infinitely superior to in the past, but it's still possible to catch a cystic portion of it, to miss the tumor cells and capture the material around it, etc. So in particular, tumor necrosis and surrounding tissue necrosis can appear mass-like, but is not useful at all for evaluation. Desmoplastic fibrosis surrounding a tumor, again, is not diagnostic. It'll be the reactive process and not actually sample the tumor itself. And thrombus, particularly in the context of cardiovascular lesions, is a major limitation. One additional note, and this is relevant going back to the size of the samples, if we have to go back on a subsequent day and cut more slides, it is not uncommon to lose another 100 to 200 microns of tissue due to what's called refacing. So the block will not be aligned the same way on the microtome. So the cutting will actually require a couple cuts just to get into the block again, at which point we are losing a little bit more tissue. So the more material we have up front, the easier it is to diagnose. Whereas in lesions such as the one pictured, it was very challenging, and more or less we ran out of material before we could do very much. So this is a sarcoma resection. This individual had a remote history of childhood osteosarcoma, and the majority of the lesion when sampled was thrombus and necrosis. There was a little bit of viable tumor. I do not know the status of the molecular testing on this case. It's relatively recent, but it is presumed that this is metastasis from osteosarcoma, which would actually have no specific findings on molecular testing. The major problem when I reviewed this case was that there was so little tumor present that there really was no value in me performing additional stains, and we had to wait for the additional workup. So this raises the question of what specimens might come to us and which are, in air quotes, better. So needle cores certainly are the traditional finding in most tumors, less invasive than many other options. And increasingly, as surgeries go in, even for things such as placing people on mechanical circulation, we're seeing a fair number of intraoperative true cut biopsies. It's important to note that we have to layer these longitudinally, and as a result, the width from the perspective of the needle is actually what determines the amount of depth we can sample from. So a 1 centimeter long core gives us a lot of tissue to look at per slide, but only generates so many slides. In contrast, a transcatheter endomyocardial biopsy, as pictured on the right, takes a chunk of tissue out that's usually 1 to 2, sometimes 3 millimeters across, frequently several chunks. As a result, no matter how it gets embedded, we see relatively the same amount of material, and we get more slides of depth out of it and more material for future testing. I will say I'm a pathologist. The more tissue you give me, the better. So open biopsy, i.e. excisional biopsy or resection, are obviously my preference for reviewing things. It is much less likely to face limitations, but I am not oblivious to the patient impact, of course, and want to do everything in my power to make biopsies work. It's just when you ask your pathologist how much is enough, the reflex is the more the better. So I'm going to come back to my cases. Case 1, this was the 36-year-old female, 7 centimeter mediastinal mass, was diagnosed as a spindle cell sarcoma without pipe. Even the expert agreed it was spindle cell sarcoma, threw a bunch more stains at it, but really couldn't conclude. There wasn't a ton of tissue left, but it was ultimately sent for molecular via a fancy new assay called the TrueSite Fusion Panel, which identifies a set of common rearrangements, cytogenetic rearrangements, found in certain types of tumors. And this particular one was found to have the diagnostic fusion protein for synovial sarcoma. So although it didn't have the histologic findings or the staining findings that were individually diagnostic, a very specific diagnosis was reached on molecular. However, that was pretty much all the tissue we had. So had any further studies been necessary, or in the future, as things are developed, we really have no more material on such a case. That said, it is likely at this point enough guidance has been given for chemotherapy, radiation, surgery, etc. Case 2, this was the pericardial effusion that was diagnosed as small atypical blue cells, but with tons of material. So by post-op day 1, this had been sent for a rather extensive hematologic workup and numerous stains. So they make what's called a cell block, which I'll talk about in a few minutes. And CD45 stain, which is a pan-leukocyte marker, was positive. Additional 30 stains and the flow cytometry within, I think it was 3 or 4 days, resulted in a definitive diagnosis of B lymphoblastic lymphoma, and significant material was left to further do molecular testing. This particular case was highly cellular. The effusion had lots of tumor in it, but it is an interesting contrast given the nature of how cytology is performed. And case 3, what am I? This is the 45-year-old with the intracavitary mass and significant alcohol abuse. And all we got to was carcinoma. However, given the clinical and histologic suspicion, I continued working up for hepatocellular carcinoma. And the traditional stain that we performed, called HepPAR, was negative, at which point I was a little let down. Of note, nothing else was positive, so I ended up with carcinoma not otherwise specified. But this is a relatively well-differentiated lesion. I could still see structure in it, and something didn't jive. So I talked to some of my colleagues, and there's a fancy new stain called Glypican 3. When we stained that, the exact same piece of tissue was positive, confirming a diagnosis of hepatocellular carcinoma, just the immunophenotype had changed during the course of metastasis, processing, etc. Of note, though, that is the exact same field of tissue, and you'll notice on the right there is considerably less material than on the left. So as that gets deeper and deeper, we will get progressively less and less tissue, which is relevant for future ancillary studies such as molecular. So this does overlap with some of the questions around intraoperative consultation, because that will also affect adequacy. I am the first to tell you that if you're going to do something different in surgery as a result of a frozen section, it is completely indicated. However, I'm also the first to tell you that if it won't change anything intraoperatively, it might not be the best route. The quality of a frozen section, as we've shown before, on the top right is the same image you saw, is significantly lower quality than the permanent section from the same lesion seen on the bottom right. So you could be looking at a difference of as little as 18 to 24 hours, depending on the facility availability, with a considerable increase in the quality of the information you will receive. As a result, you have to balance these two things against each other. If it won't change what you're doing that day, it's probably worth considering an alternate technique, such as a rush biopsy. The other thing to consider is cytology. So on the bottom right is the cytology image from the previous case. And this is just one of several preparations they made in this particular instance. And they were much more comfortable diagnosing this as a malignant lesion than was the individual performing the frozen section. So this is very, very valuable in considering, because we can actually generate cytologic preparations even from the material taken intraoperatively from a surgical approach. So I thought I should talk about cytology because it's not very common in heart or in soft tissue tumors. So it's very common in carcinomas. The lung folks use this rather frequently through endobronchial ultrasound guided fine needle aspirates. It's used in a lot of hematologic malignancies. And the question really comes up is, could it be useful in cardiovascular tumors? So for fluids and effusions, as I showed you in case 2 previously, it's very effective if the material is cellular. So the material is basically pelleted onto a slide using the funnels that you see in the centrifuge on the top. An individual funnel is shown below. About 100 microliters of the cell suspension is loaded into that funnel, and the centrifuge then effectively spins it onto the slide, where the small foam pad you see on the right absorbs the fluid while the cells stick to the charged slide. This is excellent for providing histologic, cytomorphologic evaluation of the lesion, and can be done in a very rapid time frame, sometimes same day. That same material, the remaining fluid, can then be pelleted and combined into what effectively becomes a piece of tissue, although not oriented the same way as in vivo, which can then be converted to an FFPE block and evaluated through the same traditional histologic methods that are used otherwise. Again, this is really best performed the more cellular lesions. A paucicellular lesion will be very hard to work up that way. Fine needle aspiration has become one of the workhorses of cytology. This is using simply a smaller gauge needle than would typically be used for a needle core, and several rapid passes of a cutting needle captures a little tiny bit of tissue in the needle that is aspirated back into the syringe and placed onto a glass slide by pushing it back out. This material is effectively isolated microscopic clumps of the tumor, but provides for a near instantaneous, in the span of 5 minutes, evaluation, in that the 4 vials you see in front of you, it's a few seconds to a minute in each of those 3 initial vials. The water is largely to wash off the extra, Cover slipping takes mere second, and with a microscope provided on site, it is possible to tell you if there's lesion there, which is perhaps the most important thing. You can then guide along the same track depending on the sheath you're using for a needle core, hypothetically. A lot of places use this in other contexts. Plus, you can do it again rapidly, and in some rare cases, you can get a diagnosis. The fine needle aspirate is also potentially usable for downstream diagnoses via a variety of techniques, although frequently the techniques mentioned on the previous slide would warrant more material. And then there's the, you sent us surgical or biopsy tissue, what can we do to help you in terms of cytology? And again, this is not commonly utilized. I've only started asking the question in the past few months, and I am not directly engaged in the process of generating these slides as of yet. Other centers have had significant success with sarcomas. I don't know anyone specifically doing this in cardiovascular. But what can be done is the tiny piece of tissue you send us, such as the needle core seen on the images there, can be dragged across a slide or tapped onto a slide several different times to generate either a touch prep or a smear where enough cells are taken off to provide for a rapid assessment similar to a fine needle aspirate. It is also possible with a larger section to run a glass slide across the lesion, such as a several centimeter tumor like the one shown on the first slide, and spread those cells across a glass slide to accomplish roughly the same evaluation. This process allows for a traditional needle core or catheter-driven biopsy to be evaluated for adequacy in the context of being en suite and being able to guide whether or not more is necessary. Again, this is not always implemented or even commonly implemented in this context, but it might be worth pursuing given the resources available for most other organs and cancer types. It's also important to note that cytology, by virtue of being fluid-based, can be rapidly converted to flow cytometry if a hematologic malignancy is suspected. It's particularly useful for generating rapid molecular. Given the types of fixatives, they have somewhat different considerations for what can and can't be done compared to formalin. And it can be converted, as I mentioned, to pseudohistology, which allows for immunohistochemistry phenotyping. So the takeaway message is that I wanted to give in the talk, although I suspect our conversation following will be much more fruitful, is we need enough material to evaluate, but most of the time we get enough to tell you what you absolutely need to know in guiding treatment. We have a lot of techniques available, and it's important in context to evaluate the right one. I would say that in general, talking to a pathologist can help with this. Some are more comfortable with certain techniques than others, and it does raise an opportunity for mutual education and advancement. I just wanted to throw in, as I clearly emphasized, cytology might be valuable. We as a subspecialty field don't use it very often, but it provides an opportunity. So the lesion off to the right is my token. It should be a tumor, or I should say it should be a neoplasm, but it wasn't. This was a lesion that was worked up rather extensively for a primary histiocytosis, and in the end, ended up looking more like a storage disorder in an older individual. We did some additional studies, and in the end confirmed that the most likely diagnosis here was that this was actually a drug toxicity effect, creating a mass-like lesion in the heart. I just thought that was a cool, interesting OMA to end with. We're going to have a conversation following this, but thank you. My email address is there. Please feel free to reach out. Thank you very much.
Thank you very much, Michael. I learned a lot for that. And for a guy who spends a lot of time talking to pathologists with you as well as before you came, I'm happy that I learned a lot from that. Anybody have any questions, please put them into the chat. I'm going to let you know that I'm going to give you a lot more pathology specimens. You can drag them and dip them and tap them as much as you want. I'm going to ask specifically about cytology, though. I always thought cytology was, an aspirate, a needle aspirate. You're saying that we can do that on the table, and what should we do? Take a needle and aspirate some and give it to you as well as the piece of tissue we're taking?
If you want, that is one option. Additionally, solid tissue can be dabbed or smeared on a slide in the frozen section suite and generate cytology. Our suite is not particularly well set up for cytology at this time. The better option right now would be to request an on-site assessment. Our capacity at UHN for doing that unscheduled is not stellar right now. We're understaffed, but scheduled is actually quite straightforward. Patrick actually mentioned he had done several that way, which I assume were also scheduled. And the combination of that with needle core, excisional biopsy, et cetera, can be very powerful in that even if the cytology doesn't tell you what the lesion is, it can at least tell you that it's cellular versus necrosis.
Cellular versus? What did
Necrosis.
you say?
So we had that one lesion recently. I don't know if it's the same one Patrick showed or not, but we had a lesion that was 80% necrosis at its core, and it was very likely that the core was going to pull back the necrosis preferentially. One thing to have considered in that, although I suspect Patrick knew this case far better than I, would be to do an aspirate first, figure out where cellular tumor was, and then to pass the core into that same site. Patrick, I don't know if you want to add anything to that.
The tissue we give you is small. I'm just looking at some of the questions that I have. The tissues that we give you are small. I give you big pieces because I'm in there. But the tissues you receive sometimes are very small, be it from something that Patrick gives you or after a heart transplant, we get some biopsies. And you spoke about the different stains that you can do to help us determine what these are. Once the person has a stain, say an H&E, how much is that section taken out from the rest of your sections? And can you reuse other stains in the same section given the fact that you have a small amount of tissue? Probably for the molecular stuff, it's a different story because it's a different thing. But once you stain it with one stain, how much does that remove from the amount of tissue that you actually have to make a diagnosis?
So from a practical point of view, a single stain takes about 15 to 20 microns of tissue depth. If we cut a number of stains in sequence, that is directly additive with virtually no waste. The real problem comes if the initial panel isn't sufficient. You will then have to spend another 50 to 100, frequently 200 microns in order to get back into the tissue again, at which point you can then continue ordering stains. The local practice, as preferred by our local sarcoma expert, is to not cut stains up front, which had been very popular in lung, how old am I now? 10 years ago, but has evolved because the molecular is so high priority that it's favored that you save the material for that as best as possible. So if a few stains can answer the question, save more for molecular. If you need more stains, cut as few as possible so you have as much as possible for molecular. And
from a practical point of view, the first step always when we see somebody who has an intracardiac portion of a tumor is to get a percutaneous transvenous biopsy. And I'm asked, and it's asked to us here today, is how many samples, the minimum do you need? You're going to say as many as you can. And what biopsy containers do you need to send the samples in?
Sure. Thanks, Diego. It's a great question, and thank you, RJ. From a practical point of view, in my experience with experienced operators, which I get the benefit of working with frequently, if not all the time, a typical endomyocardial biopsy of around 2 millimeters per piece, typically about 3 pieces is reasonable to work up most tumors. That said, endomyocardial biopsy, for some reason, tends to end up with less material in the end available for molecular. Part of that is I suspect the technique we're currently using in the histology lab, and I'm actually revisiting that. But there's no question that the endomyocardial biopsy, the more the better, but at the same time, it's a tumor, it's going to go badly, et cetera. So I am recommending 3 pieces of around 2 millimeters, which isn't dissimilar from the minimum requirements for transplant. Obviously, the more we get for either of them, the more certain we are.
And what about the containers he sends them in?
Oh, sorry. Yeah. In general, formalin fixed for tumor is the right thing. If you have a suspicion for hematolymphoid, it is worth sending a separate piece for flow cytometry. I will say that EM in tumors is pretty much not favored at this time. And one of the biases in the past was to send a separate piece for molecular. which is actually not valuable. You actually have to look at the H&E for the molecular to be interpreted. One thing to consider is possibly sending them in separate vials. I will say that at our institution, the resource utilization of that is usually avoided because we can take a single piece out of the block if we need to and test just that piece.
Patrick?
Favor formalin.
Yeah, thank you. I just wanted to address the question regarding the FNA first and then determine the area that has necrosis or has more vital tissue for analysis. Well, that's an approach we're using quite frequently. There's only one caveat. For FNA and then core, you need coaxial technique where you place a larger needle through which you then have to do the core biopsy, unless you navigate twice, which is always possible. So there's a bit of a challenge here because the diameter would be bigger. But even if that's possible, what I have seen, and I wanted to ask you back, if you sample FNA, I have seen not infrequently that there is a bleed, and the bleed deteriorates the core that we can harvest afterwards, unless the tumor is so large that we can re-navigate. Could you comment on this negative impact of FNA first? And the second question is, how many cores do you actually need? You talked about 1 to 2 millimeters for molecular, but would more cores from the same location overcome or mitigate that risk?
Yeah, great question. Thanks, Patrick. On the first one, you're not the first person to mention the bleeding problem to me. And I think as we've discussed, it's probably much more common in tumors relying on coronary branches for their circulation. They're getting much higher flow, et cetera, not to mention they're around this big chamber of blood thing. So I don't know is the answer. Cytology is so minimally utilized in cardiovascular tumors at all that I think it's a very valid question. Certainly that is described, as you know, in any number of other sites, and is in reality a problem. It is fascinating that it's not a problem on things like thyroid lesions, leading me to believe that visceral lesions are simply more intrinsically challenging in that regard. So it'd be interesting to have enough information. I know that the folks at Methodist are doing a slightly higher volume of cytology. We actually have someone who did her cytopathology fellowship at Methodist and has the advantage of having seen some of these things and can provide us with internal expertise. I will say most centers probably don't have a lot of people that have seen this stuff, but this is the value of training at places that have. I trained at Brigham Women's. We had seen a lot of it there. Very strong cytology group led by Ed Seavis. But you know, I'm not sure that UHN would have a robust ability to train you yet. We're working on it. And the how many cores are enough in general, we're going to have to cut into any core you send us. So I'm not sure that sending us more helps. This is one of my ongoing questions that you will hear. For every 3 pathologists that you ask, you'll get 5 answers back. The value of splitting them between blocks or not, I have not found it valuable. I find the exact same limitations between them. And I have a lower threshold for cutting something out of one block and putting it in another. So the upfront resource utilization considerations may be valuable. For any fellows who want to spend some time with us, be they surgical, interventional radiology, or pathology, this is a powerful opportunity for research. That's all.
Patrick, how many cores do you try to take when you take cores, Patrick?
Well, that's a good question. It really depends on the location. I try typically to take at least 2. I do, as you mentioned, Robert, I take photos. And the reason why I take photos is to ensure that the whole line of processing in the lab is aware of what we harvested, because we have seen at no one's individual fault that when there's necrosis, it kind of dilutes and doesn't go, doesn't reach the pathologist. So I try to take at least 2 if possible, recognizing that the complication rate goes way up the more cores you take, and there's a fine balance between. If I may add only one more question, Michael, and I wanted to hear what you think. What we have done, and again, this is anecdotal and not great experience, but maybe a potential area of research, is what is your thought about touch prep of a core inside once you harvest the core, roll over a slide and use that for cytology? And the second question is, what do you think if we have fragmented material, should we send the formalin to a cytopathologist in an attempt to harvest every cell that kind of came out of the compound and may be lost in surgical pathology?
Two really great questions. I would say that the touch prep of cores is certainly described in other settings. Given the paucity of data for us, I definitely think it's worth trying. Again, a scheduled rapid assessment would be the way to do that. Touch preps are something very familiar to the cytopathology teams. You would probably just want to warn them in advance. They're not doing an FNA, so it'll be the cytopathologist, not the technologist perhaps, but some of our technologists certainly have done touch preps. In terms of the fragmented specimen, this might be my exception to my answer to Diego. If you send that in saline, saline is a stellar specimen to send for cytology. Sarcomas have a history of not shedding cells in that setting. But if they're fragmenting, you're either dealing with something that's falling apart already, so a variation on the sarcoma, or something that's hematolymphoid or carcinoma or neuroendocrine, where it would be valuable. So I think that might be my exception, where if it's truly falling apart, send it in saline and just make sure it gets to the lab immediately, because that way we can convert whatever to formalin versus cytologic specimen. Most places, cytology and surgical pathology don't go to the same place, including our institution. So make sure you put a thing on there to, contact a pathologist, et cetera. I actually think it would be a valid use of the intraoperative consultation pathologist. I do not perform those right now, so I'm not sure my colleagues would appreciate me saying that. But I do think that tissue triage is an important part that we as a field of pathology could be more engaging in.
I think what you've just said there is very important. What can we do in the operating room to help you give us the best answer possible, both in terms of calling the pathologist before we start, having a discussion with them, having somebody else like a cytopathologist available? I didn't know that until now. And the other question is, in other words, we should book these cases at the beginning of the day instead of the end of the day. What happens if somebody comes to us on the weekend? What should we do about that? When do you call in a pathologist? When's the best, and how do you treat the specimen otherwise? So what can we do to help our patients? Because that's what we're there for. We do the operation, we do the biopsies, but you help us. And if we do it wrong, you're not going to be able to help us.
And I might quietly be frustrated. So in general, communication, I think, is the right answer.
Sure.
There's no question you will get an initial response of frustration when you're asking a question that a pathologist might not deem relevant or useful. But you can, I mean, in my case, you can always text me during the day and I can track down someone. Cytopathology actually has a separate on-call number during the day. On call, most centers, the surgical pathologist and cytopathology, are covered by the same on-call person. I will say that our model, and this is probably becoming more common, the purpose of the on-call pathologist is to identify a useful pathologist. So, for example, if it's a hepatocellular carcinoma and you call me in the middle of the night, I'm calling one of the two liver people, but I'm facilitating that for you. So you only have to know one number overnight. That's again a conversation. I know that we at UHN, and I'm sure this is true everywhere else, revisit the nature of what we can do during the day and after hours, on call, on demand, et cetera, as what is the best way to help. And I think that, ironically, I think we do more surgical frozen sections than we need to, and too few of other options, because the conversation has degraded over time. And this is over decades. So I think it would be useful to see what happens if we restart that conversation. But that requires you accepting that when we say no, that might be the best answer.
Yeah, I think that's important. I think a discussion has to happen. And especially in the past, it's different. The people's knowledge, as a person like me who's been in practice for almost 30 years, is different than the knowledge of the people who are coming in now. And unfortunately, people who are coming in now have old teachers like us, and we need to bring the pathologists into the operating room to help us to understand, and into the biopsy specimen. It's very, very important, very valuable lesson for us all. Thank you very much for that.
No problem. Thanks for giving me a chance.
I'm going to continue saying that if anybody has any questions, there have been a few questions, it's good. Put them into the chat and we'll ask the questions. I have some other questions from elsewhere as well. Our next presentation is going to be from our genital urinary group. Dr. Robert Hamilton is one of our surgeons, and Dr. McAlpine is one of our fellows in gynecologic oncology, and they're going to give us a lecture that I'm really looking forward to. I've been in practice in a couple of weeks, will be 29 years I've been on staff here, and I really started doing the interest in cardiac tumors from the urological group, the renal cell carcinomas that come up. Hey, we need somebody to push out this tumor or help us. This tumor goes into the heart, and all the other surgeons were going, oh, I don't want to do that. I'd rather do my bypass. And I said, oh, that's something I'm interested in. So I've always had a love in my heart for renal cell carcinoma, as long as it doesn't start in my kidney. And I've gotten to know all of the urologists and all the urological surgeons very well. And they're all a great, great, great group of people here. And I'm really looking forward to hearing what you have to tell us about the tumors that start in the genital urinary area and extend into the heart.
Well, thank you very much, Dr. Cusimano, and it's a real honor to be invited to speak at your cardiac tumor conference. This is an amazing resource that you've been putting together for now 6 years now. We're in our 6th year, and quite a privilege as the Division of Urology to contribute to this. You know, it's pretty rare occurrence where our tumor spaces overlap, but when it does, as we're going to talk about today, it's a pretty serious situation, and it's good that we spent some time today talking about this complex scenario so that we can do the best outcome possible for our patients. And without further ado, I'd like to introduce Dr. Kristen McAlpine, who's one of our fellows completing the Society of Urologic Oncology Fellowship with us here at the University Health Network. She's from Ottawa University. She's spending 2 years with us, and not only is she conducting research in kidney cancer and quality outcomes of surgical principles in kidney cancer, but completing her Master's of Health Sciences here at the University of Toronto. And this topic is right in her wheelhouse. And so when we heard about this topic, we thought this would be perfect for Dr. McAlpine to take the lead, and she's put the lion's share of this together. And so without further ado, Kristen, please take it away.
Thank you very much for the introduction, Dr. Hamilton, and thank you for the opportunity to present today. We'll begin with a case presentation of a 57-year-old gentleman who's seen by his family physician for blood in his urine and abdominal pain. He's healthy apart from high blood pressure, active, and works as a teacher. An ultrasound is performed, and the findings are confirmed on a CT scan of an 8-centimeter vascular right renal mass with tumor thrombus extending into the IVC. The patient is referred to a urologic oncologist for further assessment and management. Genitourinary tumors may involve the heart, although it is pretty uncommon finding. Typically, when we see genitourinary tumors that involve the heart, we're talking about kidney tumors or kidney cancers. Most commonly, we see renal cell carcinomas. About 7% of patients may have cardiac involvement, and that is largely to do with tumor thrombus that extends towards the heart. Wilms tumors, which is the most common type of kidney cancer in the pediatric population, can also involve the heart, as can angiomyolipomas, which are a benign kidney tumor. There are other types of genitourinary cancers that can involve the heart, including urothelial cell carcinoma, adrenal gland cancer, prostate cancer, and testicular cancer. But as you can see, these are very low in frequency and not something that we commonly experience with our patients. So today we're going to break our talk down into 3 sections. The first is going to be genitourinary tumors that extend to the heart. And these are the vast majority of patients that we see. And so we'll talk about the presentation, the workup, the management, and the prognosis for these patients. Next, we'll talk about genitourinary tumors that metastasize to the heart. And finally, genitourinary tumors that invade the heart. So first, we'll talk about genitourinary tumors that extend to the heart. And again, these are largely tumors with thrombus that is extended through the IVC and into the right atrium. Renal cell carcinoma is the most common type of kidney cancer in the adult population and makes up the majority of patients that we see with tumor thrombus that extends towards the atrium. Renal cell carcinoma, actually, the majority of patients are now being detected incidentally with small renal masses and are asymptomatic. However, these are not all patients, and about 4 to 10% will have larger tumors that have venous system extension, and about 1% of patients overall will have extension into the right atrium of the tumor thrombus. So unlike patients who present with a small renal mass, who are largely asymptomatic, patients who present with an IVC thrombus are, for the vast majority of these patients are symptomatic. So as you can see here, many of these patients have blood in their urine, abdominal pain, peripheral edema. Some can present with pulmonary emboli, varicoceles, claudication, Budd-Chiari syndrome, and scrotal swelling. And the minority of patients, about 15%, will present with no symptoms. When we see a new patient with a renal cell carcinoma that involves tumor thrombus, they need to be thoroughly investigated before we talk about management, whether that be surgical or systemic. First, we perform TNM staging, and for patients with a kidney tumor, that involves CT scans of the chest, abdomen, and pelvis, a bone scan, as these would be considered more advanced cases, and blood work of CBC, electrolytes, creatinine, LFTs, calcium, and the coagulation profile. With regards to actually looking at the tumor thrombus itself, several studies have shown that the most specific and sensitive test to assess the tumor thrombus is an MRI with T1 weighted images, including contrast and breath hold. And then finally, patients require an echocardiogram, and transesophageal echocardiogram is the best to look at the posterior and inferior aspects of the heart, including the right atrium. So these are performed on these patients before we consider their management. It is critical that the imaging is up to date at the time of patient's operation, because these tumors can be very dynamic and can change over a manner of days to weeks. And so if possible, imaging within 2 weeks of surgery is ideal, but imaging should not be greater than 4 weeks from their surgery because these tumors can change over time. There are two types of thrombus when a patient presents with RCC that extends into the cava towards the heart. The first is tumor thrombus. So tumor thrombus is actually the extension of the tumor into the venous system, into the IVC, and towards the atrium as well. In contrast, bland thrombus is just clot that has formed around the tumor thrombus secondary to hemostasis and coagulopathy. And it is important to determine what type of thrombus is present, as thrombosis experts will determine whether a patient needs to be on perioperative anticoagulation based on the tumor thrombus characteristics. So on imaging, tumor thrombus will enhance. It'll be contiguous with the tumor. It has the ability to expand the vessel that it's within, and it can invade the vessel wall, whereas bland thrombus will not have any of these characteristics. Tumor thrombus itself has its own staging system, which is shown here. So level 0 involves the tumor thrombus just invading into the renal vein. A level 1 thrombus extends into the IVC within 2 centimeters of the renal vein. A level 2 thrombus is beyond 2 centimeters from the renal vein, but below the hepatic veins. A level 3 thrombus is above the hepatic veins, but below the diaphragm. And a level 4 thrombus, which will be what we're talking about for the majority of today's presentation, is a thrombus that is extended above the diaphragm and into the right atrium. And so clearly these will be the cases that require cardiac surgery involvement to assist with this component of the tumor. So let's go back to our case. Our 57-year-old gentleman undergoes full staging investigations and has no metastatic disease. He also has normal cardiac function. He undergoes an MRI, which shows a mix of tumor thrombus and bland thrombus that is extended into the right atrium. And he is referred to see a multidisciplinary team of experts to plan for a large procedure, as he would like to have a surgical resection. Intraoperative management of these patients depends a lot on the level of the tumor thrombus. And again, today we're going to be talking about level 4 thrombus, which extends above the diaphragm into the right atrium. And as you can see, this requires the involvement of cardiothoracic surgery because there is the potential need for thoracotomy and open heart surgery. That being said, you also need some of the other specialists that are in the other levels, like hepatobiliary surgery, because you will need to fully mobilize the liver and expose the IVC in these operations as well. Patients will be seen by a multidisciplinary team of experts based on, given the complexity of these procedures. So usually the referral comes to the urologic oncologist first, But again, hepatobiliary is often involved in these cases for mobilization of the liver. Cardiac surgery is very important, both in terms of whether there's going to be atria, a component of the tumor thrombus in the atrium that needs to be resected, but also because of the potential need for bypass during these operations, which we'll talk about further. But cardiac surgery is integral to the management, assessment, and perioperative care of these patients. Vascular surgery may be involved if there is tumor thrombus that is extending into the IVC wall that needs to be resected and grafted. Cardiology assesses the patient's cardiac function preoperatively, and there's some discussion about if a patient's going to need to go on bypass, whether an angiogram is necessary. An anesthesiologist with advanced training in cardiac surgery is critical. These patients need intraoperative TEEs, but also they can have the need to go on bypass. They may have significant blood loss, and there may be significant changes in their hemodynamics intraoperatively. So an anesthesiologist who is comfortable with these cases is critical to be involved in the care of these patients. And finally, like we mentioned, thrombosis for perioperative anticoagulation are often involved in these patients' care as well. With regards to what's actually needed for the operation, for operative planning, transesophageal echocardiogram needs to be available, and we'll talk further about why and the benefits of having TEE intraoperatively. Although not all patients will need to go on bypass, it is a possibility, and so having that available and the patient being operated on in a center where bypass could be readily accessed is essential. And again, there may be sudden drops in the blood pressure when the IVC is clamped, or a significant amount of blood loss during these cases. And so there needs to be a plan for these intraoperative events. So whether that means banking significant blood or being ready for a massive transfusion protocol, these cases are complex, and there's a lot of planning that goes into the operative, into planning their operation. So with regards to the need for intraoperative transesophageal echocardiogram, there are several benefits to having TEE intraoperatively. First, like we've previously mentioned, these tumors are dynamic and can change over a matter of days to weeks. And so having a TEE at the start of the case can allow for updated staging. So assessment to see if the tumor has changed at all, as well as surgical planning to see if there's been a change in the extent of the tumor or the fragility of the tumor thrombus. Intraoperatively, TEE can look at the tumor fragility, the adherence to the atria, as well as after it's been removed, if there's been complete resection. And finally, with regards to hemodynamics, a TEE can allow for assessment of the patient's hemodynamics to see if there's been any changes indicative of a PE intraoperatively, whether there's been any concerns for fluid balance, as well as ventricular function at the time of the operation. My last slide before I hand it over to Dr. Hamilton is bypass is a possibility in these operations as well. Now, again, you're the experts in cardiac surgery, is the expert in bypass and the need for the timing of bypass and how to put a patient on an F pump. But typically when we think about these procedures, it's patients who need an atriotomy, or if they're going to have suprahepatic clamping of the IVC where there's not going to be any return of venous blood from the lower half of the body. Those would be patients that would be at risk for needing bypass. Benefits, depending on the type of bypass used, is it allows for a bloodless field and oxygenation of the organs. Harms, it may prolong the operating time and the patient's coagulopathy. And then the two types, venous-venous bypass versus cardiopulmonary bypass with deep hypothermic circulatory arrest. Again, that's your area of expertise. And so we work in conjunction with the cardiac surgery team around this. But we are aware that patients may need to be on bypass during these procedures.
Thanks, Dr. McAlpine. So I'll take over a little bit from here and just spend a couple minutes speaking about the actual intraoperative component, and obviously the abdominal component. As cardiac surgeons, you may not be involved, but I think it's worthwhile going through so you at least understand some of the principles, and then as we extend that into the chest, obviously there'll be more familiar with that, on the left-hand side of the screen, you'll see this particular incision was drawn here as a chevron with an extension into the chest as the sternotomy, and that's one option. If you don't know for certain that you're going to require a sternotomy, in some ways that chevron may be more advantageous. I have to say, at the University Health Network, for all of these cases, even if there's only a remotest chance of needing to go into the chest, we prefer a laparotomy so that you can just extend into an external laparotomy and access all of this through a midline. That's our preferred approach to many of our kidney tumors. And so we think of the operation in 4 components, the first being control and setup of the kidney dissection, 2 being mobilization of the liver, which we'll show you pictures of, 3 being setup and gaining control of the inferior vena cava, and then finally 4 is where you play a particular key role, which is access to the right atrium. And so this just shows step 1, and the majority of tumor thrombi in the kidney come from the right kidney. It is more rare to have the left kidney. When the left kidney is involved, it's a little bit more complicated. You have to tunnel through the mesentery of the colon and almost make the left kidney almost become like a right-sided kidney, so you have that linear access up the IVC. But nonetheless, the first step of the operation, and here on this slide we've shown a right-sided tumor, is to gain control of the right renal artery in the intra-aortocaval space, so underneath the left renal vein. The idea being you want to minimize your disruption to the right of the vena cava, because that's where your thrombus is extending from the right renal vein. And to whatever extent possible, you want to minimize your disruption of that field to avoid breaking off a thrombus and causing a massive emboli situation. So we gain control of the renal artery at the intra-aortocaval space. And it is common to actually clip the artery at that time, because by taking away the blood supply, oftentimes you can have shrinkage of your thrombus. And not only does that minimize bleeding, but it actually may allow you to put your proximal clamp lower than where you may normally put it. And if your tumor is just poking into the atrium, sometimes by taking away the blood supply, you can get just enough shrinkage of that thrombus that maybe you don't need to go into the atrium. It doesn't always work, but sometimes there are advantages to early control of the artery. So that's how we gain control of the artery. We minimize mobilization of our handling, I guess, of our kidney at that point. It's controversial, actually, whether you completely mobilize the kidney. I prefer to have the kidney totally mobilized so that when you're ready to go on the thrombus, the specimen will be able to come out. The next step is to completely mobilize the liver out of the right aspect of the upper abdomen, and so that you can have this gorgeous view of the longitudinal view of the vena cava. You can take the accessory hepatic so that you're only staying with the main, you're only keeping the main hepatic veins. And it's key to, obviously avoid clamping, not only for ischemic venous drainage of the liver, but also a huge portion of your venous return comes from the hepatic veins. And so you leave that till the end whenever possible. So once you're done mobilization of the tumor and then the liver, that's where we start our discussions with you in terms of when to do the sternotomy. And there are many cases in the literature that argue early sternotomy will make our dissection, not only of the kidney, mobilization of the liver, access to the upper aspect, suprahepatic aspect of the vena cava, way easier. And so I think if you know you're going to go into the chest, the earlier you can create the sternotomy, probably the better and more advantageous. But once you have that complete exposure, including up to the atrium, then we can start clamping our vessels, not only to the right kidney, the affected kidney, the contralateral kidney as well, gaining your occlusion of your inferior control on your vena cava and setting up control of your proximal vena cava. If you're above the hepatic veins, you obviously need to perform the Pringle maneuver on the liver to decrease your venous flow for coming back from your liver. Obviously, if you have already made your decision that we're going to go on pump for this case, that will have had to already set up and initiated before you open the vena cava. Once you open the vena cava, you need to assess the resectability and mobilization of the thrombus within the vena cava. There are times, and we didn't talk about it in today's case because I think it's a bit out of topic, but there are some predictors pre-op of whether this thrombus is actually invasive of the wall of the vena cava, and you may need to resect a portion and graft a portion of the vena cava. Once you've started to mobilize that, we work our way up to the atrium. And there's two ways, and I put this one on the left here to show that there are some times where a thrombus is just poking into the atrium. Sometimes you can pull everything down by dissecting up through the diaphragm a little bit, you can pull down and gain control from within the abdomen and resect the thrombus that way without having to make a formal incision in the pericardium and into the atrium and controlling this way. But on the right is more relevant to what we're talking about today, those classic stage level 4 thrombi, where we absolutely need your assistance to get into the atrium, visualize the thrombus, and help us with our dissection there. The options, as we've illustrated here, once we have exposure to the atrium, you can either break off the thrombus, which I think is arguably less desirable, break off the thrombus and pull out the atrial portion and then pull down the separate portion from the vena cava inferiorly, or the cardiothoracic surgeon can simply protrude the thrombus down into the abdominal portion, and then us as urologists can pull down the thrombus and completely excise the tumor in toto. And I think that, when possible, is probably preferable, certainly from a pathological standpoint. And then we close our atriotomy, our cavotomy, reperfuse our organs, make sure we have hemostasis and good tumor control. Check with your TEE to make sure that you've satisfactory, you're happy with your dissection of the thrombus, and then close. I think it's important to point out that not only as you go up in level of thrombus, obviously the prevalence of those cases goes down, so that the prevalence of level 4 thrombus is very rare. But when you are into a level 4 thrombus into the atrium, the complexity is exponentially greater. So not only operative time, you can pretty much bank on a full day case. Median time here was 11 hours. A 9-fold increase in rate of transfusion, 6-fold increase in the total amount of blood loss. So you really exponentially level up on your degree of complexity when you enter the atrium. And I think as a surgical team, you need to be prepared for that. And on that note, we thought it'd be worthwhile to put this in as a side note. This is work that's done at the University Health Network, looking at the Ontario population level data and predictors of mortality with nephrectomy associated with either renal vein or IVC thrombosis. And what the key point we wanted to point out was that when Dr. Finelli and his team analyzed the data based on volume of experience of the surgeon, and they broke it down to one case of IVC thrombus in a 10-year period versus more than one case of IVC thrombus in a 10-year period. And you can see dramatic differences in both 30-day and 90-day mortality when analyzed by surgeon volume. And so I think it's just important to point out, and it may seem obvious, but if you're a cardiac surgeon being approached by a urologist who has discovered a tumor, I think it's important to have that conversation to say, well, how many of these have we done, and should we think about optimizing the patient's chance for living, and ensure that we do this at centers that have sufficient experience in order to optimize that patient's chance of survival. And so with that, I will hand back over to Dr. McAlpine to finish the talk.
Thank you very much, Dr. Hamilton. So we're just going to talk a little bit about some of the controversial topics with regards to nephrectomy and IVC thrombectomy. The first is preoperative angioembolization of these tumors. So having interventional radiology embolize the entire kidney preoperatively. The rationale for that is that you can decrease the blood flow to the kidney and potentially have some retraction of the thrombus, like Dr. Hamilton mentioned, and potentially decreased operative time, decreased blood loss. However, there are some drawbacks. Patients can have fairly significant post-embolization syndrome after that. There's not really any change to overall survival, and it often delays the start of the OR if this is planned for the morning of the procedure. And it's felt to be not necessary for these operations. The second controversial topic is the use of IVC filters. There are risks to placing the filters, as you can imagine, alongside the tumor thrombus in the IVC preoperatively. It can be quite challenging to manage in the OR. And really, they're not recommended unless a patient is developing persistent PEs despite full anticoagulation preoperatively. With regards to prognosis of these patients, these are complex operations that are high risk, and patients have a 3 to 10% perioperative mortality rate. Many patients will have major complications, and as you can see, VTE is the most common complication, but also respiratory failure, hemorrhage, cardiac complications, including myocardial infarctions, are not uncommon. 5-year cancer-specific mortality rate, cancer-specific survival rate does depend on how you define the population, but it's around 25 to 60%. With regards to patients who present with metastatic disease, about 30 to 40% of patients who do have a thrombus that extends to the right atria will have metastatic disease. Surgery in some studies has shown to improve survival. However, we do acknowledge that this is likely very biased data, as patients who went on to the OR were likely more robust compared to those who did not receive an OR, but there is maybe some signal that patients did better. Beyond survival, surgery does help to limit symptoms and can help prevent sudden death from a massive PE for these patients. The next 2 graphs will show the prognosis based on different subgroups. So in this graph, years from nephrectomy is on the x-axis, disease-specific survival on the y-axis. And you can see that overall, about 40% cancer-specific survival at 5 years, but that it varies significantly between the metastatic patients and those that do not have metastatic disease. And in this graph, you can see that incomplete resection, the patients who had an incomplete resection did much worse than those who had a complete resection. So we're going to move on to the next portion of our talk, which is genitourinary tumors that metastasize to the heart. Now, this is very uncommon for us to see with genitourinary malignancies, but it can occur with kidney cancer, prostate cancer, and bladder cancer. And typically we see patients with cardiac metastases when they have advanced disease and either they're starting systemic therapy or they are already on systemic therapy. In this table from the study, they looked at different cardiac metastases based on their prevalence. And you can see prostate cancer, kidney cancer, and bladder cancer have made this table. When you look deeper into the table, though, they did mention that patients with renal cell carcinoma with IVC thrombus counted as endocardial metastases, which is one of the reasons that that percentage is so high. So although it is uncommon, genitourinary tumors metastasizing to the heart can happen. Here we see a metastatic bladder cancer involving the myocardium and metastatic kidney cancer involving the endocardium. This is a nice flow chart looking at the management of cardiac masses. And we look at this sometimes, although we acknowledge again that we are not the experts on cardiac masses. And so looking at these patients, they would have a malignant tumor that is secondary to another malignancy. And so typically we think of these patients requiring systemic therapy, but that's not a definite rule by any means. And we would look to the expertise of a cardiac surgeon if this is a patient who has a solitary met in the heart, as that would be your expertise for sure. Now moving on to the last portion of this talk, genitourinary tumors that invade into the heart. This is exceptionally uncommon and really only case reports that we could find on this topic. You can have adrenal cortical carcinomas, which are cancers of the adrenal gland that are extremely aggressive, that can invade through the diaphragm and into the right atrium. There's a few case reports of that. And there are some case reports of metastatic thoracic lymph nodes from testicular cancer that have invaded into the heart. Again, very uncommon, but possible. So looking back at our case, our 57-year-old gentleman with an 8-centimeter right renal cell carcinoma and grade 4 tumor thrombus. He had extensive preoperative counseling and investigations by several members of the multidisciplinary team. He opted to proceed with a multidisciplinary full-day operation and is recovering well with his incision that you can see here. In conclusion, renal cell carcinoma is the most likely genitourinary cancer to involve the heart. Nephrectomy and thrombectomy are complex and high-stakes ORs, and imaging that is up to date is critical for these operations. It is very important to note that these patients need multidisciplinary assessment and planning, and that cardiac surgery is integral in the preoperative planning, the intraoperative decision-making, and the post-operative care of these patients, as this is not necessarily our area of expertise, but these patients are complex and require physicians from all aspects to give them a successful operation. And you can expect to have intraoperative decision-making as well. Finally, cardiac mets and invasion are very rare with genitourinary cancers, but they are possible. So we'd like to say, on behalf of myself and Dr. Hamilton, thank you very much for the opportunity to present today. We would be happy to answer any questions or comments during the question and answer period. And if there's questions beyond that, please feel free to email us at your convenience as well. Thank you for your time.
Thank you very much. That was, again, outstanding. You did a fantastic job on summarizing and telling us the pertinent points of everything. I think that was a great, great lecture. And I hope that everybody learned as much as I did. And I've been dealing with these for a long time with a lot of you guys. Some of those surgeons that I started with have retired. That's how long I've been doing them. And I learned today from that. So thank you very much for that. I'm going to make a couple of comments about the surgical aspect of the whole process. You were talking about whether we open the sternum early versus late. Certainly it does help you with respect to your resection. The intraoperative transesophageal echo does tell us whether it is going into the heart or not. And we had one case here specifically, and that's when I changed my thoughts, and that's when we changed our thoughts about this, where during the dissection, the patient embolized a portion of the tumor into the lungs and had a cardiac arrest on the table. And I happened to be very close, just coincidentally happened to be close to the OR. Up until then, I used to walk in and out and say, "You ready for me yet? Ready for me yet? Ready for me yet?" And this one, I happened to be in the OR when they called me stat. There was a code blue that came over the OR system, and I ran in, and we were able to save that person. I put him on bypass very quickly, and we saved his life. And ever since then, we always open up the sternum at the beginning of the case, and I stand and watch you guys dissect as well. This is of all the tumors that we operate upon that secondarily affect the heart, into the heart, this and perhaps the gynecological tumors are the ones where we have the most collaboration of different surgical teams. That's really, really important to have a hepatobiliary expert with us when we do these tumors that go through the inferior vena cava. I think is really important. And it's an idea about if you, and talking to the people that are watching from elsewhere, if you're going to get into this field as a cardiac surgeon, as a urologic oncologist, etc., you better make sure you have a really, really good cohort of people that can help you get out of trouble. The bleeding is obviously a big thing. I mentioned it in my talk at the very beginning as a general comment that bleeding is a significant problem when other organs invade the heart. And I think part of it has to do with the magnitude of the resection that's happening. But you showed us level 3 or stage 3 versus stage 4. The magnitude of an operation in stage 3 is pretty big. And the bleeding, I think, comes in part, probably in a large part, related to the coagulopathy that occurs when we go on bypass and when we use circulatory arrest. Circulatory arrest is an integral part of this. And circulatory arrest is used not because I have to have circulatory arrest when we push the tumor down into the infradiaphragmatic portion of the vena cava. Circulatory arrest is required to reduce all of the bleeding around the operation that you need to do once I go and push it down for you. I'm going to have a one question because I don't want to take up all the time. Dr. Rogala has a comment to make, and perhaps he can do it in person. Is there any way to tell in a good way whether the tumor invades through into the wall? Because I know I've been involved in a number of them where it obviously has invaded. And would you ever use systemic therapy in those people prior to? I know we use embolization in some individuals, but what about systemic therapy prior to going to the operating room? Can you comment about that?
Yeah, it's a great question. Kristen, why don't you go first, and then I can chip on top, but it's a great question.
Yes, thank you, Dr. Cusimano. So typically, with regards to whether the thrombus actually invades into the IVC, again, MRI can help us with that a little bit. There can be some signals on the MRI. And so going into some cases, we have an idea that the thrombus does invade into the IVC. whether that be in a small percentage of the IVC or there's extensive resection. We do have some ideas going into the case usually. With regards to systemic therapy, prior to these operations, it's a bit challenging because the thrombus itself, and if there's bland thrombus around the tumor thrombus, is a threat to the patient's life and can be challenging for people to be on months of systemic therapy. I have seen some patients who have had like lymphadenopathy and potentially metastatic disease that they give almost like a litmus test of systemic therapy before the operation to see if the patient's going to do okay. But I think Dr. Hamilton will be able to comment on this. Typically, we try to get them to the OR to debulk them and to get that tumor thrombus out of there before then many patients will go on systemic therapy after as well.
Yeah, great answer, Kristen. And actually, we can tie Dr. Rogala's question into this. Interestingly, it just occurred to me. So there are some radiographic factors that we use at least below the diaphragm to get some sense of whether this is going to be invasive or not at the time of surgery. And Chris is absolutely right. The MRI is helpful. TE can help with that. But there are some factors, for example, if we look at the diameter of the ostium of the renal vein as it comes to the IVC, and of course, Dr. Rogala just came live, so he can answer this even better than me. The diameter of the IVC, these are factors that we use to glean whether when we get in there, this thing is going to have its roots into the wall of the IVC, or it's just going to be able to be plucked out. To answer the question of systemic therapy, so first let's answer Dr. Rogala's question about staging, because it matters. So technically, the level of IVC thrombus, the presence of IVC thrombus is tucked in under the T stage. And so T3 ABC correlates with our extent of thrombus. So it doesn't actually count as either a nodal or a distant metastasis. So technically, you can have a embolus all the way up to the atrium and you'll still be without node or metastatic disease. And so what that means is that a lot of the systemic therapy trials, in fact, all the systemic therapy trials did not include these types of patients in them. And not to divert on a urological tangent, but the field has changed in the last 3 years for metastatic disease. We used to think, oh, we have to go in and take out the primary tumor and then give them systemic therapy afterwards because they have this giant kidney and they'll survive better. And we have some retrospective series that tell us that that's true. New trials now point towards systemic therapy first to gain cytoreduction, and then maybe later you go in and consolidate by removing the primary tumor. But an IVC thrombus doesn't really count as that metastatic disease. And so I think we really don't know whether there's a role for giving systemic therapy to someone with just an IVC thrombus. And I agree with Kristen, there is a concern. You worry about the imminent life-threatening nature of an IVC thrombus, that if you put someone on a VEGF receptor inhibitor, that you're going to have a catastrophic event 2 weeks, 4 weeks, 2 months into their therapy. So you worry a little bit about that. So those are good questions. Hopefully we've covered it all in one answer there.
What about the smaller tumors? We're talking about the stage 4 tumors now. Would you ever use cytoreduction in the smaller tumors?
So yeah, in the setting of metastatic disease, yes. In the setting of non-metastatic disease, no, there's no role for that. And the reality is because the degree of reduction you get in the primary tumor with systemic therapy is only about 15 to 20, 25% in the trials. So you just don't get a massive involution of the primary tumor with systemic therapy. So unless there's metastatic disease, there's really no role for systemic therapy up front.
How often do you see bland thrombus, do you think? I must say that of all the tumor resections I've done and of all the tumors that come from elsewhere, urological tumors are the most common. I've never seen bland thrombus.
Yeah, and Dr. McAlpine can chip in, and even Dr. Rogala. I have trouble distinguishing bland from tumor thrombus. And I know Kristen showed that nice table and it looks great on paper, but I have trouble in reality going into the surgery going, oh yeah, this is the bland, this is the malignant. And maybe there are people with more intraoperative experience that know 100% going in, but I find it very challenging. And also, RJ, I have not personally had a case where I've had bland thrombus. I had one where the proximal propagation of thrombus was malignant. the distal propagation, almost retrograde backfilling on the cava, that was bland. But all the proximals that I've had have been malignant in nature. I don't know, Kristen, do you want to comment? And maybe Patrick, you can comment from a radiological standpoint.
Yes, so we talked a little bit about the differentiation between bland and tumor thrombus, and I have seen a couple patients, this was in Ottawa, with bland thrombus. They were advanced disease patients, and it really, the main thing that mattered was the perioperative anticoagulation that they were going to go on. Because the bland thrombus has, I believe, a higher risk of thrombosing off and causing PEs preoperatively. And so that was mostly, again, on MRI that was determined, but I think I've seen 2 or 3 with bland thrombus who then went on to full dose anticoagulation preoperatively. And then intraoperatively, I'm not sure in terms of whether there was still bland thrombus present or not. But it mattered for the thrombosis experts to determine their anticoagulation.
What I've noticed is that in the OR, and Patrick, I want you to comment about it from a radiological point of view, is that we do see portions of the tumor that are obviously alive and portions of the tumor that are obviously necrotic. And again, I've seen it, all the bland thrombus I've ever seen in the renal cells or the sarcomas, the hepatocellular stuff has always been upstream, in other words, inferior to the tumor, stuff that blocks up into it. Patrick, can you talk to us about that?
Yeah. So I can echo what Dr. Hamilton just said. I find it very challenging to give a definitive answer. If we see vascularity, we see the enhancement of the tumor, both on MRI and CT, it's easy to call. Sometimes it's equivocal, we don't know, then we err on the side of calling it a tumor, but there will be cases in which we simply can't say. And as you said, I'm very reluctant to definitively say it's only thrombus. I don't even know how the biology would actually work unless there's some sort of internal structure that holds the thrombus together, given the flow. So I would actually echo a big caution on calling it just bland thrombus. I would rather lean to a diagnosis of we don't know. And that then goes back to you, and you have to make the call whether you have all the precautionary measures or no. I hope that's a fair answer.
Yes, it is. One final question, unless somebody else wants to ask a question here, is that what about anticoagulation post-op?
Yeah, that's a great question. The pre-op question, we have very little concrete guidance on that. If you read textbooks and guidelines, they say as soon as you identify a patient with an IVC thrombus, they should be on anticoagulation up till and including their OR and thereafter. But many experts in the field who do high volume cases of this say, nah, you don't need to unless you're worried about a flapping bland thrombus. They say post-op is a different story, and we sort of adapt our guidance from other large thrombogenic tumors that we deal with. And I think generally speaking, we place these patients on prolonged anticoagulation post-op. I think you have to just make your intraoperative bleeding risk assessment guess as best you can, and maybe you hold off on full dose anticoagulation until you see that they've stabilized, and their hemoglobin stabilized. But we don't have a lot of great strong guidelines on that post-op for thrombectomies.
And are you using dabigatran or DOACs or warfarin?
Yeah, so truthfully, we sort of leave it up to the guidance of the thrombosis team. I feel like historically with cancer-based pathologies at the root of the thrombosis, they have preferred low molecular weight heparin-based up until recently, and Kristen's nodding her head. But in the last, say, 2 years, I feel like there's been a cultural change towards the DOACs. I'm sure you guys have much more experience with that than us, but that's been the general flavor. Kristen, that's your take as well?
Yeah. There's so typically these patients would fall into the category of our extended duration prophylaxis, and they'd go home with 28 days of inox. But there are some trials actually going on in urology, not just in the kidney cancer space, but the bigger all urologic oncology space, to see about exactly that, the DOACs for 28 days postoperatively versus enoxaparin, comparing bleeding and VTE risks. Just for simplicity of taking an oral medication versus an injection. But typically, I think either in Ottawa and I think here as well, patients would go on enoxaparin at this point, but DOACs are certainly what is being studied at this point as well.
And is a tumor that goes into the heart without metastatic or nodal disease enough to give a person systemic therapy post-op?
So that you've touched on another great controversial topic in urology. Up until recently, the answer was an emphatic no. We had no good evidence for that. There's been 4 adjuvant systemic therapy trials that have been done. Only one has showed a slight marginal benefit for the very advanced local stage tumors with targeted therapy. So Sutent, for example, sunitinib. Most of the field's interpretation on that is the benefit of giving a medium toxicity systemic agent to these patients post-op for a very marginal benefit in recurrence-free survival is not worth the cost to the patient, the cost to the system, the toxicity example, et cetera. So most medical oncologists, if you refer these patients to them post-op, they don't want to give because their take on the literature is the same, that it's not worth it.
Well, thank you very much for that. We could talk about this for the next hour, but everybody has to go to the washroom and have some lunch. It's been a wonderful lecture that you gave us. It's been a wonderful morning. Thank you very much for continuing to educate us. Each and every talk has been wonderful. We're going to go now for a half an hour break, and we'll come back again, and we're going to hear from the Dr. McGilvery talking to us about hepatobiliary lesions that go through the IVC. It's a different kind of an IVC tumor. It's the same sort of stuff, but a completely different pathology. Be interesting to see what he has to say to us as well. At the end, we're going to have some cases, and some of them are going to involve urological problems. So a little surprise, but we're going to discuss some cases. It'd be very interesting to see that as well. So let's hope that this afternoon is as successful as this morning, and everybody learns as much as at least I have this afternoon, this morning. Thank you very much. We'll see you all in half an hour. Welcome back from our little lunch break here, or whatever you're getting at this time of the day in your own country. It was a great morning to the meeting so far. I hope that everybody enjoys it as much as I have so far. Please, everybody ask questions in the link in the chat. It's at the bottom of the screen if you have any questions for any of our speakers. Don't let me take up all the time. This afternoon, we're going to have some lectures from different organ specialists. We heard from the urological team in the morning, and we're going to hear from general surgery for the retroperitoneal and hepatic tumors from the gynecological service. People don't often think of gynecological malignancies that are not malignancies, tumors that enter the heart, pulmonary lesions that enter the heart. And then we're going to talk a little bit about chemotherapy at the end, prior to having some case discussions and see at a multidisciplinary level how the different people would treat these particular lesions. It really is a multidisciplinary approach, as you've heard this morning, all the way from the very beginning at the diagnosis point of view to the treatment, to the postoperative care and follow-up. Okay, so without much further ado, we're going to hear from Dr. Ian McGilvery, who's one of our hepatobiliary surgeons. He's an outstanding surgeon and has an absolutely gigantic number of tumors that he's resected from the infradiaphragmatic region, the liver and retroperitoneal area, into the inferior vena cava and sometimes into the heart.
So good morning. It's really a pleasure to give this talk. Dr. Cusimano asked me to talk about how we deal with intracardiac extension of abdominal and retroperitoneal tumors, and specifically hepatic tumors, although I'm going to talk about hepatic cable, adrenal, renal, really anything that pops into the cava goes through the liver, and basal liver doesn't, then goes into the heart. This is, in broad terms, what I'm going to be dealing with. I'd like to give a couple of case examples and a couple of examples of the approaches we take with this. Really, I think that's probably the heart of all of this. I'm going to focus on in situ cold perfusion of the liver and cable clamping, because those are the cases, in my world anyway, that have cardiac extension. And usually when you're dealing with cardiac extension of an hepatic or a tumor in the cava, you're inevitably dealing with the liver. I'm going to give some general pointers, not many, just 2 slides, but general pointers about how to approach these kind of cases. I'd like to talk about how we assess what's resectable, because I think that's the heart of all of this. You know, when can you resect things? It's not, these are specialized tumors that generally are dealt with in specialized areas, specialized centers. There aren't huge numbers of any of these, so ideally you want a method where you can bring a lot of people together in one room, virtual or not, and then quickly go into conclusions. So let me just talk about some case examples of hepatic and retroperitoneal tumors that require dealing with an intracardiac component. So this is a typical sort of case that we would deal with here. This is a 60-year-old woman who presented with hepatocellular cancer. She had a normal liver, but she had this huge hepatocellular cancer that was invading involving the top half of the right lobe of the liver. Not infrequently with these things, obviously I have a selection bias, but not infrequently these things, they'll grow into the hepatic vein, they'll grow up the cava, and then they'll pop into the heart, often just the lower part of the right atrium, but if they keep growing, they can be largely asymptomatic with time, and they can get quite large. So in this case, I'm just going to pause this for a sec. So in this case, you can see that what you're dealing with is a case where you have to deal with the liver, the cava, and then the cardiac component of the extension. So inevitably, that means you're going to be clamping the cava below and above, and often you're clamping the clamp on this figures are quite right. You're actually clamping the lower atrium. And as soon as you do that, there are a couple of things you have to do. One is you have to shut flow down to the heart, so you've got to shut flow down to the liver, so you've got to clamp the liver as well. And when you start doing that, of course, the liver, although it's very tolerant, is starting to die, it's ischemic. And you have to assess whether or not the patient will tolerate the cable clamping. And if they don't, then you're faced with a situation of, well, can I fluid load them? Can I give them enough inotropes to get them through the clamp phase? Or do I need to institute some kind of bypass? And I'm going to argue that the Probably the best bypass you can do for this is a vena-vena bypass. That's our go-to move for these sort of things. Because if you institute cardiac bypass and you give a ton of anticoagulation, and anticoagulation, or at least massive anticoagulation in the face of a liver section is not a good thing. So in this case, they didn't tolerate the clamp. So we've instituted a vena-vena bypass with the cava to the right IJ, clamped the cava below and above, clamp the liver. And the idea is it will go through the liver, take the left hepatic vein, flush the liver with cold preservation solution. When we do that, the liver is preserved, basically, and then we can remove the specimen and then rebuild the cava and sew the left hepatic vein onto the side of the caval graft. And you can do that in a safe manner. The whole idea with these cases is turning a complicated situation into a reasonably straightforward one. Here's another example of a case that requires planning, but just to demonstrate that often with these cases, the planning doesn't work out as you might expect. So this is a lady in her 50s who presented actually with peripheral edema, and she presented with peripheral edema because she had the caval tumor, a Lyme's sarcoma that had started. They often start just at the junction of the cava and the right renal vein, and then it had grown up through the liver and it popped into the lower part of the heart. So this is an example of it. There's the inferior border of the tumor, and you can see how the cava is expanded. You can see actually the tumor growing into the right hepatic vein and then popping up into the lower part of the heart. So our plan with this was to do much like I showed you with the last case, was to do a liver resection and involve the cava, but in this case also took out the kidney, then flush the liver so that it's preserved with the atrium clamp and the caval clamp like before, and then reconstruct the cava and sew the hepatic vein back on. That was our plan anyway. In this case, we'd be reimplanting the middle and left hepatic vein. The problem was that when we started this case, the right hepatic vein we knew was clotted. This is the TE showing the occluded right hepatic vein. What we didn't expect is that in 2 weeks that it took us to get the patient to the OR, the middle hepatic vein and the left hepatic vein had clotted as well. So now we had this acute Budd-Chiari syndrome, and we had this sort of nasty situation where we had to think either about abandoning the whole thing or moving to an ex vivo approach where you take the whole specimen out and do everything on the backbench and hope that you can find enough acute clot that you can pull it out and free up the middle and left hepatic vein, open them up enough that you can then sew them back into a graft. In the end, that's what we went with. And so this is on the backbench. This is us removing some of the tumor from the divided middle and left hepatic vein. Opening up, in that case, the middle vein. So that's the specimen itself that you can see the tumor expanding the cava. And then on the back bench, we can divide the liver. That's the caval graft, the temporary portocaval shunt. This is us making a diamond-shaped opening in the graft. That caval graft is sewn from the lower part of the atrium to the renal aspect of the cava. This is the post and the pre-TEE with the sarcoma sitting atrium pre and the sarcoma and the atrium being free of tumor afterwards. So I'm showing that because it points out that planning is really important, but planning for all eventualities is impossible. So you have to be able to dance through these cases, and you have to have a wide armamentarium of options before you set out on this. No, just to point out that in the previous case, I'd shown you one with needing vena bypass. This was done without vena bypass, just with fluid loading and with appropriate inotropes. And here's an example where you have to have bypass. This is a hepatoma that we did a couple months ago. A large hepatoma starting in the liver that grew into the cava and then grew up into the heart, had been there for a long time, and there's a huge ball sitting in the atrium that actually kept popping into the tricuspid. There was no way that was going to slide out. So we knew we had to put this patient on bypass. This is an interesting case, actually, because I put a circle here around a really interesting part of this. You can see there's a tumor in the liver. What it's actually done is it's grown into the bile duct. This is the bile duct here. So this lady actually presented with jaundice, partly because she had a bud carry because all the hepatic veins were blocked, but also because the bile duct was blocked. So when we put a stent in, that helped, although the bilirubin never came down to normal. So in this case, we plan to do an ex vivo extended right hepatectomy with a sternotomy, midline laparotomy, bilateral horizontal extensions to give you as much exposure as possible. Initiated cardiopulmonary bypass, removed the liver, the cava, and the lower atrium, reconstructed the cava with a tube made out of bovine pericardium, did the liver resection ex vivo, and that left us with, in this case, 2 hepatic veins that were widely separated. So we brought another tube of bovine pericardium and sewed the 2 hepatic veins onto that, and then brought that tube onto the side of the cable graft. Now, the real advantage of this was that we could, once the cable graft was in place, RJ could reverse the bypass, and then the patient can be there for any length of time, because it takes hours to do the ex vivo liver resection, the hepatic vein reconstruction. And then after that, it becomes a standard sort of liver transplant with the hepatic artery and the bile duct anastomosis completed. So this is a picture of the specimen on the back bench, actually, after the resection. And you can see how the tumor has expanded the liver itself, and then it's popped into the cava, has actually invaded the wall of the cava. There's a rim of atrium around here. And this lady did struggled for a while, as you can imagine. That once the liver had decongested, if you liked, once it had shrunk back to its normal size, the amount of liver that we put back in was really quite small. So we spent about 6 weeks waiting for the liver to grow back, and then once it grew back to a decent size, we could extubate her and get her home. Hubris. So I'm bringing up this case. RJ actually sent me these pictures last night. I'm bringing up this case because you have to put your pride on a back burner with these sort of things. There are a lot of teaching points that only come with experience here. This is a case that we did shortly after I came on staff in 2006. And it's a caval sarcoma. You can see it expanding the cava here. And it had grown up past the hepatic veins and into the atrium, and we all thought, well, no biggie. We'll just put the clamps on, open the cava, remove the lower part of the cava, and pull the whole thing out of the atrium, and then rebuild the cava with this bovine pericardium graft. Now, if you look closely, you'll actually see that this is the lower part of the atrium, and it's actually reconstructed with bovine pericardium. Sorry, this graft is PTFE. Or sorry, Gore-Tex. In that time I was using Gore-Tex. And this is, but if you look at the lower part of the atrium, you can see it's reconstructed with a patch of bovine pericardium. That's because this thing didn't pull out of the atrium. So then we're left in this situation where we went on bypass quite precipitously, which is great from a cardiac standpoint, but terrible from a liver standpoint, because now the whole body was cooled except for the liver, which we'd already clamped for the exclusion portion of this, which is a bit nauseating. Fortunately, I was with a fellow who pointed out that we could quickly cannulate the portal vein, so we did that and then flush it. But just to point out again that these cases inevitably are going to be something of a dance, and planning is essential. But experience counts, and you have to put your ego on a back burner to get everything through. So now I'm going to talk about in situ cold perfusion of liver and cable clamping. I'm going to talk about that because the reasons for doing in situ cold perfusion of the liver for an hepatic tumor not infrequently involve intracardiac extension of a cardiac tumor, or a cable tumor, or an adrenal tumor, or a renal tumor. Because again, anytime you have to replace the cava, you're going to have to clamp at least the liver portion of that. You're going to have to clamp the liver to exclude blood flow to that area. And the same is true of a tumor that comes from liver and goes into the cava and or the hepatic vein and goes up into the heart. So the liver surgery gets tricky when the major vessels you want to keep are involved. So I'm saying this is true for hepatic veins, which is what the bulk of these cases are for, but it's just as true if it goes up in the hepatic vein, it goes up into the heart. And that's because if you're going to rebuild this, you're going to have to exclude the liver. So you're going to have to clamp the inflow to the liver, and you're going to have to clamp the outflow of the liver, whether that's lower atrium or cava. And as soon as you do that, the liver starts to die. The liver is now ischemic. Now, liver is actually remarkably tolerant to ischemia, to ischemic perfusion injury, but there's a limit to that. And you can probably exclude it for an hour or even longer pretty safely. The question is whether you can predict for sure that you're going to have an hour to exclude it, or whether it's going to take longer, or whether one of those disasters that I showed you before is going to happen, and whether you're going to have to dance a bit. And it just, when those things happen, it gets very stressful. So ideally, you want something that takes the stress out of it and gives you as many options as possible. So ideally, you want a technique that will maintain liver parenchymal integrity for as long as possible. So one solution to that is in situ cold perfusion of the liver, which is where you flush the liver in the abdomen and cool it down, and that gives you hours, really, of time, safety, takes the pressure valve right off. And really what we're doing here is adopting transplantation techniques for oncology and for oncologic liver resection. So the idea is that every step of those cases that I presented before, really whether it's ex vivo or whether it's in situ, is analogous to a live donor liver transplant, because there's a liver resection phase, then there's a preservation phase where you flush the liver, whether it's remaining in situ or whether it's ex vivo, where you're creating a graft, in essence. And then there's an implantation phase. And the principles of that, the principles of caval reconstruction, the principles of maintaining decent outflow for the liver, maintaining decent inflow, those are all transplantation principles. Let me just describe this in a little bit more detail because I think it's important. So in vivo hyperthermic perfusion of the liver, now I have shown here a hepatic vein tumor, or a tumor at the confluence of the 3 hepatic veins, but it could just easily be a tumor that's grown into the cava from the liver, or a tumor that's growing through the liver in the cava. And the principle of this is you put a cannula into the inflow of the liver, and almost always in the portal vein. That's how we do it. Stick a cannula into the portal vein. And through that cannula, you then flush ice-cold preservation solution. And that really quickly cools down the liver. And the outflow for that is wherever you're going to reconstruct, whether it's a hepatic vein or the cava. You can pack the liver on ice, and that cools it down even more. It gets the core temperature of the liver down. And once you've got it down below about 25 degrees, you're pretty safe for a long period of time. We've taken this out for 2 hours or more, which is really, as I say, stress relieving. And that gives you time to take your time while you're rebuilding the cava, which is important because this upper anastomosis, whether it's to the atrium or to the cava, is always awkward. And you really want to have time so you can position the hepatic vein or whatever else you're reimplanting onto the side of that graft. Now you notice in this that there are cable clamps. So why am I pointing that out? I'm pointing that out because of a strong memory that I have from fellowship. I think I was a fellow back in 2003, and one of my now partners, I wasn't actually involved in this, but I was wandering through the OR, and one of my partners, and so I watched, of course, because you do, sort of out of morbid curiosity. One of my partners had this nasty situation where the hepatic vein had ripped during a standard liver resection, and the vein had ripped and had torn the cava up under the diaphragm attachments and was going up somewhere near the atrium, although no one could see it because there was so much blood. So they got one of our world famous cardiac surgeons, and I won't say who because there's so many here, but they got one of our cardiac surgeons in, we did a sternotomy, they did a sternotomy, and then followed this strange situation where the cardiac guy kept saying, you should never clamp the cava, you should never clamp the cava, which I always found a bit odd because we have the largest liver transplant center in North America, and we clamp the cava all the time, but there's still this feeling that you shouldn't clamp the cava short of doing it in the context of a bypass. And the truth is, of course, you can clamp the cava, and with good anesthesia, most patients with good hearts will tolerate it. And if not, again, I'm going to stress this again, if they don't, then I would consider vena bypass before I would cardiac bypass because huge doses of heparin and liver section are just bad. And that points out that anesthesia is really front and center for all these cases. Anesthetic considerations are central, and they differ for each case. So for instance, if you look at an in situ cold perfusion liver or any of these cases, there are different phases here. There's the phase prior to clamping, which Stuart McCluskey, who's a good friend of mine and an excellent anesthetist, both cardiac and liver, made this slide for me. So he's calling it a paleohepatic phase because Stuart is this far off from being a classical scholar, but he means the pre-anapanic phase or the pre-clamp phase. And during that phase, when you're going through the liver, you want to keep people as dry as possible, so the liver isn't congested, and you can minimize blood loss. But then there's the anapatic phase, which is when you clamp the liver inflow and you clamp the cava. When everything is excluded, that's a totally different phase, because there, although you're still trying to keep people dry, you may yet have to fluid load them to some extent, and you've instituted a whack load of inotropes to get them through it, and or you've instituted vena bypass. And then the next phase is when you take the clamps off, which is not small. I mean, of course, cardiac surgeons will be very used to taking the clamps off for the heart. We have similar sort of considerations when you take the clamps off and you're now releasing all of this acidic fluid from the liver into the circulation, because the first thing it hits is the heart, of course. So as Stu would say, talk to your anesthetist and prepare. And there are lots of things to do before any of these cases start. And this is another slide that Stu gave me. This is a couple of years ago. This is pre-COVID, so I think I weighed about 60 pounds more than I do now. But this is me smiling into the OR, asking Stu why it's taking so long. But it's taking so long because he had to put in IVs, because he had an art line in the hand, because defib pads, testing, maybe another art line somewhere else, central lines. And this is a central line in the right IJ, which is where people tend to go. But I would generally recommend that if you're going to have a combined case with a cardiac tumor, you should put the central line in the left IJ in case you have to go and bypass and need to cannulate the right IJ for vena bypass. I'm talking specifically. The level 1 warmer, and then of course the inotropes. So we sort of go back and forth, inotropes and other additional medication. We tend to go back and forth on tranexamic acid, but certainly in any of these cases, vasopressin is a good thing to consider, partly for its vasoconstrictive aspect, but also because it decreases flow to the liver, which will limit blood loss from the liver and levofed. And as Stu would point out, the key with these sort of things is testing. You're not going to know if someone is going to tolerate a cable clamp until you test it. There's no rush to this. You want to set these things up so that you're not doing this under pressure. So we usually test the cava early, so we get some sense of whether or not somebody will tolerate cable clamping. Go through the liver, as I say, under minimal fluid loading conditions, keeping the CVP as low as you can, keeping the urine output as low as you can. And then if they really don't tolerate clamping, when you get near the point that you're really committed, then vena bypass is a good option. And what we usually do is put a cannula in the cava, because it's right there. You can just put a maquette, curve maquette straight into it, pop it in, and then one in the another maquette in the right IJ, and then use an ECMO machine to keep it circulating. And that will get you through a lot. So another slide from Stuart to point out anesthetic considerations, that when the clamps are on and the liver is excluded, you're anapatic, basically. And a good way to monitor how the heart's doing, how everything else is doing, is a TEE. Fluid management. So I've been talking about fluid loading, but which is maybe the surgical approach to it. Keep everyone dry up to the point they need to put the clamps on. When you put the clamps on, fluid load. Stuart has a more nuanced, subtle approach to that. He watches the urine output and tries to keep the fluid loading as low as possible, because when you take the clamps off, it's going to go into circulation. The liver is going to get congested, which is bad. So he aims to keep people as dry as possible. watches the coagulation carefully with rotems, routine rotems, and asks a lot, how the patient is doing from a coagulation standpoint. And inotropes, as I say, generally we tend to focus on vasopressin and levofed. And again, if these things aren't tolerated, if you can't get somebody through this, then vena bypass is a good thing to consider before you put somebody on cardiac bypass. Before you clamp, we always anticoagulate. If it's just a cable reconstruction and a atrial, lower atrial reconstruction, where we may or may not have done a sternotomy, but we're just looking at the lower atrium, then we don't do an ACT. I just give 5,000 or thereabouts units of heparin, because I'm not trying to over anticoagulate, because I really want to limit that for the liver. But if you do go on bypass, of course, you do have to do an ACT. And of course, if you go into, if you have to go on vena bypass, then we do aim for a initial ACT of about 300. And if you have to go on cardiac bypass, then of course you all know that much better than I. Just to point out, I was saying that, the considerations when you remove the clamps from the liver, there are considerations, just there are considerations when you remove the clamps from the heart and when you reverse that bypass. The principal one being that, whatever is built up in the liver is going to hit the heart, and it's going to hit the systemic circulation. It's going to hit the heart first. And that's going to be a combination of cold preservation solution if you haven't flushed the liver properly, whatever acid and other garbage is sitting in the liver, and it can definitely hit the heart and the systemic circulation pretty hard. So rather than just releasing the clamps quickly, usually we'll release the portal vein clamp especially slowly, and watch the temperature on the PA line just to keep it from going up too fast. It's a transplant. It's actually a living donor transplant trick, but it works especially well for these kind of cases. And to follow up on all this, so we tend to think of surgery as surgeons, but anesthesia is just as important. And truthfully, it's not just anesthesia. I mean, surgery is a team in these kind of cases. In particular, point out that this is really a team approach, and if you're going to get through it, then you need a good team. It's not just anesthesia, maybe the anesthetist and the fellow, but it's the OR nurses, scrubs, circulating, maybe a few trainees, residents, fellows, X-ray staff, porters, and then of course everyone else, all the ICU staff and everyone who's involved in the post-operative care. So it's a large team that gets these people through. And that's an important consideration, because everyone's going to be looking at these cases slightly differently. So I use this slide a lot, because one of the things I do is, or one of my hobbies, if you like, or passions, depending how you look at it, is video-based surgical education. And all of that has to do with interpretation. How do you interpret an image, or how do you interpret a case? So this is an example of a bunch of people staring at a screen prior to a case. The screen has a CT on it of the case that we're going to do. But, everyone in that room, although they're staring at the same picture, is going to be interpreting it differently. There's the staff involved, the fellow, senior resident, junior resident, staff radiologist, someone else, and all those people are going to be looking at that picture, and they're all going to see something totally different. The same is true of these sort of cases that I'm talking about, that we're talking about, of hepatic cable cases that are starting the abdomen and going up into the heart. Everyone has a different conception of, first of all, what that means, second of all, what the issues are, and third of what you're going to do. So really, ideally, what you'd like to do is get everyone on the same page. And one way to do that is to make a page, is to create a script. This is something we've been doing for the last number of years. And it basically is just me or whoever's doing the case sitting down and saying, okay, this is what we need. Here's all the equipment that we need. Here's some things that I think anesthesia should think about. And then here is a step-by-step description of the case, at least as I'm visualizing it. And it's a very useful exercise, because it lets you think about what could go wrong. It lets you think about who you would need in that room if it does go wrong. It allows you to work your way through the whole thing, and then you give that script to everyone else in the room, the nurses, the anesthetists, fellows, residents, everyone. And then everyone is now much closer together when it comes to the interpretation of what is going to happen in the case. And it really changes the whole case. I started doing this when we created the Toronto Video Atlas of Surgery, because we were trying to think of ways that we could efficiently record films, but which is telling a story. And so you wanted to be able to make sure that you captured that story, but it's actually a really useful tool for getting the whole team on the same page about a complicated case. And it works. This is a slide I've used a lot about a 24-hour case that we had. We said it was going to take 24 hours. It took 24 hours. There's 44 steps. We went through all of them in sequence, actually in order, which is unusual, and it worked. And it got everyone through it, and the patient through it, and it was as efficient as possible. I think the single most important step is usually the last step, step 44, which is now we have in every script. Step 44 is when you close, and then you celebrate. So how do these people do? How do these cases do? How do people with an in situ cold perfusion, liver and or cardiac extension and or bypass actually do? Because these are big cases. There aren't that many of them done around the world. There have been a few reviews done, but even when you pull everyone together, you're looking at 200, 300 cases. So if you want to become an expert at something, I would say to the trainees, this is not a bad thing to become an expert at, because you only have to do a handful of cases or read about them, and there you are. You're an expert. There just aren't that many that are done. In Toronto, we reviewed our experience recently. If you look from 2006 to 2018, at over 12-year span, we had 56 cases, 52 were in situ, 4 ex vivo liver resections, with total vascular extrusion, liver, vascular reconstruction, whether it's portal vein, hepatic artery, cava, hepatic veins. They all had vascular reconstruction of some form. A good fraction of them, probably about a quarter, had an intracardiac extension, which is the reason that we had to do this in the first place. Had to do the in situ, I mean. What are these cases? About a third are metastatic colon cancer. About a quarter are intrahepatic cholangiocarcinomas. The rest are things like sarcomas, hepatomas, and adrenal cancers, or for the most part, these are not. In fact, none of these I don't think are. No, that's wrong. There are one renal cell cancer. And I think there's another lecture talking about renal cells and such that go up into the heart, which is a different approach by and large than what I'm talking about. Metastatic colon cancer can grow into a vein, can grow around a vein, can go into the heart, but for the most part, the ones that have intracardiac extension are things like cholangiocarcinomas, sarcomas, and hepatomas, I've shown you before. They're long cases, 10 hours or so. Usually you're clamping the liver for about an hour. It ranges, though, obviously, from half an hour to 2 or 2.5. They're lengthy. You can expect blood loss, 3.7 blood units, liters, or general, 6.3 units transfused on average. And there's a bit of a learning curve. So if you look at it from how we did in the first half and how you do in the next half, people, as the experience grows in the center, not just in the surgical hands, the stay in the ICU shortens, the stay in the step down shortens, and the hospital stays tends to shorten as well. Mortality, 5 of 43 for the patients we had long-term follow-up. This is in 2006, 2016, so about 12% overall, which is significant, obviously, in these days of limiting mortality. And they're morbid, having grade 3 or higher, about 51%. So you can expect something is likely to go wrong post-operatively in general. It's just the nature of the beast with these, and the mortality is real. And generally the mortality with these reflects the liver more than anything else. I mean, if the liver kicks in and does well, then generally the patient will kick in and do well. But if the liver doesn't do well, and it can be really hard to predict why they won't. Sometimes the liver just won't. Then patients don't do well. And in a handful of cases, I've had bad coagulation problems where the hepatic veins just clotted off, and There was one hepatoma case where that was the case, and one metastatic colon cancer where that was the case, and they came out of the blue, and it was just almost malignant clotting, and that's disastrous. Okay, how do they do in the long term? Well, the overall survival for these kind of patients at 5 years is about 40%. Disease-free survival is less, so obviously about 33%. It obviously depends on the disease. So metastatic colon cancer actually does remarkably well. So the 5-year survival after this sort of case for metastatic colon cancer is near 60%. Disease-free survival is less, 45, 50%. But these are obviously highly selected patients. But the 5-year survival is significant. Less so for things like intrahepatic cholangiocarcinomas, where the 3-year survival is only about 30%. Which points out that once you get over that initial drop in the curve, which is around the time of surgery, everything else depends on the cancer. And really, very much biology trumps everything else. You can do weird and wonderful things, but in the end, biology is going to dictate how people do. I'm going to talk about some general pointers. So, in terms of the workup, so if you have a cancer that's growing up into the heart, whatever it's starting from, whether it's a cholangiocarcinoma, or whether it's a cholangio or metastatic colon cancer or hepatoma, they all have to have a thorough staging radiological workup. They all need a CT of the abdomen and pelvis, 3-stage, because you're looking at the liver as much as anything else. So, hepatic and arterial and venous phases. An MRI is quite useful to look at the bile ducts because the bile ducts can be exceptionally variable. And the last thing you need is a bile duct injury sitting over a, biologic or a, artificial graft leaking. That's another terrible complication. CT chest, obviously, and some visualization of the heart. PET scan, I'm not so adamant about because if you get everything else above it, you're going to encompass most things. And a biopsy, I think if you're going to do these things, almost everyone gets a biopsy to let you know what you're dealing with and to give you the option of instituting neoadjuvant therapy. Patient needs a thorough workup, obviously, as well. I mean, you will know that better than I, because at that point you're dealing with, how will this person do from a heart standpoint, from a cardiac standpoint, and what will they do when I stress the heart, because I've limited the venous return or put them on vena bypass. I'm just going to say that constitutional symptoms are bad. If you have a cancer with, and the patient's got constitutional symptoms, bad weight loss, bad fatigue, anorectic, probably that's a patient you shouldn't be touching. If it's a perineoplastic, that's another issue. If they're symptomatic from, some of these sarcomas have some pretty odd perineoplastics, and if you're operating for that, that's one thing, but constitutional symptoms are bad. And neoadjuvant therapy is something that should be considered often, I think, because I think it's a test of time. It gives an idea of how that tumor and how the patient's going to do with time, which is a question of, what's the biology of the disease, and can I actually help with this wild and wonderful operation? Sarcomas we tend to put on chemo, even though the chemo doesn't, the response rate to sarcomas on chemo is really pretty low. But it gives you time to see whether you're going to get mets popping up here, there, and everywhere. Radiation we tend to do. However, if you've got a large tumor and you've got a large spillover in the liver, I'd avoid it because, again, how that patient does is going to depend on how the liver does. And if you're killing the liver with the radiation, you shouldn't. Metastatic colon cancer, they almost all get chemotherapy, and I think it's a very good idea because the survival really is dependent on two things, the surgery and the chemo. And every other creature, for the most part, probably chemo is not a bad idea as well. Not because it makes the operation any easier, it usually doesn't, but because it gives you time to assess how this person is going to do with time. And I think the notion that mets are going to suddenly show up that weren't there before, well, when you meet the patient, I think to a large extent the die is cast. They either have mets or they don't. You just don't see them, or you do. In terms of the case, planning, I think, is everything. Good anesthesia, good crosstalk is essential. Your anesthetic team has to have a good experience with liver, and good experience with cardiac. I think you need to find people you work well with. This is not a time where you want to have people come in that you don't like and can't work with. You need a good team. When it comes to a team, you need some way of getting people on the same page, and I think a script is something to consider. It sounds silly, but it doesn't sound silly, but it sounds self-evident, but we don't do this sort of thing enough. So I think writing a script can be very useful. Cable clamping, despite my fellow experience, is tolerated in many patients with or without collaterals, with or without venous collaterals. If it's not, then I consider venous bypass first before cardiac bypass. Because again, massive doses of heparin association with liver resection are not bad. When I started off, I had a few cases of people who died from just profuse bleeding, at sites distant from where we were operating on, because we were putting them on bypass and giving massive doses of anticoagulation. Some intra-abdominal cable tumors slip out of the atrium, some don't, like that disaster case I showed you earlier. So you need to plan for both, and you need to think, okay, well, if I've got everything clamped, is everything going to be, and I go on bypass, is everything going to be protected, like specifically the liver, which you may have clamped off before? And I think it's worth pointing out, we started off doing these cases, I just in everyone, now we don't, because a large portion of the atrium can actually be pulled in the abdomen if you just keep creeping up on it. And you can clamp a good part of the atrium, providing you spare the coronary sinus. So often a sternotomy is not necessary, but I think you should have a low threshold for it, especially when you're starting off with these cases, because you want the best exposure possible. And that brings me to the last point, which is how do you determine what is resectable and what isn't? Because again, these are highly specialized kinds of cases. And some people will look at this and say, well, no way. And other people will look at that and say, well, that looks, interesting. And ideally, what you want is to be able to bring people together in the same room and have them all looking at things in the same way. And this is another hobby. I think virtual reality is one way of doing this. So I'm just showing this because I think it's kind of a fun video. But we and other people are developing tools where you can take the CT or the MRI and create a reconstruction model, and then manipulate that in a virtual reality space, and then develop these tools where you can, take these planes through in a coronal, axial, sagittal way and look at the intersection of all these planes and get a really good idea of what the anatomy is like. Here's an example. This is one of our previous fellows. That was a baby skull because it was kind of entertaining, but this is more of a case that would be relevant to this discussion. So this is what he is seeing on the computer screen, and these are kind of some of the models that we're working with, where you can take the CT, which is now a VR model, and make it bigger, make it smaller, change the axis, rotate it around, and then start manipulating the field of view, sagittal, coronal, axial. You can really have a good look at the intersection of all these different anatomical planes. And then you can start highlighting things. You can start highlighting the venous phase, the arterial phase, really get a good idea of how the vessels are interacting with the tumor. He's just doing this for himself, so he's in the room, he's doing it for himself, but you don't have to. The neat thing about VR is you don't have to be in anywhere, really. You can be sitting in your office, you can be sitting at home, and everyone can be in the same, seeing the same thing, manipulating the same thing, and you can develop these tools where you can take a pointer, for instance, and put it right on the thing you're looking at, so everyone can exactly what you're looking at. So we've actually done that, across the ocean. This is pre-COVID, obviously. You could go across the ocean. So this is a fellow of mine that's sitting in my office, which is why it's so messy. Another fellow sitting in Dublin, Ireland, and they're discussing the same case, which you can see on the screen behind the fellow in Ireland. They're both seeing the same thing, and my fellow currently is manipulating the model, which is a sarcoma that started in ovary and grew up into the cava and then through the heart and blocked the hepatic veins and grew up into the heart. And they're talking about these points, and they can use these instruments, pick up an instrument, exchange the instruments so we can point out individual things, ask each other different things about it. Plan, really, you see what I mean? So they're across an ocean, but they are discussing this actually in front of an audience in Dublin. But you can have as many people in the virtual world as you like, and here they are shifting models, looking at different things. So it's, I think, it'll be a very useful way of bringing people together so that with these weird but rare cases, you can bring expertise to bear really quite quickly to answer, whether you should resect it, because often that's really the question. Not can you, but should you? So just quickly, some conclusions. Tales from Down Under, dealing with intracardiac extension of hepatic and retrocranial tumors. So often you have to deal with the liver, whether you're just excluding it, whether you're resecting it. And those bring up combined surgical anesthesia considerations. Again, I think biology trumps everything else. You can do amazing things from surgery, but ultimately, once you get through that first curve, survival is dictated by the disease. Careful planning is absolutely critical, and I think we should all be discussing cases more often in the same place. And I think virtual reality is one way to do that. It's here, and the word for COVID, it might even be more pronounced, but hopefully COVID will end, and then we can all start doing things again. I'm going to stop there, and wish you all a very good day.
Thanks very much, Ian, for a very, very comprehensive discussion. This underscores as well how important it is to be team players and everything. And even though we're all wanting COVID to end, and it's important that it does end, sometimes a disaster brings new venues into our way and new ways of treating things, and the collaboration is around the world. This is a really good example of where, as I said, in the tumor database world, we need to be able to identify areas of excellence. And we're very lucky here in Canada and in Toronto and in University Health Network, Toronto General Hospital, to have people like Ian and Patrick Regala and people like that available to us so we can do these amazing, amazing operations. Thank you very much for helping us. We're going to move on for the next lecture because nobody's asking any questions. We're going to move on now to the gynecological world. Dr. Sabrina Piedmonte here is one of our fellows in the gynecological oncology, and she's going to give us a lecture about gynecological tumors that enter the heart. I've personally been involved with or seen about 3 or 4 of them in my life. They're very uncommon, but when they do happen, they happen, and we need to know, and you as practitioners who have a case of a gynecologic tumor that enters in the heart, what should you do? And we'll find out now about that. Dr. Piedmonte, welcome, and thank you very much for speaking to us.
Thank you to the organizers of the annual virtual cardiac conference for allowing me to present our talk today, which is gynecologic tumors involving the heart. And I prepared this with my supervisor, Dr. Bernardini. I'm a fellow in gynae oncology. I have no conflict of interest to disclose. So we'll go through the common gynecologic cancers and our associations with metastasis to the heart. So we'll go through cervical cancer, endometrial cancer, intravenous leiomyomatosis, endometrial stromal sarcoma, and ovarian cancers, presenting several cases for each one. And so the first case is a 52-year-old female, G2, P1. She had a past medical history of a cerebral infarct at 48 years old and now presents with shortness of breath, lower extremity edema, thrombocytopenia, and a high LDH. So upon investigation, she was found on transthoracic echo and CT on admission to have a 40 millimeter large mobile mass in the right atrium, which are identified by the arrows here. She underwent an emergency cardiac surgery to reduce the risk of pulmonary embolism and tricuspid valve obstruction. The large tumor was found attached to the right atrial wall between the IVC and the coronary sinus and was excised with clear margins. Here's the final pathology specimen, and we can see the gross specimen and the histology, and the final diagnosis from the specimen was a squamous cell carcinoma, metastasis of an unknown primary tumor. So patient went on to receive further investigations and was found on MRI to have a 1.8 centimeter tumor in the cervix. She had a CT preoperatively, but of course that didn't pick up the tumor, as CT is not a sensitive imaging modality for cervical tumors. So that was missed preoperatively. And then this is a speculum examination of the cervix, and we see here at 7 o'clock the area where the tumor would have been. That was biopsied and revealed a cervical squamous carcinoma. So due to the metastasis to the heart, the patient is now a FIGO stage 4B. So the outcome, the patient underwent primary treatment with chemoradiation. There was no mention of whether she received systemic chemotherapy, which would have been thought to be given for distant metastasis. At 1 year follow-up, she had no recurrence. And this highlights a rare case of an isolated cardiac metastasis of an otherwise stage 1B cervical cancer. The differential diagnosis for the cardiac mass on presentation could have been one, a metastasis from a cervical carcinoma, but at the time the patient wasn't known to present with any symptoms, no vaginal bleeding, no abdominal pain, so it was not in the differential at the time. Other differential diagnoses include atrial myxomas, a thrombus, a brown fat mediastinal node, or a variable uptake in a normal heart. So the incidence of cervical cancer metastasis to the heart is 1.2%, and this is based on autopsy specimens. The location is most commonly found in the pericardium, and then followed by myocardium in 30% of the time, and then the endocardium for 6% of the cases. And very infrequently, formation of an intraventricular tumor is found. Most commonly affects the right heart. And the median age of diagnosis is 49 years old based on combination of case reports. Most of them are diagnosed in stage 2 or higher, and the median interval time from diagnosis to cervical cancer to cardiac metastasis is 10 months. From a review of the literature based on a collection of case reports and case series, we can see that when cervical cancer metastasizes to the heart, it's a very poor prognosis, and thus the median survival based on these case reports is between 1 and 13 months. Now, endometrial cancer is the most common gynecologic malignancy. However, only 2 to 4% of them are diagnosed in stage 4. The most common sites of distant metastasis are the lungs, followed by the liver, brain, and bone being other common sites. In terms of cardiac metastasis, it's only limited to very few case reports, which I've summarized in this table. So for only one patient, the cardiac metastasis was found at the time of presentation of her endometrial cancer. She had right heart failure at diagnosis and was found to have a large mobile mass involving 80% of the right ventricle. She underwent primary surgery for the endometrial cancer, lymph node dissection, and then for the cardiac tumor, she didn't have surgery. She had a cardiac radiation followed by cisplatin and calyx for a year, and she had no evidence of disease at 6.8 years. The other 4 case reports that I found were all diagnosed after the primary surgery for endometrial cancer. All were found with a mass in the heart, and all had very different treatments. So one patient had no treatment and died 17 days later. And then there was a combination of chemotherapy, palliative radiation, and hormonal therapy, and all patients died within a very short time span. Here's another case of a 56-year-old female who was admitted with exertional angina and dyspnea lasting 3 days. Her medical history included hypertension and metastatic leiomyosarcoma, and she underwent primary surgery and radiation therapy 7 years prior. When she presented, her examination showed a grade 4 pansystolic murmur at the apex and a 3 by 3 centimeter mass in the right lower quadrant. On transthoracic echo, she had severe mitral regurgitation, a 6 by 7 centimeter mass compressing the left ventricle, and the images are found here, and this was her EKG on presentation. And the final diagnosis for this patient was a giant left ventricular metastasis of a uterine leiomyosarcoma mimicking acute coronary syndrome. So uterine leiomyosarcomas are aggressive smooth muscle tumors. They represent 1% of all genital tract cancers and correspond to 3 to 7% of all uterine cancers. The mainstay of treatment is surgery. However, it harbors a very poor prognosis. The 5-year survival is between 18.8% and 65% across all stages. Next, we present a case from our site, which is a patient who at the time of presentation was in her 50s, and in May 2012 was found to have a tumor invading the heart and into the pulmonary artery. 7 years prior to presentation, she underwent a hysterectomy for a benign fibroid, and unclear if at the time, based on the notes in the chart, whether at that time the tumor was already invading the iliac vessels. However, on presentation in 2012, her MRI showed a right adnexal mass, a tumor versus a thrombus in the gonadal vein extending up to the IVC and into the right lobe, into the right atria and into the right pulmonary arteries. The plan was a multidisciplinary plan for surgery between vascular surgery, cardiac surgery, and gynecologic oncology. So in June 2012, she underwent the following procedure. She had a midline laparotomy and a median sternotomy. Mass was in the right lower quadrant, involving the entire gonadal vein, extending to the IVC, the heart atria, and into the pulmonary arteries. In the surgical procedure, the right colon was dissected medially. The mass was adherent to the right pelvic sidewall peritoneum, and the ureter was identified, dissected from the gonadal vein, and ultimately dissected off. The mass was dissected off the colon mesentery, and then the only attachment of the mass was to the IVC. And then, so that was the pelvic part and resection of the mass in the gonadal veins to the IVC. And just to clarify as well, the mass was on the right side in the pelvis. So once the pelvic portion was done, the cardiac surgeons put a non-plegid monofilament suture into the ascending aorta and into the right atrium, and then the cannula was placed into the superior vena cava. An echo was performed at the time and showed that the tumor was very mobile within the right atrium, and therefore a cannula was not placed in the right atrium. The tumor was removed and the patient was off bypass, and the overall time of bypass was 5 minutes. Hemostasis was obtained, the protamine was reversed, and the pericardial sac was closed after placing 1 pericardial and 1 mediastinal tube. So overall, the tumor was, this was the image of the pelvic tumor, and the tumor was removed, as we can see in the central image, in a single piece. And they also noted that there were evidence of tumor fragments in the pulmonary vessels, as seen on CT, and those were completely resected as well. And we can see here a final picture of the final dissection, which was complete, and all tumor was removed. Following this procedure, how the patient evolved was initially, she always had lung nodules, and over the course of her disease illness, these nodules progressed in size. However, in order to achieve treatment, complete resolution and complete treatment of these nodules, she would require a right lung transplant for resection, which was deemed very morbid, and also the patient did not agree to that. So she was followed for those lung lesions over time. In December 2012, so 3 months after the initial surgery, she had a sternal infection requiring sternectomy with pectoral muscle flaps. In 2016, she had a recurrence of the pelvic mass, which was 3 centimeters and was asymptomatic at the time. And given the fact that she had disease again in the lungs, nothing was done at the time, and she continued to be followed. In 2018, there was a growth of the pelvic mass to 4 centimeters. Again, she was asymptomatic, and there was discussion of giving her fibrostal, which is a progesterone modulator that we commonly give in gynecology to patients who have benign fibroids. And at the time, her disease was found to be a leiomyomatosis, so rather benign, although aggressive course, but not malignant. In 2019, there was a plan to remove the cardiac lesions that she had along with the lung nodules that were followed. However, the patient declined. And the plan was to undergo cardiac catheterization and resection of the right ventricular outflow tract and pulmonary mass, that the patient did not agree. And then in September 2020, in June 2020, there was an increase in the size of the pelvic mass, causing pain. And however, for the lungs, the only option was a lung transplant. And so preoperatively, because she started to have pain in the pelvis, the decision was made to remove the mass in the pelvis. However, the safety of the procedure, given her lung mass and her cardiac mass, there was a discussion whether we can resect the pelvic mass. Therefore, preoperatively, she had a transthoracic echo, and there was no gradient across the tumor, so it was deemed safe to proceed with a surgical procedure in the pelvis. And I was involved in this case with Dr. Bernardini. So on September 12, 2020, she underwent a resection of the pelvic mass, and the mass was in the peritoneum, originating from the stump of the infundibulopelvic ligament. We dissected laterally to separate the mass of the external iliac vessels, as well as the psoas mass. Immediately, the sigmoid was adherent to the mass. However, we were able to identify the plane and successfully resect the mass. And of note, during the procedure, the patient had a intraoperative cardiac echo, transthoracic echo, which was normal throughout the procedure. The pathology revealed a sarcoma with myogenic differentiation. Here is another case from our center as well. It was a 42-year-old female who had a previous hysterectomy for a leiomyoma. She presents with a left adnexal mass and IVC thrombus. The CT, however, was reviewed at our center, and it revealed intravenous leiomyomatosis with extension to the left gonadal vein, left renal vein, IVC, and hepatic vein up to the right atrium. So she underwent surgery. She underwent a left oophorectomy, left gonadal vein resection, right hepatectomy, infrahepatic and retrohepatic vena cava resection and reconstruction, and reimplantation of the left and middle hepatic vein in September 2019. Postoperatively, she developed partial occlusion of the IVC graft and intra-abdominal collection. Here is a picture of the specimen, and the pathology showed IV leiomyomatosis, and the outcome was no residual disease. So the previous two cases were of intravenous leiomyomatosis with cardiac metastasis. So although rare and histologically benign, you can see that the course is a biologically aggressive tumor, although the histology is non-malignant. There are two theories as to where the leiomyomatosis originates. So it's either thought to be a uterine leiomyoma, which then extends, or begins in the venous walls of the uterine veins and grows within the venous channels without necessarily invading them. The mainstay of treatment is complete surgical resection, and that is the key to preventing recurrence. Based on a literature review, there was a literature review that summarized 194 cases from 1974 to September 2012, and they determined that the most common age is in the fifth decade, and the mean age is 50 years old. Most of the patients in their review had undergone a previous hysterectomy, myomectomy, or had coexisting uterine leiomyomas when admitted. Based on the table that we can see on the right side, the most common presentations were dyspnea, syncope, or edema in the lower extremities, and the most common routes of extensions were the iliac veins, ovarian veins, or renal veins. Usually on preoperative examination, a transthoracic echo, CT, and MRI are usually useful in preoperative diagnosis and surgical management. So based on this review of these 194 cases, they performed the survival analysis and compared patients who had complete versus incomplete resection. And you can see here there's a significant difference in PFS in those patients that were not completely resected, and their hazard ratio was 0.029 as compared to the overall survival, which there's a smaller gap between the two curves, but still a significant difference in overall survival. In patients who are incompletely resected, there is a possibility to give adjuvant hormonal treatments such as tamoxifen or Megace, and they found that there was no difference in survival with those that had anti-estrogen therapy versus those without anti-estrogen therapy. The differential diagnosis, again, for these cardiac masses include a right atrial myxoma, a thrombus in transit, a renal cell carcinoma, a Wilms tumor, intracardiac leiomyomatosis, benign metastasizing leiomyomas, and metastatic cardiac tumors. In fact, 30% of the patients in this case series report, review of the literature, found that 30% of patients were misdiagnosed preoperatively as having a right atrial myxomas. So the surgical approach to resection of intravenous cardiac leiomyomatosis is the incision is a combined thoracic and abdominal incision. The right atrium is open to reveal the intracardiac leiomyoma. The IVC is incised to reveal the IV leiomyoma with cardio bypass support. After separating the site of the intracardiac or intravascular adhesions under full control of both sides of the tumor, the intravenous cardiac leiomyoma the way it's extracted depends on the morphology of the tumor. So the extraction is upward. It was upward in 17 out of 59 of the cases in the literature review. And the upward resection is if there is intracardiac inflation only, or downward from the venotomy if there is no inflation or adhesion. Segmental resection was done in 20 out of 59 of the cases presented, through which the tumor segments can be resected from the atriotomy and the venotomy, and can also be considered if multiple inflation or adhesions exist. Complete resection of the intravascular and extravascular portions of the tumor is mandatory to relieve symptoms and prevent recurrence. A single stage or two-stage procedure with cardiopulmonary bypass can be performed and have been used for resection of the tumors depending on the lesion and depending on the surgical team planning. The advantages of a one-stage operation is that it decreases the risk of tumor embolism, tumor progression, and hemodynamic complications in the interval between surgical cases and avoids the need for a second operation. When there is invasion of the vena cava wall, there is partial or complete resection of the vein wall, and subsequent reconstruction may be necessary. In order to obtain vascular control, temporary occlusion of the renal veins, gonadal veins, contralateral iliac vein, and if necessary, a Pringle maneuver can be sufficient. And alternatively, one can put the patient under hypothermic circulatory arrest. In a surgical approach without a sternotomy, this could be an option that can be done by resecting the leiomyoma from the point of attachment in the abdominal portion of the IVC. The patient is positioned for an anterolateral approach and can identify the IVC. We can obtain vascular control with a vessel loop superiorly and a vascular clamp inferiorly to the tumor and extracted with an ellipse of the IVC. The next case is a case of a 61-year-old female with a large tumoral infiltration extending from the pelvis through the IVC into the right atrium, protruding into the right ventricle and to the right ventricular outflow tract. 10 years prior, she had a low-grade endometrial stromal sarcoma treated with hysterectomy and followed by hormonal and radiation therapy. And so basically here we can see her transthoracic echo presents with a large tumor infiltration through the pelvis, from the pelvis through the IVC and invading the right ventricle and the right ventricular outflow tract. And we can see here on her CT scan the mass and the IVC infiltration. So here we see that the patient underwent a two-step procedure, which was performed 25 days after the initial surgery. The tumor's basal part was found in the right iliac vein. She underwent a venotomy at the junction of the iliac vein and IVC. Simultaneously, a right atriectomy under ECMO was performed. The solid tumor mass was found in the right atrium, contiguous with the tumor filling the IVC. A portion of the tumor in the right atrium branched into the right ventricle through the tricuspid valve, making a Y shape. And the branching part of the tumor was extracted from the right ventricle through the tricuspid valve. The tumor was completely pulled out through the IVC, and the final specimen, which we can see here, measured 33 centimeters and was grayish white, cylindrical shaped, smooth, and hard, and which is the usual presentation of how leiomyomatosis, intravenous leiomyomatosis presents. So to summarize endometrial stromal sarcomas, they are more aggressive than intravenous leiomyomatosis and have a greater propensity for local invasion and systemic metastases, and of course, they are malignant. The final cancer that we'll review is ovarian cancer. When we refer to ovarian cancer, the most common type and the most aggressive type is the surface epithelial types of ovarian cancers, and the ones that we refer to the most are the serous cancers. And I reviewed the literature. There were no cases of invasion into the heart related to sex-scored stromal tumors or germ cell tumors. So I'll focus the next part of the presentation related to high-grade serous ovarian cancer. So high-grade serous ovarian cancer, the mainstay of treatment is achieving surgical resection, complete surgical resection, and deciding which patients are amenable for a primary cytoreductive surgery as compared to neoadjuvant chemotherapy. Most of the cases present in stage 3 or 4 disease, and we are wondering in patients who have stage 4B disease, there is a question of benefit of cytoreduction versus neoadjuvant chemotherapy. If we're not able to completely cytoreduce all of the tumor, then the patient may benefit from chemotherapy. However, if there is a possibility of resecting even distant metastases, then this patient may benefit from increased survival. So here is the CT of a patient with high-grade ovarian cancer who presented with a 1.8 centimeter cardiophrenic lymph node. And the idea is that if the rest of the abdominal and peritoneal and pelvic disease could be resected, then making the difference in her survival, if we leave this tumor behind, that's more than 1 centimeter, she would be suboptimally cytoreduced. So we would give her chemotherapy preoperatively. However, if a surgical consultation deems that this tumor is resectable, then she can be cytoreduced to no visible disease and benefit from increased survival. And the question as well is whether that cardiac lymph node ends up being metastatic or not on primary pathology, which would then upstage the patient into stage 4B. So in the review of the literature, there was a prospective series of 196 consecutive patients with epithelial ovarian cancer undergoing primary cytoreductive surgery in a 2-year period. So the suspicious cardiophrenic lymph nodes are over 10 millimeters on preoperative CT. And as I mentioned, they were removed if the rest of the cytoreductive procedure resulted in no gross residual disease or optimal less than 1 centimeter cytoreduction, and if the patient's performance status allowed a surgical procedure. So 15% out of those 196 epithelial ovarian cancers had suspicious cardiophrenic lymph nodes on preoperative imaging, and 90% of these had at least one positive cardiophrenic lymph node on pathological examination. And they also found that cardiophrenic lymph node dissection cardiophrenic lymph node is associated with extensive intra-abdominal tumor spread in the upper abdomen, so very seldom an isolated lesion. So the procedure to remove the cardiophrenic lymph nodes involves full exposure of the diaphragm peritoneum after mobilization of the liver. The diaphragm is excised using electrocautery. The pleural space is explored. The cardiophrenic nodes are resected using a vessel sealing cutting device. The 15 French JP drain is used as an alternative to the standard chest tube and placed to the through the diaphragmatic defect. The diaphragmatic defect is then closed using a non-absorbable suture. So they suggest 2,0 polypropylene in a figure of 8 fashion. The JP drain is connected to suction to evacuate the pneumothorax, and then you perform a bubble test to make sure that the diaphragm is completely closed. The morbidity and oncologic outcomes of this procedure were reviewed in the literature. So a case series of 54 patients was done in patients undergoing cardiophrenic lymph node resection. And 94% of these lymph nodes ended up being positive on pathology. And in the patients, 100% of them were at least optimally cytoreduced, and 55% of them had no gross residual. In terms of morbidity, 94% of them had a chest tube placement, and the median time to removal was 4 days. In another case series, the most common postoperative complication was small pneumothorax. In this series, there was a 35% rate of major postoperative complications, and 4 out of these were surgery related. And the median time to adjuvant chemotherapy was 40 days. The median PFS was 17.2 months, and the median overall survival was 70 months, which is very good for a high-grade ovarian cancer. Kleiby and al. Reported on the oncologic outcomes based on a Mayo Clinic cohort of 250 patients. There was recurrence was found in 81.5% of those patients with abnormal preoperative cardiophrenic lymph nodes, and abnormal cardiophrenic lymph nodes were more likely to be associated with synchronous recurrence in the thorax, pelvis, and abdomen in 50% of the cases. And all patients who had a CT scan after 6 cycles of chemotherapy had improvement in cardiophrenic lymphadenopathy. So in summary, gynecologic metastases to the heart are exceedingly rare. A common presentation is a presentation of as a CHF, and commonly women have a previous history of having a hysterectomy, and therefore when a woman presents with CHF, in very rare cases, sometimes you may have to investigate other symptoms. So again, just to summarize in an illustrative fashion, so the cervix, based on literature reviews, we know that cervical cancers metastasizing to the heart have very poor prognosis, and the question is, do we give palliative radiation versus chemotherapy? Endometrial cancers are exceedingly rare and based on only case reports and have a poor prognosis, and the treatment is debatable between chemotherapy, radiation, possibly calyx. The ovary, we found that with resection of the cardiophrenic lymph nodes may achieve complete cytoreduction and may assist in increasing survival. For leiomyomas and intravenous leiomyomatosis, the mainstay of treatment is usually surgical, and the treatment plan should be made in a multidisciplinary fashion, planning a 1-stage or a 2-stage procedure, and there's questionable benefits of a adjuvant hormonal therapy. So on this, I conclude our presentation on gynecologic tumors metastasizing to the heart, and I'm open to take questions or any comments on this topic. Thank you very much for allowing me to present today.
Thank you very much. That was very complete. Please, everybody, if you have any questions, ask them on the chat. I was a little bit confused about the stromal cell, because I'm not a gynecologist, stromal cell versus endometrial leiomyomatosis. What's the difference between the two again?
The intravenous leiomyomatosis is a benign version. So it's like a fibroid, like about 70 to 80%. It's very common in women, between 50 to 70% to have uterine fibroids, but to have intravenous leiomyomatosis is much more rare. So it's a benign histologic pathology, but it acts very aggressively. Whereas an endometrial sarcoma, that actually originates from the endometrial lining and is malignant from the get-go.
That's the stromal cell tumor you were talking about.
Yeah.
And because you mentioned in that this is how leiomyomatosis, they're not necessarily that one invades the wall and the other one doesn't. Can you get leiomyomatosis invading the wall and stromal cell not?
I'm not sure about if stromal cell can invade the wall. I think it's only based on some case reports, but what I read is that the leiomyomatosis doesn't invade the wall of the IVC, but maybe vascular surgery could be more experienced with this.
And it's quite interesting that a benign tumor has such a horrible outcome when it's not completely resected. And when you say incompletely resected, what are you talking about? Are you talking about the pelvic portion being incompletely resected, or what do you mean?
So any portion. So if you left a part in the IVC. So for example, the first case that it was a joint case with you initially and Dr. Bernardini and a few other people. So there was some notes that she had some fragments in the pulmonary arteries as well that were also resected. So let's say we had left one of those behind, or like the portion in the atrium. From what I understand, leaving those behind could affect worse prognosis. For example, if not by purpose, you will leave them behind, but if they were not able to be resected, those patients have poorer prognosis. It's unclear whether they can benefit from adjuvant tamoxifen or Megaze, but that's what's commonly used. But again, these are exceedingly rare cases.
And the pelvic portion, those pelvic portion, if you leave the pelvic portion, does that adversely affect outcome as well? I see Dr. Bernardini is here too. You may want to comment as well. Sorry to take the question away from you, Sabrina, but you've had all the fun so far.
Oh, and I think that, Sabrina, that was a great overview, in fact, of a rare phenomenon in all cases, but certainly have been reported in a number of gynecologic malignancies. And I think the ones that we tend to see it most are definitely these leiomyomatosis type cases. The difference between the endometrial stromal sarcomas is they do have more of an ability to kind of invade within the wall, as opposed to the leiomyomatosis, which just kind of, you know, in a way, it's almost if they're picked early enough. I think where we have a challenge with leiomyomatosis cases, if sometimes they're left too long and they get so large that the separation between the actual tumor and the lumen itself you almost you have no room to kind of work with, so to speak. And we saw that case recently. The one, in fact, I know I saw Ian was on the line earlier, and that was the case that, you know, you had to do almost a hepatectomy in a sense to get it all out, because we weren't going to be able to just slide it out like we can in a number of cases where you're fortunate. In terms of the pelvic disease, yes, I think if you, going back to Sabrina's point, if you're leaving any of the disease behind, you leave a nidus for further development of these tumors to grow. You know, the good news, I think, is that we tend not to see a lot of embolisms. You'd think we'd see more emboli from them, but they seem to be continuous. They just sort of grow contiguously. We had a case recently, as you know, where we were able to clear out a lot of the upper abdominal disease going up into the heart. But when you have some of the stuff within the veins of the uterine veins and deep in the pelvic veins, there's just really no way that you're going to be able to clear those veins entirely. We've had a few of these cases recently. We're going to be following them, obviously, and see how they do. But yes, I think the expectation is their risk of recurrence is higher.
Why do you think they die from benign disease? I mean, it's pretty significant mortality rate that Sabrina showed.
Yeah, I mean, I think we have to remember that they're coming from different types of institutions, and I would probably propose that a lot of it has to do with the cardiac expertise and the center where these patients find themselves. You know, I think, you know, you had the case recently, as you know, where that person was compromised, and you were able to perform that procedure, and she recovered in the unit, and then we did a combined procedure after. I mean, again, I think a lot of centers, you just don't have that capability, and it runs the risk for those patients.
The mortality she showed, though, was not upfront. It was years later.
Well, yeah, I mean, I think in some of these cases, and so we have the one case that we saw that you're aware of, you're also involved in the case. I mean, that individual does have significant lung metastases, growths of these tumors. So it's not common. It's very, very rare. But when you have these situations where they kind of grow seemingly out of control, there is no systemic treatment that's effective at shrinking it down. There is no true chemotherapy for these because they're histologically benign lesions. So there's nothing that we can utilize. And so eventually, when there's enough burden in the right organs, if you will, then they usually will succumb to that.
That's what it is. Mike Seidman, can you elucidate us a little bit more about the pathology? How many slices do you take before you call it benign? Do you just look at 2 high power fields or 10 high power fields, or do you look at 200 high power fields?
Yeah, that's not a straightforward question. So LIO is LIO is LIO. Yeah. So in general, the guideline is 1 section per centimeter. We certainly follow that guideline. I cannot speak to other centers. It's how I was trained and how I follow here. So of an N of 2, I'm 2 for 2. That particular strategy is very effective at identifying malignant components in primary things that otherwise look benign. Intravascular LIO versus intravascular spread of pretty much any of the other lesions look so dramatically different that it's not necessarily relevant. Plus, on top of that, as was shown, the outcome is not dramatically different. In terms of, you know, looking for an underlying lesion, I will say stromosarcoma and leiomyosarcoma tend not to just grossly look the same way. They tend not to go up the vena cava quite the same way. They tend, ironically, they end up in lungs and then invade down. But yeah, so in terms of number of mitoses, et cetera, the IVL is graded the same way as fibroids. So there is a technically 3-step framework as long as you ignore atypical leiomyoma as a thing, which it isn't. But there's then a stromal tumor of uncertain malignant potential, which honestly, if that's intravascular, I'm probably going to already call bad, and then the sarcoma. You're muted.
One final question. The patient that was described, and I know that patient, but the patient that was described, we thought had leiomyoma, and I suspect that she had leiomyoma for all this time, and was found to have a leiomyosarcoma. Do you think that's something separate, or do you think it was part of the same disease process? In other words, how often do you see these things degenerate or associated with the sarcoma?
Yeah, I mean, that was an interesting. Oh, sorry. Go ahead, Mike.
Yeah, unfortunately, I was involved in, if not the fault of, the uterine morcellation study. In general, fibroids don't hold sarcoma, don't degenerate the sarcoma. They were always sarcoma where you missed the sarcoma.
And in this particular case, RJ, I know that the pathologist went back and forth on it because she's had obviously a number of specimens removed. There was even a question mark at one point whether they wondered this was a de novo lesion of a gist. And so I think they didn't ultimately land on that. But I think that, as Michael says, they tend not to change. So I think it's just sort of the nature of this particular tumor that this particular patient had.
Well, thanks very much for both of you. I threw the gauntlet out to you to give us a lecture about gynecological tumors, and that's something that's very, very rare. And you came up with a great presentation and a great review of the whole process. People don't think about the heart when they think about gynecology, but that's why in the Twitter I said, "What is a gynecological surgeon talking at a cardiac tumor meeting?" And I think that this shows us why you did that. Well, you did a great job. Thank you, both of us. Thank you, both of you, for doing this.
Thank you for inviting us.
Yeah, thank you.
You're welcome. Our next presentation is going to be by Dr. Marc Deperreau. He's a professor of surgery here. He's one of our thoracic surgeons, and here he's showing up right now. The most common tumors I deal with from elsewhere, I think, are head and neck, or not head and neck, neck and neck with the renal cell carcinomas and the thoracic tumors. And I've gotten to know all of these two groups of surgeons very, very well. And Marc Deperreau is kind enough to talk to us about pulmonary tumors that invade the heart.
Good afternoon. I would like to thank Dr. Cusimano for the invitation to present today on pulmonary tumors that invade the hearts. This is my disclosure. Speaker fees from Bayer on that board meeting from Actelion on AstraZeneca. So tumor that invades the heart can be differentiated into predominantly lung cancer, which will be the group of T4 tumors, mediastinal tumors, and the separate group will be the pulmonary vascular tumor or the sarcoma or intimal sarcoma, which I will go in more details at the end of the presentation. So factors that affect survival in T4 non-small cell lung cancer includes predominantly complete R0 resection. Generally, these tumors have to be resected with a lobectomy or occasionally a pneumonectomy, but not lesser resection such as a wedge resection. We do need to have a mediastinal nodal status evaluated either by endobronchial ultrasound or mediastinoscopy to rule out mediastinal lymph node disease. And frequently, we will treat these tumors with induction therapy, either chemotherapy, chemoradiation therapy, and more recently, possibly immunotherapy or chemoimmunotherapy, which may improve the chance to achieve an R0 resection and optimize local control. These patients are assessed from a physiological standpoint with a pulmonary function test, VQ scan, particularly if pneumonectomy is anticipated, and echocardiogram. The clinical staging is performed with a CT scan, a PET scan, a brain MRI, and as I mentioned, mediastinal nodes are evaluated with EBUS or mediastinoscopy, and occasionally we will use cardiac MRI as well. This assessment must be done before the induction therapy, and some specific tests are generally repeated after the induction therapy, and in particular the CT scan, and occasionally the PET scan or the MRI. Now, the T4 tumors that infiltrate structures outside of the chest can be differentiated into those that will involve the thoracic inlet, which is the larger group of patients, and these often are referred as Ponco's tumor. The second group of mediastinal tumor are also often classified as T4 tumor. And then carinal resection and SVC resection are another group of patients who require or can require a T4 resection. The overall survival generally for T4 tumors is around 35 to 40% at 5 years. And this is the series from the group in Paris who has one of the largest experience with T4 tumor. As you can see, 271 patients in that cohort. Now, the limitation when we looked at mediastinal tumor is often related to the trachea, and particularly at the level of the carina. Resection of tracheal and carinal component is limited to 3 to 4 centimeters. Particularly due to the aortic arch, which limits the ability to bring the left main bronchus into the trachea. And the aortic arch will often generate some tension if more than 3 to 4 centimeters of tracheal resection is performed. And you can see on this right lateral view after the pneumonectomy, the left main bronchus, the distal end of the trachea, the mediastinum, and the SVC that was partially resected. So the distance here generally should be less than 4 centimeters to limit the risk of tension on anastomotic problem. During this resection, we use a cross-field ventilation with a second ventilator system that is sterile, and then the anastomosis is done end-to-end between the trachea and the left main bronchus. Occasionally, this central mediastinal tumor, in addition to invading the carina, can invade the SVC, and more rarely, but occasionally can invade the right upper pulmonary vein. And this is a patient from Paris that had the chance to operate with Dr. Dartavel, where you can see the resection of the SVC, the carina, and the upper pole of the left atrium that was resected with a stapler, and then the reconstruction between the SVC and the atrial appendage with a graft. Other type of tumor which may require SVC resection are mediastinal mass. This is a germ cell tumor that extended across the SVC and invaded the left and right innominate vein. Generally, if both innominate veins are needing to be resected, one of them can be reconstructed, as you can see on this intraoperative picture. Now, tumors that extend throughout the heart can also involve the aorta. Most frequently, they will involve the upper part of the descending aorta, close to the subclavian artery on the left side, as you can see on this picture. And these tumors may require resection with either partial bypass with VA ECMO, cardiopulmonary bypass, and less frequently, a gut shunt has been described between the ascending and the descending aorta, or you can do a clamp on resection. But generally, the best approach is to use a partial bypass. Nowadays, the ECMO is certainly the optimal technique. With partial ECMO, which allows perfusion of the upper part of the body and perfusion through the ECMO of the distal part of the aorta. The approach in order to expose the subclavian artery can be through an anterior approach, extending from the neck into the third or fourth intercostal space. The neck extension can be along the clavicle, supraclavicular incision, or along the sternocleidomastoid muscle in order to have a more posterior exposure, particularly if the tumor extends towards the vertebral artery here. The trapdoor approach is again most commonly used, and involves an incision along the lower part of the neck above the clavicle, then a midline stentomy that extends in the fourth intercostal space, which gives us the trapdoor approach to expose the upper mediastinum on the left lung. If necessary, the first rib can be resected with a small counter incision in order to open the window between the clavicle and the first rib, particularly if the subclavian vein is involved. If the tumor extends along the subclavian artery, the area to look at is the lower extension of the tumor, whether it extends to the aortic arch or involves only the subclavian artery, and then whether the vertebral artery is involved, in which case the dissection will extend higher up in the neck through an incision along the sternocleidomastoid muscle, which will provide exposure to the upper part of the neck and the posterior part of the neck, which allows resection of the vertebral artery, exposure of the brachial plexus, potential resection of the T1 nerve root, the chest wall, and then the subclavian artery can be resected distally and proximally on the aortic arch with a stapler here, and then the subclavian artery can be reanastomosed into the carotid artery, and the tumor is resected en bloc with a lobectomy through the second intercostal space. Now, for tumors that are more extensive, extending to the dome of the aorta, the posterior part of the aortic arch, the resection is more complex and will require potentially cardiopulmonary bypass or partial ECMO, as I mentioned, in order to be able to dissect and reconstruct the distal part of the aortic arch. On the subclavian artery can also be reanastomosed into the carotid artery. This is a patient who had surgery conjointly with Dr. Oreopoulos several years ago, where the tumor was extending down along the subclavian artery to the dome of the aortic arch. And Dr. Oropoulos did right to left carotid bypass. And then that patient was treated with an aortic stent in order to limit the need of cardiopulmonary bypass. And the stent was advanced close to the innominate artery. On the left carotid artery was covered and therefore required the right to left bypass for completeness of the resection. Another type of tumor that can extend toward the heart, which are not frequent but certainly well manageable with cardiopulmonary bypass, are tumor that involves the left hilum and extend along the left pulmonary artery to the bifurcation with the main pulmonary artery, as you can see here. These tumors can be resected through sternotomy or trapdoor approach in order to expose the main pulmonary artery, go on cardiopulmonary bypass, resect the tumor, and then the main pulmonary artery can be reconstructed with a patch. And this is the patients at 3 months postoperatively. You can see that the phrenic nerve was involved, and there is an elevation of the left hemidiaphragm. Now you can have a tumor that extends into the pulmonary artery lumen, and these are a lot less frequent, but an important group of patients to monitor and assess. This is a patient who eventually was diagnosed with a carcinoma, which was originating from his left lung and extended into the pulmonary artery, and he presented with pulmonary emboli, shortness of breath, and was found to have that intravascular extension of his disease. So that brings me to the third group of patients, which I will discuss in more details, which are the sarcoma of the pulmonary artery. These are patients who frequently present with progressive shortness of breath, occasionally chest pain, and very often will be misdiagnosed as an acute PE. Generally, the suspicion of sarcoma or malignancy is made on the CT scan of the chest with one of these features, either a large burden of disease that very often will be unilateral, or occasionally the CT scan may demonstrate an extraluminal extension of the disease or pulmonary metastasis. It is important to remember that these patients will progress despite anticoagulation, and if a patient is started on anticoagulation for suspicion of acute PE and his symptoms worsen despite the anticoagulation, a possibility of malignancy should come on the list of differential diagnosis. Occasionally, a cardiac MR or a PET scan can be helpful to tease out the possibility of malignancy, and these are increasingly frequently performed. A tissue diagnosis can often be difficult to get, and therefore the process to take this patient to the operating room often are based on suspicion rather than a diagnosis made preoperatively. Occasionally, the pulmonary artery can be accessed for biopsy with an IBUS done through the distal trachea, where the mass that could be located in the right main pulmonary artery could be accessed with an IBUS, obviously with some risk on hardly performed, but a possibility. And it is also important to remember that the intimal sarcoma generally will frequently extend towards the pulmonary valve. So an involvement, an abnormality along the pulmonary valve should also raise concern about the possibility of sarcoma. So this is generally the algorithm that we take to assess these patients. So if we suspect that there is a pulmonary artery sarcoma on the CT scan, we look at the possibility of a complete resection. So generally, we look at whether the disease is unilateral or not. If the disease is unilateral, then these patients can be evaluated for a pneumonectomy, and then the proximal extent of the disease may require a reconstruction of the main pulmonary artery. And intraoperatively, the final diagnosis on evaluation is done with a frozen section to confirm the malignant characteristic of the tumor, and also to determine the completeness of resection with a frozen section, particularly in the section of the pulmonary artery. If malignancy is confirmed and a zero resection is feasible, then patients on the surgery can proceed with a pneumonectomy. If the tumor is not completely resectable, either preoperatively or intraoperatively, then the assessment relates to whether the patients can have a pulmonary endarterectomy, and that will directly depend of the presence of extraluminal extension of the disease. If the disease is purely intraluminal, then these patients can have a pulmonary endarterectomy, which will improve their quality of life, their symptoms. It will not be a curative surgery. The resection will be an R1 resection, but it will again improve their quality of life and is a valuable option for these patients. If the disease extends beyond the wall of the artery, then palliative treatment, generally with chemotherapy, will be the main treatment. These pulmonary artery sarcoma are rare. In our experience at the Toronto Journal, with about 450 cases of pulmonary endarterectomy, we have encountered about 8 patients who required resection for malignancy, generally pulmonary artery sarcoma, and occasionally metastasis, renal cell carcinoma, or osteosarcoma in one patient, in a pediatric patient. The technique of pulmonary endarterectomy that we use for these patients is the same as those used for chronic thrombotic pulmonary hypertension, with a median sternotomy, the use of cardiopulmonary bypass, deep hypothermia with circulatory arrest at 18 to 20 degrees Celsius, in order to be able to visualize the segmental component of the pulmonary arteries. The approach is through a sternotomy, intrapericardial approach, in order to limit the extent into the pleural space, where generally there will be adhesions, and typically the procedure will be bilateral, and that includes as well pulmonary artery sarcoma. In the pulmonary artery sarcoma, the tumor can extend into the wall of the artery more than with chronic thrombotic disease, and therefore the resections occasionally can be more complex. This is a schematic of the technical approach with cardiopulmonary bypass for the aorta, 2 single-stage venous cannula for the SVC and IVC. The pulmonary artery is dissected on both sides. Generally, we will section the arterial ligament, and then the exposure of the right pulmonary artery allows a longitudinal incision, and then the plane is elevated, and the dissection goes along the intima and the media of the pulmonary artery, and then extend into the distality, as I will show you on a short video. So this is a short video of a patient with chronic thrombotic pulmonary hypertension. This is the right pulmonary artery that is open from behind the aorta all the way to the right upper pulmonary vein. The plane of dissection has been elevated and advanced into the segmental branches, and this is the component under circulatory arrest, which allows us to do the dissection at the level of the segmental and subsegmental branches without any back bleeding from the bronchial circulation. So the plane of dissection is circumferential. We elevate and separate the cast from the wall of the artery at the level of the media, and then we progressively pull the cast into the field of surgery, and we use this blunt dissection with a suction tip in order to gently dissect into the periphery of the artery. And then at the bifurcation, we go more distal in the subsegmental branches until the tail is coming into the field. These are the type of specimen that we can get along the main pulmonary artery or lobar arteries as level 2 for lobar arteries, segmental arteries, and occasionally we can also reach disease that is predominantly located in the distal segmental arteries or subsegmental arteries with excellent optimization of the hemodynamic postoperatively. So on the in patients with pulmonary artery sarcoma, we use the same technique. So if the disease is bilateral, as in the patients that are presented, we will ensure that the disease does not extend outside of the wall of the pulmonary artery and determine the feasibility of the pulmonary endarterectomy to resect the intraliminal component of the disease. In that specific patients, it was difficult to tease out whether that extension was tumor extending through the wall of the artery or if it was a separate component of the tumor that was extraliminal. That component was clearly intraliminal. So we did an MRI in order to tease that out, and the MRI did demonstrate the intraliminal component of the disease, but the extraliminal component of the disease was mostly nodal disease in the orthopulmonary window, which was extraliminal or not connected to the intraliminal component of the disease. We therefore proceeded with the pulmonary endarterectomy and resected the disease. That part of the disease was malignant, and that was associated with some chronic thrombotic disease on the left side, and then on the right side as well. A mixture of tumor and clot was also found on the right side. The nodal extension of the disease was not touched at the time of the surgery, but reevaluated postoperatively. And you can see in follow-up that the lymph nodes were still present. And therefore, we reevaluated the patients with a PET scan, demonstrating that the disease was confined to that orthopulmonary window lymph nodes with no other activity on the PET scan. On that patients, therefore, underwent adjuvant radiation therapy to that area of the tumor postoperatively at the level of station 5. The final diagnosis of the tumor was a sarcomatoid carcinoma, and the patient is currently alive without recurrence over 6 years from his resection. This is another type of situation that we can face. This is a patient's 53-year-old man who presented with progressive shortness of breath on chest pain, which was diagnosed as an acute PE, but his symptoms continued to progress despite the anticoagulation, and he was reevaluated. And on the follow-up CT scan that you can see here, the clot had progressed towards the main pulmonary artery, and the possibility of malignancy was raised, and the patient referred to us. His disease on the CT scan was localized only on the right side, only intraliminal, with no extension into the main pulmonary artery or into the left lung. Therefore, patients who could potentially be approached for a right pneumonectomy with a complete resection. This is another patient, 45-year-old woman, who also presented with chest pain and shortness of breath, diagnosed with an acute PE on progression despite anticoagulation. But in contrast to the other patient, the tumor in this specific patient extended towards the main pulmonary artery and along the left side of the pulmonary artery, putting the patient at risk of a major hemodynamic event, and therefore was referred to us for management. This is a third similar clinical presentation, but a tumor that is more advanced into the right lung, and you can see the right tumor extending into the parenchyma of the right lung, associated with an intraliminal component extending into the main pulmonary artery, and activity on the PET scan in the main tumor, as well as the intraliminal extension to the main pulmonary artery here. So these three patients were treated very similarly on the approach with sternotomy, cardiopulmonary bypass, dissection of the right and the left pulmonary artery. The pulmonary artery is then open in order to get frozen section for diagnosis. If malignancy is confirmed on the extent of the disease allows a complete resection, potentially with resection of the main pulmonary artery and possibly even resection of the main pulmonary artery on the pulmonary valve. Then a right pneumonectomy can be performed with a Dacron patch reconstruction for the main pulmonary artery that extend to the left main artery, and reconstruction of the pulmonary valve if necessary. If during that process malignancy is not confirmed, but the disease is truly a chronic thromboembolic disease, then these patients can proceed with a pulmonary endarterectomy. Or if the disease is not completely resectable, then the alternative options is a pulmonary endarterectomy in order to provide hemodynamic improvement and improvement in symptoms as well. This is another patient who presented acutely and also was treated for acute PE and then progressed and then was urgently referred to us about 6 weeks after the initial acute event. She was referred to us to a critical stage and eventually underwent on acute pulmonary endarterectomy. On the CT scan, the disease was localized mostly on the right side at a lobar level, but there was disease extending to the pulmonary valve that initially was not appreciated on the CT scan and retrospectively could be seen. There was a thickening along the valve of the pulmonary valve on some calcification that you can see on the sagittal cut, which is what we found intraoperatively when that patient was brought down to emergently to the operating room. This is the intraoperative finding, with the tumor extending into the main pulmonary artery, affecting the pulmonary valve and extending into the RVOT. And then that patient underwent a pulmonary endarterectomy with reconstruction of the pulmonary valve, and the pulmonary artery was left intact otherwise. And this is the follow-up scan. The survival after resection of pulmonary artery sarcoma is leading to a median survival generally of about 18 months. Most series are relatively small. This is the one from Paris with Philippe Dartevel, which is the largest series published with 31 patients. And you can see the clinical presentation from these patients. About half of the patients presented with a clinical presentation suggestive of chronic thromboembolic pulmonary hypertension. 6 patients presented in the acute setting, suggesting an acute PE. 7 patients were referred for presumed diagnosis of sarcoma based on tumor infiltration or large mass in the right or the left lung. 2 patients presented with pneumonia, and 1 patient presented with a fibrosing mediastinitis. A preoperative diagnosis was obtained only in 5 patients prior to the surgery, and the median survival was 17 months, which is quite typical. But you can see that there is occasional patients who will have a long-term benefit from the surgery here. This is a literature review that was performed by Dr. Blackman in MD Anderson, and summarized their experience with 8 patients and reviewed 57 patients from the literature, and look at the survival based on different characteristics. And one of the main differences was the ability to perform a complete resection versus an incomplete resection, including thromboendarterectomy, where no patients survive beyond 4 years, with a median survival of about 11 months in that series, while patients who had a complete resection did achieve long-term benefit in some patients. Patients who have a thromboendarterectomy even though they will recur on have progression of their disease, will still benefit from the surgery in order to alleviate the hemodynamic component of the disease with a risk of impact on the right outflow tract. So in conclusion, resection of tumors extending to the heart is rare. Cardiopulmonary bypass, ECMO, and endovascular aortic stent can provide support to achieve an R0 resection. Pulmonectomy with reconstruction of the main pulmonary artery and occasionally of the pulmonary valve is an option for unilateral sarcoma. Otherwise, pulmonary endarterectomy is an alternative approach for pulmonary artery sarcoma when complete resection cannot be achieved with benefit on their quality of life despite recurrence of the disease in the midterm. Finally, would like to thank you for your attention, and I will be happy to take some questions. Thank you.
Thank you very much, Mark. That was a very, very interesting talk. You are a world expert in pulmonary endarterectomy. You had a long training in that, and you've come back here to Toronto General and really championed that, and you really are a light in the world with respect to pulmonary endarterectomy, in addition to other things. Your pulmonary endarterectomies are completely different than the pulmonary endarterectomies that are done in the world. Unless you come from France where you trained, most of them do not look like yours. And you wonder whether or not it's an old study by Shauna Blackman, whether or not some of those pulmonary endarterectomies were incomplete and they had R1, not R1, but R2 resection margin, in other words, gross tumor left behind. If you do a pulmonary endarterectomy and you find in the pathology that you get back that the person did have a sarcoma, any other treatment? Do you use radiation? Because as you've said, I think the gold standard is still resection and reconstruction of the pulmonary artery, but here you found it coincidentally in an endarterectomy specimen. What would you do differently for those kinds of patients, if anything?
Yeah, these are very good questions, RG. Yeah, sometimes we can have, unexpected finding in the OR, and we still proceed the same way. And postoperatively, we will have a discussion with the oncologist to see if further treatment is beneficial. And very often, the option will be chemotherapy, and often they will not have chemotherapy. Probably about half of the patients will do on those, the other half won't. The treatment is not curative, even if you resect the tumor completely, unless it's a very localized disease, like the patient with the sarcomatoid carcinoma, which was very unusual. His tumor was probably more central on so far it seems to be okay, but most of the patients otherwise will recur on whether, probably giving them chemotherapy will prolong their life, but it comes down to a quality of life decision, with the patients, although to a large extent. Radiation is often not done because of the risk on the heart. Like these are tumors that are often close to the heart, and because of the risk of, complication or side effects on the heart, this would be less frequent. But like that patients again with the hilum, who had radiation was, within the range of what we typically would do for lung cancer. But I would say most of the time, surgery will be the main treatment.
When you see recurrence in a pulmonary artery sarcoma after an endarterectomy, is it localized or distant? I've not had very many of these. I've resected the people's outflow tract in the main pulmonary artery down to each hilum. So it's really central disease I'm dealing with. You're dealing with more peripheral disease with the tumor found as well. The recurrence has been distant in the lungs. They die of lung mets. What about what do you find?
They're the same. So if you do another resection, if you get to a complete resection, they will typically come back with distant recurrence. Lung mets will be one of them, or other distant mets will be the type of recurrence. If you do a pulmonary endarterectomy, they will recur within the lumen of the artery. The patient who had the pulmonary valve resected with the endarterectomy had recurrence in the RV, right ventricular outflow tract, on so they become palliative quite quickly once they occur.
Yeah, yeah, I think that's a good lesson for those people. Again, people who are tuning in are watching really world experts talk about these sorts of things. You're seeing a world expert here in pulmonary endarterectomy. But one of the takeaways in this particular statement is that the pulmonary valve is involved very frequently if it's in a central portion. And when you resect the pulmonary valve, you can't just resect the pulmonary valve. It's actually an RV, right ventricular outflow tract resection in addition to the pulmonary valve. If you stop right at the pulmonary valve, you're going to have a positive margin and probably early recurrence. Was that patient an early recurrence, Mark?
Yeah, that patient occurred about 12 months, 12, 18 months post-op. She survived. I forget the exact amount of time, but it was, if I recall correctly, like 18, 20 months. So, within the range of what is reported, in the literature. But I've seen patients recur much faster on I think there's still a debate among surgeons who do pulmonary endarterectomy whether pneumonectomy is a better option, or they should be palliative and just have the endarterectomy. Nobody has the right answer. So, but certainly what I've seen occasionally with at least in one or two patients, when you do the endarterectomy, they can occur quite quickly. To me, it seems that if you can do a complete resection in a patient who have limited risk otherwise, and often the lung that you're going to resect is not functional, so you actually don't compromise the hemodynamic by doing a pneumonectomy. And if you can do a complete resection, I think there is still some benefit to proceed with that option primarily rather than trying to do palliative endarterectomy. So it's still a debate, and I think it depends a lot of the patient's conditions on comorbidities. But it's certainly a palliative procedure leads to potentially rapid recurrence, which is not very satisfactory. If they develop recurrence within 6 months or so.
Thankfully, pulmonary sarcoma is not very common.
Yeah.
This morning we heard about complex tumors that involve the heart, and other than just the one that sneak into the pulmonary vein into the heart, more complicated ones. Dr. Reardon this morning spoke about their Texas two-step approach, and I've been involved with the discussions about him about that. What they do is they go in one day and resect the cardiac portion, so remove that portion of the cardiac, the tumor in the lung that affects the cardiac or the mediastinal tumor, and leave that alone, let the patient recover from that operation, and then the next day go back and do a pneumonectomy. And they found better results doing that than if they did it all at once. Would you comment on an approach, a two-stage approach to that, a 2-day approach, 2 or 3 days later or whatever, leaving the lung not attached to the heart, and then going back a few days later and removing the specimen?
Yeah, I think that's a great point. On the doing a two-stage approach is has a lot of benefit. I mean, the big problem when you do a pneumonectomy on cardiopulmonary bypass is the bleeding issues. And if you can do the component on cardiopulmonary bypass, normalize the coagulation, let the patient recover, and then go back even to a better approach. By doing a thoracotomy, you'll have better exposure of the posterior mediastinum or middle component or hilum, middle component of the mediastinum or the hilum is involved. Then you have two benefits, I think, doing it two-stage. On the thoracic side, we do a fair number of spinal resection in two-stage. So the posterior approach is done by the spine surgeon at the Toronto Western, and then we do the second step with the lung resection at TGH. On that has worked very well. So rather than doing a 12, 18 hours operation, you break it down into two reasonable days of surgery. On patients do recover faster. So having a stage operation is actually a very good option. I agree here. On plus the coagulation component, that certainly will be beneficial.
How long do you wait when you do the spinal surgery and your operation?
Usually we wait 6-7 days.
6 or 7 days.
Yeah. So the lung is still perfused. So there's like if you remove the cardiac component, you may have taken some of the pulmonary vein, or I guess maybe the pulmonary artery, but certainly the pulmonary vein, I suspect, will be removed with the cardiac component. So the lung may not be perfused, so it may not work to leave them for as long, but certainly from a spine perspective, 6-7 days has not been a problem.
Yeah, I've been involved with some combined pneumonectomy, cardiac cases, and they're high risk patients, to say the least.
Yeah. No, I think certainly a pneumonectomy on capillary bypass is potentially a problem. The ECMO has been quite beneficial. Obviously, you have to be within a closed system, but if you can use ECMO rather than bypass, I think that's becoming a very advantageous option. Like for canal resection, rather than doing cross-field ventilation, if you put them on VA ECMO, you can do surgery without much problem from a ventilatory perspective. On the amount of heparin you give is low enough that you have very minimal bleeding problems. So it's certainly increasingly becoming an advantage as well if it is an option based on the location of the tumor.
Yeah. Again, Dr. DePro and the group here at Toronto General Hospital have a gigantic experience in VA ECMO. And it's one of these things, don't try this at home. You have to be, just like Dr. McGilvery said and other people said, and Dr. Rogala said in this morning, is that if you're going to try some of these things, you better make sure you know what you're doing, go get trained or ask for help. Definitely ask for help. The group here is an amazing and an outstanding group of thoracic surgeons, and they have a huge experience in the things that Dr. DePro spoke about. It's a center of excellence here for all of Canada.
Yeah. No, these complex cases, you benefit a lot from discussion on everybody comes with their own input, and I think building a team effort as to how best to approach these tumors is very beneficial. So I think the teamwork is a big component of these success for this type of tumor.
Yeah, we take it for granted here in this hospital that we almost don't even talk about it. But I think around the world, it's something that people can strive to make teams like we have here in this hospital.
Mm-hmm.
All right. Well, thank you very, very much. That was a very interesting talk, Mark. Thank you very much for coming.
Thank you very much, Ajay.
We're going to have a 15-minute break, and we're going to actually shift gears, and we're going to bring the oncologists around. It's hard to have a cardiac, or not a cardiac tumor, a tumor conference without having an oncologist with us, just like it's hard to have a cancer discussion without a radiologist or a pathologist. So after about a 15-minute break, we're going to come back and we're going to talk about chemotherapy and really what do you do when you run out of chemotherapy. That's what we're going to talk about. So stay tuned. Don't forget to ask questions, and we'll see you in about 15 minutes or so. Bye-bye. Welcome back, everybody. We're entering our last session. This is really one more talk about consolidating everything we've heard about cancer and having the people who do things sometimes before we as treating people, most of the times afterwards, and they're the ones that see the patient to the very end, and it's our friends, the oncologists. They sometimes have the most difficult problem because we give them hope and they give them hope as well, but sometimes when hope runs out, they're the ones that have to deal with it. This last lecture is going to be about that particular time when they've run out of things to offer the patient. I'd initially asked the talk to be called doxorubicin. Is it candy or cocaine? Is it something we can use or something we need to use? And the idea is when you can't use that medication anymore and other medications, where do you turn to help the patient? With that, I'll hand the microphone and the screen over to our oncological colleagues. Following that, we're going to have case presentations. Okay, let's start.
Hi, thank you again for giving me the opportunity to deliver this talk. My name is Abdulaziz Salau, Clinical Fellow in the Toronto Sarcoma Program, and I'll be presenting a talk titled Chemotherapy When the Usual Drugs Don't Work. The focus of this talk is going to be on primary malignant tumors of the heart. The vast majority of these are sarcomas, so essentially I'll be presenting a talk on primary cardiac sarcomas. I know most of the previous talks have been on tumors from other sites that metastasize to the heart. And I'll be providing an overview of systemic treatments, including the usual chemotherapy, as well as other chemotherapy that's available for treatment of this disease, targeted therapies and immunotherapies, and I'll finish up with a case presentation. So malignant tumors arising from the heart are very rare. The estimated incidence is quite low. No studies have shown more than 0.03%. They do have a high propensity to metastasize and are regarded as a systemic disease at presentation, even when disease is only localized on a radiological basis. They have a tendency to metastasize to the lungs, to the liver, and also to the brain. The prognosis for cardiac sarcomas, unfortunately, is quite poor, with median survival ranging from 9 to 27 months. And adequate surgical resection is probably the most important prognostic factor. That means an R0 resection and multimodality treatment, which involves surgery, chemotherapy, plus or minus radiation, is advocated. And this is advocated to be done at specialist centers that have a relatively high volume of this disease in order to get the best outcomes from patients. And there's several retrospective reviews that support this. Unfortunately, location matters with sarcomas, and as you can see here in this busy slide, in highlighted, soft tissue sarcomas of the heart have a relatively poor outcome in terms of 5-year survival compared with soft tissue sarcomas at any other site in the body. In terms of histological subtypes, the cardiac sarcomas can be essentially of any histologic subtype, but we see most commonly angiosarcomas, and possibly intimal sarcomas, but essentially any other sarcoma is possible. I've put here about 6 retrospective case series that showed different histological subtypes of sarcomas, showing the wide range of possible sarcomas, including synovial sarcomas, leiomyosarcomas, liposarcomas, etc. Unfortunately, there's a lack of prospective evidence, as you can imagine, with a very rare tumor like this. And the approach to treatment is largely extrapolated from the systemic treatment that is used to treat sarcomas at other anatomic locations. There's several considerations here. In terms of histologic subtype, that's still probably the most important determinant of what kind of systemic treatment we choose. The location I've put here because quite frequently, because the heart is such a vital organ, some localized treatment to the heart is usually part of the management regimen upfront for these patients. There's also patient factors in terms of their fitness and ability to tolerate systemic treatment. Biomarkers, where available, there's very few of them, and I'll talk about these as we go on. But biomarkers where available are encouraged, and it's also encouraging these tumors to do genomic profiling when available in order to identify possible treatments. And we employ phase 1 trials, which I'll go into a bit later as well. So the usual drugs for systemic treatment of primary cardiac sarcoma tend to be adriamycin-based chemotherapy. We use combination therapy generally if patients are fit enough, because this is an aggressive disease. The most common partner for adriamycin is ifosfamide, and this is suitable for the vast majority of histological subtypes, such as angiosarcoma, intimal sarcoma, leiomyosarcoma, synovial sarcoma. The response rates vary from 25% in general to up to 75% in some neoadjuvant treatment for cardiac sarcoma, some case series that have been presented. The responses, unfortunately, are often not durable. Progression-free survival is about 7 months. And in some specific histological subtypes, the partner for adriamycin can vary. Like, for instance, dacarbazine may be favored as a partner for adriamycin in leiomyosarcoma, or combinations such as VAC may be considered for rhabdomyosarcoma. Following, when disease recurs after adriamycin and ifosfamide, or when adriamycin and ifosfamide is just not feasible because of possibly patient factors, there's other chemotherapy options that can be considered. These tend to be, again, drawn from other histologic subtypes of sarcoma at other anatomic sites. Gemcitabine plus or minus docetaxel is probably the most popular of these, with relatively good response rates, but I think in general it is felt that adriamycin and ifosfamide is a bit superior to gemcitabine docetaxel. Gemcitabine as a single agent can be considered as well in patients who are not fit enough for the docetaxel. Trabectedin can be used in certain subtypes such as leiomyosarcoma. Dacarbazine or eribulin are also quite typically considered. It's important to note here that even though we see angiosarcomas in the heart relatively commonly, we do not use paclitaxel in general to treat angiosarcomas of the heart, because the response rates are poor, can be as low as 14%. And paclitaxel is the preferred chemotherapy regime for cutaneous angiosarcomas, which are typically on the face in elderly male patients and have a very different biology in terms of etiology, as well as even molecular characteristics. There's emerging evidence that these tumors have a high tumor mutation burden and response to immune checkpoint inhibitors, which is slightly different from the cardiac or visceral angiosarcomas. So it's important that we don't generally use paclitaxel in treatment of cardiac sarcomas. Next is targeted agents. We know about pazopanib based on the phase 3 PALET trial. And we know that for certain subtypes such as synovial sarcomas or intimal sarcomas, targeting angiogenesis with drugs like pazopanib has been shown to be quite efficacious. Regorafenib is another drug that's shown evidence in phase 2 trials, such as the REGOSARC trial, to be of use for treating these tumors with similar median progression-free survival to pazopanib in that trial. So this is another area where we can use an oral treatment to control this disease systemically. Emerging targeted agents include things like the NTRK inhibitors, which are tumor agnostic, so but they are biomarker led, which is quite good. We get very high response rates. Unfortunately, NTRK fusions are quite rare in adult sarcomas, including cardiac sarcomas. Larotrectinib is now FDA and EMA approved, and you can see here on the right the waterfall plot that shows the very high response rate that you can see in suitable patients, which also comes back to the fact that genomic profiling of these tumors is quite important in terms of looking at all possible treatment options, because this is a highly effective treatment, albeit rare. Next is mTOR inhibitors for certain sarcoma subtypes, specifically the epithelioid hemangioendotheliomas or PICOMAs. In fact, some retrospective studies have shown higher response rates compared with chemotherapy with these drugs. And on the right side, there's some recent evidence presented at CTOS late last year, that shows that an albumin-bound formulation of sirolimus and nab-sirolimus is quite efficacious, and also shows a predictive mutation with TSC mutations, showing high evidence of efficacy. So again, this comes back down to the importance of genomic profiling for these patients. Another emerging treatment is selinexor, again presented at CTOS late last year, which showed some evidence of progression-free survival advantage in liposarcomas. And these can occur in the heart, so that will be another treatment option. Selinexor can be associated with quite a bit of toxicity, and there are ongoing studies, including here at our center, to look at alternative dosing regimens and see whether we can improve this toxicity. But this is certainly an emerging treatment that can be used for control of sarcomas as well. The selinexor targets exportin, which is a specific protein that works in the trafficking of tumor suppressor proteins from the nucleus and helps to reactivate these tumor suppressor proteins and improve apoptosis in the tumor cells. Another targeted agent that's coming on stream with promising evidence is MDM2 inhibitors. These are probably these have been shown to have efficacy in liposarcomas in a phase 1b trial, as shown here last year. And there's and we also have quite good evidence that MDM2 amplifications are quite common in intimal sarcomas, which are a common subtype for cardiac sarcomas. So the presence of MDM2 inhibitors and genomic profiling might point one in that direction as a treatment option after the usual drugs do not work anymore. Finally, we go to immunotherapy. The immunotherapy checkpoint inhibitors have changed the face of medical oncology in the last few years. And even though it's been largely disappointing, there has been some signals of some soft tissue sarcomas that respond to anti-PD-1 agents. I think notably among these is alveolar sarcoma of soft parts, the ASPS, which have shown quite good overall response rates, whether alone or in combination with anti-angiogenic agents such as axitinib. And we've also seen in combination studies of ipilimumab and nivolumab, responses were seen among angiosarcomas, undifferentiated pleomorphic sarcomas, leiomyosarcoma, and fibrosarcoma, making this something to consider among these tumors as treatment options. There's further combination studies that are ongoing. And something that has made quite a lot of waves is cellular immunotherapy, which has been exploited in certain sarcoma subtypes, such as synovial sarcoma, mixed liposarcoma, that express specific antigens like the NY-ESO1 or MAGE-A4. Excuse me. Targeted T cell therapies, adoptive T cell therapies, whereby T cells are isolated from the patient and re-engineered, usually by viral transduction to express specific T cell receptors that that recognize these antigens, and then the cells are expanded and reinfused into the patient to develop an immune response. And two promising trials in synovial sarcoma that has previously been treated with the usual drugs of adriamycin and ifosfamide have shown quite impressive results with overall response rates of 50% and 44%, as you can see on the screen. The limitations, however, are that these patients have to be HLA-A2 positive. This is rare in non-Caucasians. And also, the durable responses are usually only seen when the treatment is preceded by lymphodepletion, which can come with the side effects of prolonged neutropenia or bone marrow failure. There's also the risk of cytokine release syndrome or the neurological symptoms, now commonly described as ICANS. But these are, they are considered to be safe. They are effective treatments for these side effects. And this opens up a new range of possible treatments for patients with synovial sarcoma. There's ongoing phase 2 studies to look at the efficacy of these treatments in more detail. So I'll move on now to a case presentation for a patient seen here, 49-year-old gentleman who presented in July of 2018 with breathlessness on exertion for about a week and some chest pain. He quite rightly had a suspicion of a pulmonary embolism. The CTPA was negative, and so he was discharged. In his background, he had no significant past medical history, apart from an allergy to amoxicillin. He lived with his wife and 2 children, and generally had a healthy lifestyle. About a month later, he represented with further shortness of breath, and an echocardiogram at the time showed the pericardial effusion with tamponade, which was drained. The cytology was negative, and it was suspected that he had possible viral pericarditis and was treated with aspirin and colchicine. But he was admitted again with collapse a few days after, with recurrence of the pericardial effusion, and another 2 liters of bloody fluid was drained with a pericardial window now put in, but the tissue again showed no malignancy. This just highlights how difficult the diagnosis of such a rare disease can sometimes be. He had further chest pain and eventually had a CT scan of the chest on September 6th of 2018, which showed a rounded mass in the right atrium measuring up to 6 centimeters with extension into the right atrium. It was initially thought to possibly be a right atrial myxoma, but he was also noted to have mediastinal lymphadenopathy and pulmonary nodules that were in keeping with metastases. And he went on to have dedicated cardiac MRI that showed the full extent of the tumor, which was infiltrating the right atrium into the cavity and involved the right coronary artery and tricuspid valve. And a CT-guided biopsy from this mass showed by cytology, histological and immunohistochemical evidence of an angiosarcoma grade 3. And this confirmed that the mediastinal lymphadenopathy and bilateral pulmonary metastases, bilateral pulmonary lesions were indeed metastases. So quite rightly, he was referred to a high volume center in Toronto and had underwent tumor board discussion. He was treated upfront with doxorubicin and ifosfamide for 6 cycles and had a partial response. But unfortunately, he didn't have resolution of the lung metastatic disease. So what did we do next? We changed his treatment to gemcitabine and docetaxel. And unfortunately, even despite 6 cycles of this, he had further progression in the lung nodules. And at this point, we had exhausted 2 chemotherapy lines. And so he was enrolled in a phase 1 clinical trial of immunotherapy with interleukin-2 in combination with an anti-PD-1 drug in July of 2019. He had stable disease in his lung nodules, but an increased size of the right atrial mass. And so in December 2019, he was referred to our radiation oncology colleagues for consideration of treatment to the right atrium where there was disease progression. And he had radiation treatment to the right atrium and the mediastinum, which allowed him to go back onto systemic treatment with Calyx, which was controlling the disease at other sites. And I can report that up to October of 2020, which is more than 2 years after his diagnosis, his disease remained stable on Calyx. So what this case highlights is the possibility of additional treatments after first-line doxorubicin ifosfamide, and the fact that some patients who are young and motivated can sometimes actually tolerate and have disease stability through several lines of treatment. And so in such patients, it's important to have as much information so that we can sequence treatments as well as possible. A patient like this would certainly benefit from genomic profiling of his tumor to see if there's any other systemic treatment options that are available. He is currently not under our care at this center anymore and has returned to Quebec to his original oncologist who's managing him there. So in conclusion, there's a range of new and emerging treatments beyond the first-line AI for primary cardiac sarcomas. Molecular profiling, I cannot overstate, may identify additional therapeutic options, but definitely more high-quality evidence is needed, and this can only come through improved collaboration with national and international patient databases such as the CANSAC database, which will provide high-quality retrospective data to help us move things forward. In terms of prospective trial design, these have to be multi-center because of the rarity of this disease, and it will be useful for them to be histology specific and biomarker driven in order for us to get the best quality evidence out there. Translational studies attached to these trials will be important in order to identify new targets. And one should also not underestimate the value of referring these patients to phase 1 clinical trials, as this is where sometimes some unexpected therapeutic signals are seen, even though this is infrequent. Thank you very much for listening.
Oh, thank you very much for discussing a very, very difficult problem that exists in the world. I'm always amazed at the lectures from the oncologists about the chemotherapeutic trials. All of the past presentations of the Toronto Cardiac Tumor Conference are online. And if you go back to the very, very first meeting, there's a very interesting lecture about chemotherapy for cardiac sarcoma. And it's almost a mirror image of what was said at that time. It's very, very difficult to find chemotherapeutic agents that have a long-lasting effect. One of the things that we see as very poor outcome, disease-free survival is very poor in all of the chemotherapy trials. What you didn't show is the small numbers of patients in each one of those trials. Very, very small. And you're absolutely correct that not just the national database, as Dr. Reardon said this morning, but Dr. Reardon and Dr. Farku said, but we really need the whole world to come together and help us to deal with these and get more patients enrolled. If you have 7 patients in a trial and it's an international trial, it tells you that the outcome is not going to be good because there's not enough patients to really understand what's happening. You mentioned genetic sequencing and genetic profiling more than once in your discussion, and I'm going to ask Mike Seidman about genetic profiling, how difficult that is, especially with small volume tumors that we have. Again, I know it's funny that I've known most of those patients, partly because most of the speakers are from Toronto. I've known all those patients, and this particular patient you saw in Patrick Rogala's lecture because he's one of the first ones I sent to him to biopsy. How difficult is it to get to this genomic profiling in a small piece of tumor?
Yeah, it's a great question. The reality is what we need is obviously way less than what we used to need. The current extraction techniques and the current capacity for next generation sequencing has considerably improved our ability to this effect. Also the addition of next generation sequencing based techniques for translocations. There were several translocation targeted therapies mentioned. That also requires considerably less material than some of the past techniques have, and doesn't require cells quite as intact and robust as they did for fish, for example. So the reality is most of the biopsies at UHN are yielding enough molecular material to guide therapy, but it is not clear to me that that is widely available yet. There's then also the question of how much testing to do. Our centers do a fairly targeted panel based on things we have therapies for. And when you start getting into more and more trials, you're going to have to test more and more stuff. So that's definitely a set of conversations you have to have at each center, including the option of sending it out. There are a number of commercial entities out there that provide varying levels of information. And, the reality is you take what you can take for the given patient, and we try to tell you as much as we can tell you.
When we do genetic profiling, so you're not doing the whole genetic, you're not doing the whole genome, you're just doing specific known sequences.
Correct. Right now, I think the oncology panel is somewhere around 20 genes in Ontario. Give or take, there is an experimental profile that I think is about a dozen more. The center where I trained had implemented a 1,000 gene panel the year I left. The reality is of those, no more than 25 are clinically actionable, even as today, 10 years later. Another 20-ish are grounds for trial enrollment. All of the rest range from theoretical trial enrollment to biologically interesting at best. You have to be cautious when you get to the really big panels. When you're dealing with 20-ish genes, it is a limited sequencing technique. When you break 100, it frequently becomes more cost-effective to test the entire exome and just tell the computer which things you want to know. But that also makes trials easier for the things that you haven't asked for yet. And I will say germline sequencing superimposed on that is of variable yield depending on the amount of material.
Can you do
therapy? Yeah.
Can you do any of this testing in blood?
Isolated tumor cells, circulating tumor cells, in theory, are a source of material. Ariel, I'll come back to your question in just a second. I do not know if it is up and running robustly at UHN. The problem is that the tumor has to actually shed the material. So carcinomas are reasonably well studied in this regard, lung cancer in particular. I am not familiar with any data on sarcoma. That doesn't mean there aren't any. Albie might be able to speak to it. In terms of T-cell therapy profiling, the Foundation One basically does everything, including the thousands now of genes, all sorts of calculations. But as you alluded to, a lot of them are research level, so clinical trial level. In terms of T cell therapy, most of what we actually do is IHC based. It's really the do they express or not, and then of course the irony being for most tumors it doesn't matter. The therapies seem to work no matter what, or don't work no matter what. But in terms of genomic profiling for response to T cell therapy or any of the immunotherapies, I don't think it's very robust yet, in my opinion. So I think you're still looking at things that need a lot more work.
Can you educate us what Foundation One is?
Yeah, Foundation One is a company that does a absolutely massive genomic profiling. They actually developed out of a few different centers in parallel to when I was training. They test a very similar panel. I think it really is approaching 2,000 genes now. They did a next generation sequencing based panel. Basically, as they validate a gene, it gets added because I believe they are using exome backbone. They also are the people who sort of popularized tumor mutational burden. Although I have to admit, I don't personally know their algorithm for that, so I can't comment on whether it's the robust ones or not. And they continue to introduce more and more assays. I mean, my only footnote with them is their commercials, so I don't know that they are driven by resource utilization questions. So in Canada, we're asking a slightly different set of questions when we implement our own tests. I have no idea whether or not in that setting, funding to send out to Foundation One is an option. In the US, I will say that centers that don't have their own such profiling pretty routinely are using Foundation, but it's billable.
One of the other questions has to do with adriamycin or doxorubicin.
Yes, I can answer that if that's okay. This is Aziz Salau here.
Replace it. Just repeat the question in case people can't see the question.
Yes, so the question is, are the adriamycin doses in the cardiotoxic range, the adriamycin doses that we use for treating cardiac sarcomas? The answer is they're supposed to be lower than the cardiotoxic range. So we would still limit the lifetime dose of adriamycin as we routinely would in any other patients. We typically use 75 milligrams per meter square of adriamycin per cycle and keep it below the allowed lifetime dose. In general, we use the same dose when we combine with ifosfamide. Quite frequently, when we treat cardiac sarcomas, we are aiming to get as good a response, so as much tumor shrinkage as possible, just because of usually the location of the primary tumor. And so the best evidence for shrinking sarcomas of any kind is a combination of adriamycin and ifosfamide. But we would use a standard range of about 75 milligrams per meter square to achieve this. Do we monitor the cardiac function while we do this? It's not done in all centers, but in our center, we routinely do MUGA scans, radionuclide scans to monitor the ejection fraction as we treat. The last part of the question, I'm not quite sure I understand. If you don't mind repeating it. It says, given the low PFS.
I think what he's trying to ask is that the mortality rate of the natural course of the disease is very, very high.
Yeah.
And do you really need to?
So who cares if you develop dilated cardiomyopathy 10 years later?
5 years to kill you. That's a big question.
It is a good question. But sometimes our patients develop cardiomyopathy during the treatment quite quickly after they start adriamycin. So we feel like it's important to monitor, at the very least, have a baseline and at least one more check of the ejection fraction.
And so that's if a person doesn't have a fall off in ventricular function, is adriamycin, the combination of adriamycin and phosphomide, so good that you would like to keep it if it wasn't for cardiotoxicity? Should I be, at the time of a cardiac resection, I can give the heart whatever cocktail of medications you want to give me, and I can collect it all at the coronary sinus, so zero enters the body. I can take the heart out, as Dr. Reardon says, do an auto transplant, pour some medication, whatever toxic medication you want to give me, and soak that heart with the highest concentration you can ever believe. If it didn't matter, is adriamycin really that good?
I'm not sure. I suspect that would probably be toxic to the heart. There have been studies to look at the exposure of the heart to adriamycin. So I think this was touched on in the talks last year, whether to give it as an infusion over time or to give it as a bolus.
Right.
In terms of the exposure of the heart, and it doesn't seem to make any difference. The bolus treatment seems to have the same efficacy as prolonged infusion. But try as hard as we can. It's been about 50 years since adriamycin was established in sarcomas, and unfortunately, we're still yet to top adriamycin in terms of efficacy for sarcoma treatment.
When a person has a early drop off in ventricular function, A, how long does it take? And B, do you drop the adriamycin at that point, or do you go to a fuller dose, or do you change to a continuous infusion?
Generally speaking, if they have a drop off in ventricular function, we would
early loss.
Yeah. For early loss of ventricular function, we would generally stop adriamycin and give an alternative.
And if that's going to occur, how fast does it occur?
It's not very common, and in terms of when it occurs, it tends to be variable. Some patients will have it early by the second or third cycle. We can already see evidence of it. I've seen patients who had one single treatment and their ejection fraction dropped to 20-something%, whilst others, usually it's after they've finished all 6 cycles of treatment that they then start to have heart problems. So it's very variable.
So when do you look at ventricular function then?
So we look at it at we look at it at baseline.
Yes.
We try and aim for at least ejection fraction of 50%. We're happier with 55 in general. And we usually do another Mugger scan after 3 cycles of treatment to make sure that the ventricular function is holding.
And if the patient has normal ventricular function at the end of their 6 courses of chemotherapy, and they have something like a cardiac sarcoma, which, as you've shown, has a horrible outcome, especially if somebody I'm not going to operate on because they have a disease elsewhere, and they have normal ventricular function, would you continue IA into phosphomide and
Yeah, that's a good question. There's a lifetime limit to the dose of adriamycin that we can give.
Why is that?
So historical studies have shown that above a certain cumulative lifetime dose, the risk of cardiomyopathy is higher. Right. And so generally, we're not even allowed to exceed those. To exceed
you realize I'm pushing you hard on a topic I know a little bit about.
Yes.
I mean, it's one thing to have a peripheral tumor that responds to adriamycin, like an osteosarcoma or something like that, where a person you would hope that they would they would survive for many years. But when you have a primary cardiac sarcoma, which has such a dismal prognosis, do you ever go beyond that lifetime dose?
Well, we have liposomal doxorubicin in the form of Calyx, which is what we tend to go for. So when they've had 6 doses of doxorubicin, our practice in this center at least is to continue with Calyx if appropriate. So if they've responded to doxorubicin and we want to continue that treatment, we'll give Calyx.
Liposomal, is that what Calyx is?
Yes, it's a liposomal formulation of doxorubicin, which is supposed to have less cardiotoxicity.
Go ahead.
Sorry. Occasionally, we'd use cardioprotective agents like dextrosane, but that's not very common practice in our center. Some oncologists are more comfortable with using it. Some oncologists are not. Some centers use the cardioprotective agents routinely for all their patients on doxorubicin.
And can you talk a little bit about, you spoke a little bit about efficacy of continuous versus bolus adriamycin. Can you talk to us about continuous versus bolus adriamycin? What I'm getting at here in this all of this discussion is that it seems as though nothing works as well as the bisphosphonamide adriamycin combination. I'm going to ask you about the immunotherapy. That's very interesting. But what tricks do you have that will prolong the dosage or reduce the effects of adriamycin for the patient?
Right. In terms of prolonging the dosage, I think there was a trial, I don't have all the details to hand, that compared giving doxorubicin as an infusion over 3 days to giving the bolus over a few minutes as we routinely do, to see if this improved the efficacy of doxorubicin. But they were both regimens were equivalent, and given that it's so easy to give the bolus infusion over a few minutes, the bolus treatment, that's what most centers do instead of giving an infusion over several days.
Right, that's efficacy of the treatment. What about cardiotoxicity?
Cardiotoxicity, that study didn't show any significant difference in the cardiotoxicity. Cardiotoxicity wise, dextrosane is what's most commonly our go-to agent for protecting the heart.
And do you remember if that was in all sarcomas or cardiac sarcomas, and if so, what the number of patients were in each group?
I'm really sorry, I don't have that to hand right now.
It's okay.
Yeah.
Adriamycin is such a backbone in sarcoma that when we lose the ability to use adriamycin, the tools that we have to treat are really very limited, aren't they?
Yes, that's it. Gemcitabine with docetaxel has reasonable efficacy. It's not as good as adriamycin ifosfamide, but it does have reasonable efficacy, and we sometimes see very, very good responses to that combination of treatments as well.
And when you've completed your adriamycin, it sounds like you go there first. When you treat that, do you go to the gemcitabine next?
Yeah, so it's either, so if there's been progression with adriamycin, we tend to go to gemcitabine with docetaxel. In patients who...
What about if you've had response? You've had response, now you're going, oh my goodness, my lifetime dose of adriamycin is here. What do you do next for the patient?
We could give Calyx as a continuous treatment.
And is there a lifetime dose of this Calyx stuff?
Generally speaking, no. We can give Calyx. So, for instance, the patient I presented, he's still on Calyx and has been on Calyx for almost a year.
Why not use Calyx right from the beginning? What's the difference between Calyx and adriamycin in terms of efficacy?
I think it's cost.
Cost is the only thing.
Calyx is a lot more expensive.
Okay. All right. I'm sorry to push you so hard. What do you think about immunotherapy and these immune systems where you get the body to fight the cancer?
Immunotherapy is very interesting. When it works, it sometimes works brilliantly. And we're seeing a lot of headway being made, particularly with the synovial sarcomas and the cellular therapies. But those treatments are very complex. It's going to take a lot of resources to get those kinds of treatments mainstream, if I'm honest. And not every patient is going to be able to handle those treatments, especially if they've been heavily pretreated with limited bone marrow reserve. With regards to immune checkpoint inhibitors, there's certain subtypes like the ASPS, alveolar soft part sarcoma, which we're quite confident are likely to have a response to immune checkpoint inhibitors like the anti-PD-1 or PD-L1 agents. And we know that being such a heterogeneous disease, there might be other subtypes where a small proportion of them would respond, but as things stand right now, there's no good predictive biomarkers for identifying which types of sarcomas other than the ASPS would respond to immune checkpoint inhibitors. But there's definitely a lot of work going on there, particularly combining them with targeted agents to see whether we can turn what's regarded as a generally cold, immune cold tumor like sarcomas into a more immune active treatment.
I could go on and talk to you for the rest of the night. The advantage of having an in-person meeting is I could take you out for dinner and we could talk for the next 3 hours about this. We have to go on to the next one. Is there a brief answer to what Dr. Seidman asked? The cardioprotective data is from breast cancer. Is that true? Is that where most of the cardioprotective data comes from?
Yes, most of the cardioprotective data comes from breast cancer, the use of doxorubicin in that setting. That is a
completely different prognostic. I'm a heart transplant surgeon. I know full well the problems of adriamycin and long-term cardio damaging effects. So, but these are a different group of patients. Anyway, thank you very, very much. Very interesting talk. You have the most difficult job of all of us because of the limited amount of medications you have and the danger for the patients. We're going to move on now to Dr. Ahmed Makhdoom. He's one of our cardiac surgical residents who's with us this year. And he's going to talk about 2 cases that we're going to present. And we'll see how we come along with these. This is for general, anybody can ask questions. Anybody can come up with a response, but we'll see what happens. Go ahead, Ahmed.
All right. Do you guys hear me?
Yes.
Yeah.
And we see your screen.
Yeah. All right. I'm sharing. Are you guys seeing my screen as well?
Yes.
All right. Okay. Fantastic. Thank you, everyone, and thanks to Dr. Cusimano and the panel for letting me have the privilege to present at the conference. My name is Ahmed Makhdoom. I'm a cardiac surgery resident at the University of Toronto. I'll be presenting a couple of cases, and we'll have a discussion throughout these. As first, I have no disclosures with case 1. Case 1, I have a 47 years old healthy forest manager. I'm actually from Saudi Arabia. I still don't know what that is. However, he's a forest manager worker who presented to the office as an outpatient with hematuria. He had a workup for hematuria, and as including as a workup for hematuria, he had a CT scan that showed a right renal mass with extension into the right atrium. He has no previous illnesses or operation, and he was asymptomatic at the time. And here is a picture of his CT scan. We see the right renal mass, and we can see also like some invasion around the IVC and also around the RA. Then on the CT chest, we can tell that there's some. We still don't know whether it's a mass or a thrombus around the PA. In particular, the right PA and the right atrium. We don't have like a full CT scan for him, so. You see this images on the CT scan, and you don't know. We still don't know what that is, and what comes to my mind or the audience or the panel. How often do you guys see this, and what kind of further imaging would help you to determine what that is? And I would leave it to the panel to discuss that along with Dr. Cusimano, and I have other questions to ask as we go through the discussion. Dr. Cusimano.
Can you show the CT scan again?
Yeah.
So it starts out as a pretty simple case. And then you give us this mass in the right pulmonary artery, not that one. Go to the next one.
Yeah.
Because the renal cell carcinoma, we had a great discussion about that, great talk about that. But here's this tumor thrombus with the potential embolus. So why don't we ask, what can we do to diagnose this? We can ask Patrick Rogala if there's anything that he can do with that. Do you biopsy through vessels? The other question I'm going to have for our genital urinary surgeons is, how would your treatment be different for this compared to regular renal cell carcinoma? And then I'm going to ask Dr. DePerot, how he would deal with this if he were asked to come to the operating room. I don't know if you're online or not.
I'm here, yeah.
Okay, good. Okay, Mark. So you see, this man has a renal cell carcinoma, and they got a CT scan, and he has this little plug there at his right pulmonary artery. So they talk about a tumor thrombus.
Mm-hmm.
And the question is it tumor thrombus or is this a bland thrombus? How can we get a diagnosis of it? What can we do differently in terms of imaging? And from Kristen, does it really matter? So I don't think Patrick is able to come online, so we can't ask him any questions. But Kristen, you want to ask the question? You want to answer some of those questions to see whether you want Mark DePerot to do something for us, and if there's any way that we can biopsy that and find out what it is first?
Sure. So just to answer the first question, these patients are not common in our practice. They are something that we see a couple times a year, maybe a handful of times. And as Dr. Hamilton mentioned in the talk, these patients are complex. They need to be seen in tertiary and quaternary care settings for this very reason, because they're challenging and we need all hands on deck. So with regards to what we would do when we first saw this patient would be fully staged. So they would get a CT chest, abdomen, pelvis, bone scan, blood work. With regards to this thrombus in the pulmonary artery, we would get probably multidisciplinary opinions with regards to the best imaging of this. If it was, in fact, extension of tumor thrombus, the best imaging is a T1 MRI. But the question is really whether this is tumor thrombus or bland thrombus. And we mentioned that that's challenging to differentiate the best of times. So we would probably talk to our colleagues in thoracic surgery and or thoracics radiology to see what the best imaging would be for this. However, they do need to be fully staged because we want to make sure there's no metastatic disease as well.
Do you guys use PET scanners in renal cell carcinoma?
Not typically. No, PET scan is not usually used for RCC.
Renal cell carcinoma is PET avid?
We don't, I'm not sure, but we don't use it. We use it a little bit in bladder cancer, but not in RCC.
It's too bad that Patrick is not being able to be online here. And if this were considered, we don't know just yet what this is, but if this were not a bland thrombus, would this be considered a metastatic disease, or is this still a T4 lesion that's considered an extension with just a little piece that broke off? Is it equivalent to somebody who we're operating together on a case and all of a sudden you call me because there's been a piece that broke off and went into the lung, but it just happened a week ago? Or is this considered a different stage for this patient? Is a different prognosis?
Yeah, it's an excellent question. And I think we would certainly be fully investigating whether this was extension of the tumor directly into the pulmonary artery. And if it wasn't, if it was a piece that had broken off and had landed in the pulmonary artery, again, it would be essential to make sure there's not diffuse pulmonary mets, because that can sometimes happen where essentially the lungs get showered with mets from one of these tumors. And that would be very different than if this was a solitary piece of thrombus that had broken off and we thought that the patient was otherwise a suitable candidate for surgery. It probably would be something that we would get many, many opinions from the different team members. But if this was a young, healthy person who was surgically resectable and cardiac surgery felt that it was something that we could go after, we probably would entertain that thought for sure.
And would this be somebody you might consider a SUDENT or a systemic therapy to see if it starts to shrink?
It depends. I think it depends a little bit on if this is, I guess we'll see how this unfolds, but whether this is extension of thrombus or if it's a piece that has broken off, because if it's a piece that's broken off and then you put them on therapy and then that kind of dislodges and you have an unstable thrombus, it is not routine for us to put these people on systemic therapy to see how the thrombus and the tumor thrombus reacts. And I would be worried about the hemodynamic stability of this patient, just given where that is in a main vessel. Again, not our area of expertise, so we would be talking to all of the team members to see, how to get this person through a surgery successfully.
If everybody shrugs their shoulders and say, we need pathology of that little hunk of stuff, would this be somebody you would delay surgery and repeat the imaging? Obviously, it depends on the patient's clinical status, but repeat imaging to see whether other little bits and pieces spring up elsewhere?
If people said that they needed pathology, so you could easily...
we don't know whether this is we don't know whether this is bland or cancer.
Yeah.
There's this terrible word is called tumor thrombus, and people think that tumor thrombus is bland thrombus.
Mm-hmm.
But this is cancer. And we don't know whether this is cancer or a piece of thrombus, plain old bland thrombus is broken off. And we don't know the result because this patient's come for surgery. Mm-hmm. And we have to make a decision in what kind of things can we use. It's unfortunate we don't have radiology here. If anybody listening is a radiologist, please identify yourself and we'll unmute you. So what would you do?
So they would also certainly see thrombosis and start on full dose anticoagulation. And bland thrombus would hopefully over time resolve, but again, it's not necessarily a patient that you have a lot of time with. And again, we would probably talk to thoracics radiology, like you mentioned, to see if they could help us a little bit more in terms of differentiating what was going on here. Thrombosis would be involved, and then surgical, cardiac and or thoracic surgery, we would get as many opinions as possible, because for us, it would still be a technically feasible operation. But again, if this patient's going to become hemodynamically unstable, and we can't get that piece of whatever it is, it would change our actions.
And if you knew that was, if I could give you a magical ball and tell you that was cancer, would it change your procedure?
Well, it would certainly, I think honestly, we would be talking to you about whether we could get that out. Because for us, if there was thrombus that was extending through the kidney and the IVC and into the right atrium, and everyone felt that that was possible to remove, we would ask your expertise about, is this something that we can get out, especially if there's no other metastatic lesions, if the lung hasn't been showered with metastatic disease. Kidney cancer, one of the big things is they need a full resection. And so if this was something that we felt that we could go after through cardiac surgery, then it would change our management in that it would probably be a more, I'm guessing, extensive cardiac operation rather than what we would normally do for one of these procedures.
So if a person had low volume, I know the gynecologists talk about 1 cubic centimeter volume when they talk about ovarian cancer left in the belly. Do you have that sort of thing for renal cell carcinoma?
In terms of if they have metastatic disease?
Yeah, in other words, you always go after the primary tumor if they have a few mets here and there in the lungs? I know afterwards you said those people will get chemotherapy, but in terms of your primary...
So it's a highly debated topic right now about a cytoreductive nephrectomy in the setting of metastatic disease. And typically the trend right now is to not remove the kidney if a patient is a candidate for systemic therapy for metastatic disease. People with tumor thrombus, it's a bit of a different beast just because of the risk of them having emboli and them showering off metastatic disease into their lungs. But another thought process is if the bulk of the tumor is within the kidney and they have a few lung lesions here and there, then they may respond better to systemic therapy if you can take out the majority of the cancer, especially in the setting of IVC thrombus that would extend into the heart. I think one of the main thought processes remove the bulk of the tumor, and then after they recover, allow the systemic therapy to kind of do the work on the small lesions in the lungs or elsewhere.
You still like to see this thing taken out at the time of an operation.
Yeah.
I see Patrick Regala is back online. Patrick, this is a patient who has a renal cell carcinoma that extended an IVC tumor thrombus, as they say, and they find this little thing there. And is there any way that you can help us to determine whether this is bland versus cancer? A hard question. Oh, you're still muted.
Yeah, that's a hard question. I'll tell you why that's so difficult. One would believe if it's cancer, you might see some enhancement if intravenous contrast is given. I have to tell you, I doubt that's going to be the case for following reasons. Unless the cancer has gotten access to the local blood supply, then yes. But if it's a fragment from another site, it just is an embolus. Why would it take up contrast? It's just tissue. Right now, there will be some uptake, but so will that be seen in the thrombus, because the thrombus is also kind of a jelly material that also after a while will take the contrast because it diffuses in. So the ability to actually make that call depends on whether this is tissue that has received access to blood supply locally and then has grown into the wall, or if it's just a simple embolus. We have looked at MRI, if that's able to characterize. I would say if the thrombus is large enough, yes. Motion and the other factors I just told you can be prohibitive. I probably would give a shot for MRI. CT can be challenging in those circumstances.
And does renal cell take up FGD for PET? Do you know?
Yes, it does. It does. The only problem is here that, if it's a fragment of a cancer, the metabolism changes, right? Again, it's cut off from its original blood supply. PET is actually also a good consideration, but it really depends on where the timing is. Is it just, embolized within whatever, a few hours, maybe a day? We might see still activity. If that's more a chronic situation, possibly not.
Mark, what are your comments about this patient?
Yeah, so I agree.
You're drooling because it's a pulmonary endarterectomy case, but
no,
that may be why it was thrown in there.
Yeah, that's right. Yeah, these are the challenging situation, but I think a big part that helps is just to to give a bit of time, and I think to do things in stage procedure is certainly a possibility. I mean, if it's thrombus, it should progressively resolve on the not be a problem as you monitor them over time. If it is truly tumor, then it may start to expand. On close follow-up, for a few weeks may help you, make the right decision as well. So, on that, maybe giving the benefit of the doubt to the patient on treat his primary tumor as you monitor the lung lesion is certainly an option that should be considered.
Yeah, this is a patient. I should have shown as another slide. This is a patient who went into the right atrium, so the patient is going to be on cardiopulmonary bypass.
Yeah, so if you have to put patients on bypass, then obviously you will take it out at the same time. I mean, it would be fairly straightforward to do, and that would be the thing to do. So I think the first step is really to complete the investigations on, depending of the extent of the IVC tumor, particularly if it extends into the RA or the RV or even all the way to the PA, then it should be taken out at the same time. If it's just a single embolus, from the tumor with nothing in the heart, then you can potentially do it in a stage procedure, as long as the patient, doesn't have any hemodynamic compromise, from that lesion. But technically, it's you can remove that. There's very limited problem and risk with it outside of having to go on bypass.
For those people that aren't, this is pure vena cava right over here, so it's actually technically a very simple spot to get. Would you just attack it locally here, Mark?
Sorry,
I said here's the SV. I'm showing the people who may not know as much as we do. This is a superior vena cava over here. Would you, if you were to be called for this, would you cut the pulmonary artery right here?
Oh, you probably don't have the same side.
We don't see.
I'm sorry, you're right. It's the overlying the superior vena cava and pulmonary artery.
Oh yeah, you're correct. Good.
Where would you make your incision for that? How would you explore something like that?
Oh, Yeah, so you would open. I mean, you can open the main PA to, if you're just gonna suck the the thrombus. If the thrombus is mobile, you can do it from the main PA on even aspirate the material. If you need to see inside the pulmonary artery, on most likely that's what would need to be done. It would be to dissect between the aorta and the SVC, and then you do a longitudinal incision along along the right PA between the level of the aorta to the level of the SVC or right upper pulmonary vein, and that will give you an opening to see most of the right PA on descending branch of the right PA. So you will be able to dissect the clot off the wall of the artery if necessary, and then you can see in the different lobar and segmental branches, make sure there's nothing else.
Okay, I don't know whether I should tell you the answer and move on to the next question. It's like one of those TV shows you watch, or one of the ones that we're all binge watching during COVID. You have to watch the next episode. This patient, that's exactly what we did. Cut into it, and it was actually a subintimal metastasis to the pulmonary artery. Mike, does that happen very often?
You asking me?
Yeah.
I have not seen that previously.
And
Mark, of course, you have an amazing ability to attract stuff that no one's seen before.
Yeah, and that's what they would keep them off of these meetings. Mark, when you were to do something like that, would you expect it to recur locally if all we did was do a subintimal endarterectomy?
Yeah, like I mean, if the tumor is really on the edge of or within the wall of the artery, probably it will occur there, I suspect, or or somewhere along the pulmonary artery. I mean, if it metastasizes to the intimal component of the artery in one place, it's probably in some other area. So it may occur, in other area, I suspect.
And do you think there's enough, Patrick? Do you think there's enough blood supply if a person has a subintimal metastasis to show up on these other imaging like PET, or does that need a real blood supply?
No, I think as soon as the PET is dependent on metabolism, as soon as any sort of location in the body, neoplasm has access to blood supply, which in this particular case is the case, it will light up on PET, and the size is definitely above the threshold. So my prediction would be PET would have detected it. I was referring to of an embolus that just goes in, is disconnected from any blood supply. That could be a challenge.
Yeah. This was a challenging case, and we were expecting to find a bland embolus or a tumor embolus that had just sort of stopped there, but we actually found a subintimal metastasis. The patient had another recurrence in the other lung about a year later and died about 8 or 10 years later of distant disease. So exactly as you suggested.
RJ, was there any thrombi as well, or was it just
No.
tumor, like the whole specimen was tumor?
It was all cancer. No
cancer.
No thrombus at all.
Strange spot, yeah.
And the lesion in the, I could have shown the pathology gross specimen, but the one in the superior vena cava wasn't one of these gigantic ones. It was one that went into the heart, but it wasn't one that pushed the IVC out. There's different kinds of renal cell carcinomas, the kind that really expand the IVC and the kinds that don't really expand it very much. I don't understand the biology of those. Anyway, that was a great discussion. We have one more case. Ahmed, you want to go on? And Ahmed, one day you're from Saudi Arabia, you don't know what a forest manager is. We'll talk about that.
No problem.
I caught that. That's good.
Yeah, so we move to case number 2. Case number 2 is a 39 years old banker, and for sure I know what banker is now, with the upper quadrant pain after eating fatty foods. The the patient had an ultrasound that showed a normal gallbladder, but showed an IVC tumor. As a consequence of that, the patient had an imaging that showed a CT scan that showed a lifted nexal mass extending into the RA and the RV. Looking at the patient history, the patient had a previous fibroid operation at the age of 31, but the patient was otherwise healthy. All right. So, and here's a CT scan that showed
the RA with a mass slash thrombi that is going to the RV as well, including the RV and RA. And when you do on a further examination of the CT chest, it shows also like a right lower lobe nodule, as we can see that would assume more than 2 to 3 millimeter per centimeter in length. What would your working diagnosis be? What investigation that you would do to reach that diagnosis, and how would you deal with the pulmonary nodule? And I would open that to discussion again with Dr. Cusimano.
Could you go back to the slide to show us? So we have a patient here who has a tumor going through the heart, needs heart surgery, and one more right there. So we have this.
Yeah.
Well, go back to the next one, because that identifies it's from an adnexal mass, and the patient has this. Are one of our gynecological people here, gynecological oncologists here? While they're firing up their microphone, hopefully they are here. Mark and Patrick, this is lung cancer. Is it? 2 diagnoses? How often do we get 2 diagnoses, Mike?
Not lung cancer, no.
No. Tell us why you don't think it's lung cancer. Educate us. That's what this meeting's all about.
Too round, too smooth. No speculation, no reaction of the tissue. That's something else. When I see it, first shot would be, it could be smooth muscle. Maybe it's an leiomyoma. Maybe it is something pre-existing. It could be granuloma. Maybe it's an hamartoma that is in the lung forever. I don't know, even if it's new.
Would you consider this more benign? What sort of radiological investigations would you suggest for this, if any?
My first question would be, do you have priors?
That's great.
I probably don't. I would probably describe it as a nodule that requires further investigation. It could be from smooth muscle, maybe a metastasis. They can look like this, but it could also be a hamartoma. I only have one window here and I have nothing else, so it's a bit of a difficult thing, but I would definitely exclude infection in terms of an ongoing process. I would exclude lung cancer.
And Mark?
Yeah, I agree exactly with Patrick. Like, just make sure there is nothing else in the rest of the lungs. Like if it was a met, you may expect more than just one lesion. But otherwise, it looks pretty indolent based on the characteristic. Yeah, and it looks like it's at the end of a bronchus. So maybe you can get a tissue, either from a bronchoscopy or certainly from an FNA. I think. Yeah.
And what about the history we've received? A person who has an adnexal mass with a tumor going through the heart. Is that enough to say that this is metastasis from that?
From the gynae point of view, hi, Dr. Cusimano, I'm here. So it sounds a little bit familiar to some of the cases we presented with a pelvic mass, a pulmonary mass, and a cardiac mass. From my point of view, what I'd want to know, so it's not, she's 39, so I assume she still has her uterus and she had a previous fibroid. Sounds like she could have had a myomectomy. I would get pathology review from that. And then if she still has her uterus, I would investigate if she has any bleeding symptoms. She does have pain. I could start with an ultrasound and then further imaging of the abdomen as well. And
so you might have missed it. She does have an adnexal mass with a tumor going through the heart.
Mm-hmm.
Up the IVC.
Mm-hmm. And nothing in the uterus?
Adnexal mass. That's all he said. And Patrick, this is a fairly simple biopsy for you. And Michael, can you teach us about leiomyoma in the lung? Or Sabrina?
Sure.
Go ahead.
From a path perspective, primary leiomyoma of the lung is incredibly unusual. When you see it, it actually tends to be vascular leiomyoma, distinct from IVL, and would be more proximal. This case, we're obviously talking about, we are implying that there might be an intravascular lesion. Adnexal leiomyoma causing IVL would not be my first picture of that, but as I said, you attract some really crazy stuff. in terms of biopsying it, I actually thought Mark's point was great, and that an EBUS might actually be able to get in there. It's probably right at the edge, but it also looks like it might be amenable to needle. I don't know. Patrick probably prefers needles because he gets to do them.
No, I would definitely say bronchoscopy first if that's possible. I only see this one level of, so it's hard to say if it's reachable. Let's assume it would be in proximity. Definitely bronchoscopy, guided biopsy, first shot. If that's not doable, I would do a percutaneous with the expectation it's probably something. It's not lung cancer.
And if we were to prove to you that this was a leiomyoma, is that what it's called, the leiomyoma? Metastatic leiomyoma? Can you talk to us about that a little bit more? How would that affect your treatment of this lady? Is she an incomplete resection and therefore has a reduced lifespan, Sabrina?
So as we discussed earlier, I think that we would have to have a discussion, a multidisciplinary discussion as to kind of like we did with the recurrence of our second case. Do we only remove the pelvic mass and leave the pulmonary mass if that's not resectable? Or do we do a one-stage multidisciplinary procedure? And as you said, do we consider if the pulmonary masses, either they're related or unrelated? And do we consider giving her adjuvant hormonal treatment afterward?
We find that this leiomyoma, she has leiomyomatosis, benign metastatic leiomyomatosis. Mark, would you resect that?
Probably, yeah. I mean, if it's just a single lesion, I probably would resect it. You know, these are, to my knowledge, good prognosis, you know, tumor, so I would, you know, stay proactive. You know, I don't think it should be done at the same time. I think if you have to, you know, resect the intracardiac component, I would monitor her first for even a few months and then, you know, intervene when she's recovered from her primary surgery. So I wouldn't necessarily be, you know, extremely proactive, but I think if it stays as a single isolated lesion, I would, you know, resect it probably. Yeah. You know.
How about if she had two? I'm trying to push you now in terms of metastatectomy. What's the too many metastases to remove in a metastatectomy?
Yeah, it depends who you know, what you read and who you talk to. Like, you know, some people in the literature, at least, you know, one is, you know, probably the cutoff. But the, you know, I think in general, the parameters that have shown to have an impact, I mean, there are really three parameters. One is the number of lesions, and up to 3, the prognosis remains, you know, quite good or very good in some of the disease. So, you know, 3 is a good cutoff. The other parameters is, you know, having the ability to do a complete resection. So it's really to be able to remove all the lesions, particularly if there's more than 3, you really have to be sure that you can remove them all. And then the third parameter is the time interval between the, you know, the initial primary treatment or resection and then the interval with the development of the metastasis. So the longer that is, and particularly if it's more than 3 years or so, the better the prognosis. So these are really the 3 parameters that you look at. And then a group that's a little bit different but highlights the ability to give successful, you know, systemic therapy. The germ cell tumor are very different group. But these are patients who have extremely sensitive tumor to cisplatin. On the chemotherapy can be curative to some patients or in some patients. So we would, you know, potentially intervene for many lesions in these patients with, you know, if they have a good response to, you know, in terms of tumor markers. So that's a very different group than the rest of the patients with metastatic disease.
All right, Sabrina, last word to you.
So it's a good discussion. So I would just, as I said, I would really like to characterize this adnexal mass a little bit more. If it is a leiomyoma, if it looks like a leiomyoma on imaging versus like the rest of the discussion, if it could just be, as Dr. Seaman said, a red herring, which I'm less in favor of, and especially we would see that differently. I've got used to an ultrasound, which, you know, is simple cyst, I agree, in a 39-year-old would be common, but this doesn't sound like that kind of presentation. So I would go ahead and further characterize it, said nexal mass, and get biopsy from the most accessible site. We never biopsy at nexal masses. So if the lung metastasis is biopsyable, that's what my next approach would be.
Yeah.
Question to our gynecology colleague, Sabrina. Out of curiosity or interest, it's my understanding that those kind of like leiomyomas, they can be like, would you treat them with, or like with hormonal therapy? Would they be sensitive to that? It's just something that runs in my head.
You speak up, please.
Yeah.
Do you hear me now?
Yeah, so I heard the question is whether treating these leiomyomas with a hormonal therapy works. So it is a little bit controversial, mostly between the gynecologist and the gyne-oncologist in terms of fibrostal, which is something that I mentioned earlier. It's a progesterone receptor modulator that was considered in our case. And it really acts on the smooth muscle tissue, and it is a common treatment for fibroids. I'm not sure the efficacy of it in the leiomyomatosis that's intravenous and in the heart. I'm pretty sure that's never been studied before, but it's controversial, and Dr. Seidman can comment because sometimes, like we saw, something that's called a fibroid in a community center, for instance, that was maybe actually a sarcoma, and you're giving hormonal treatment to it, it's misviewed in the gyne-oncology world and the gyne pathology world. So you'd really have to have good evidence that in a tertiary center that it was a benign fibroid, and even leiomyomatosis is benign, as we said. So it could be considered. And there are a few case reports where it has been used, but the survival difference is not, there's no benefit, but it can be considered, just to confirm that it's not histologically malignant from the get-go.
Mark, one question for you is, would you do VATS for metastatectomy?
Yeah. So we increasingly do VATS, particularly in non-sarcoma patients. Like the sarcoma group is a little bit different, but for a lesion like this one, we could do that certainly. On metastatic carcinoma, from colorectal, increasingly we do that if it's accessible to that. The sarcoma tumor, like osteosarcoma particularly, can present with very small lesion that 2-3 millimeter that you don't see on the CT scan. So that's a group generally we would still palpate the lung and do resect every single palpable lesion, but we do increasingly use VATS for the other tumors.
Michael, you are the pathologist, so you do have the last say. What's a pecoma? Teach us what a pecoma is.
Yeah, so Sabrina really was speaking to this point, is that there's a lot of things that look like lyo, and particularly for an adnexal mass. Sabrina, you can probably speak to this better. Without seeing the uterine lesion seems a bit funny to me. Yes, it could be stuck in a vessel, blah, 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 but usually the primary has either already, primary is a horrible term there, has already gone away or has been taken out or is visible. Pecoma is the periendothelial cell tumors, which is a completely inaccurate name. This is the category of tumors that include angiomyolipoma and the various tumors associated with tuberous sclerosis. And the uterine ones, and presumably therefore also the ovarian ones, which are a little less well studied, given a rare tumor anyway, can look amazingly like a leiomyoma. And if you don't throw the one particular immunohistochemical stain on it, you'll miss it. And they have a much more aggressive pattern even in the reality is pecoma doesn't come in benign, it comes in indeterminate malignant potential and malignant. So even on the lower end, you're going to have something behaving more aggressively than a fibroid, even if it's the ideal variant.
All right, that's great. Well, that brings us to the end of the conference. I think I've had a lot of fun learning, and I have to thank everybody who participated, both as speakers, questioners, as well as audience, to make this yet another successful tumor conference. This shows how important it is to have discussion amongst people you sometimes don't even collaborate with, because together we can do a lot more than we can do alone. And it's a really important point that is brought home. hopefully over the next year, COVID will have a less grip on us all, and we'll be able to interact more. This video stuff is pretty good. It's nothing like getting together in person. But also, hopefully, it'll allow us to do more research and get things like the International Cardiac Tumor database a little bit higher and going a little bit more. And hopefully, we'll have a little bit more to report next year. So until next year, thank you very much. Thank you, everybody, for coming in and being part of the meeting. It really means a lot to me, and it's because of the continued interest that we continue doing this. It's a very important meeting, and thank you again to all the speakers.
Thank you.
Bye-bye. Thank you very much for staying to the end. Thank you.